Good morning, guys. It's me, Dr. Jenny Yusuf, doctor of physical therapist and creator of Balance and Fall Support Group in Aging Adults. I will be your host and moderator for this event. We will begin around right now, 8 o'clock, 8:05 for Dara Meldrum. She's the CEO and founder of Vertigenius. We will learn wonderful things and technology tonight if you are globally and this morning if you are in US. So it's my opportunity to learn more about you, and I really grateful for this year. This is our last summit for this year, the Innovator Summit. This is, I think, our fourth year to do this. All right. So I hope we can learn more and share this to your colleagues as well. All right. So let's see. And thank you. Yes, please put here where are you from. We have Missouri and we have even from Abu Dhabi. Hi, June. Nice to see you. And we have lots of from Vietnam, almost 20 of them registered. So tell us more about on the chat. What do you want to learn more? Okay? All right. So for this morning, we will learn more about that. Okay, let's see. Want to share more on the PowerPoint? It's all up to you. Let me see. So we have Dara Meldrum for our first. She will talk about vertiginous, followed by the neurostimulation and Copa Health. Copa Health will be more on osteoporosis with Ian Cutts and Edward Wilborn. They will be more on Spinomed. So the different braces for spinal braces as well. And then we will have Web FCE. Learn more about what are the different falls and balance assessment that you can use. After that, we have a break, lunch break. Then we will have Balance Connect. Balance Connect will be and also motor coordination, and they will going to tell us the different kinds of motor coordination balance training, then followed by DC Care Network and some of the different kinds of closing for us. If you have any questions, definitely always connect with us. All right. Okay, let me give the floor to Dara. All right. You will be the host, Dara. You have an option of sharing your, what do you call this, your video as well. All right. I'll give the floor to you soon. All right. Yes, we can see your video. I'm not video, the PowerPoint. But we cannot hear you yet.
Yeah, you can hear me now?
Okay.
Just hold on 1 second. I just need to share once more. I want to share my sound as well.
Yes, we can hear
Um,
you. All right. And I pin you.
no, it's not allowing me to share my sound. Okay, not to worry. All right, can you hear me? All
Yes, we
right.
can hear you well. Good
Okay,
morning.
great. Good morning, everybody. And it's really nice to be here. And thank you so much, Dr. Youssef, for inviting me to speak about vertiginous and about a topic in physical therapy that I think is becoming more mainstream and is a really valuable treatment for patients that have got dizziness, vertigo, and imbalance. And I'd just like to share with you a little bit about the work I've been doing trying to get this treatment out to as many patients as we can using technology. So, let me just introduce you to a few patients here this morning, all right, that you may come across in your practice. I know some of you are clinicians. So let's just meet Lisa. So Lisa got a year ago, she got a sudden onset of vertigo and dizziness and imbalance. She has a history of migraine and she sometimes gets these attacks without headaches, she gets dizziness, she feels imbalanced. And usually between attacks, she had been fine, but lately she started to feel like she's dizzy all the time. She's imbalanced and it's really affecting her life. She's not able to go to work. She's not able to tolerate crowds or moving stimuli. So she doesn't like things like stripes and patterned rugs. She doesn't go like going on escalators. And it's really starting to affect her daily life, and she's really not sure what to do. And then we have Mary, who's an 85-year-old lady. Her balance isn't great. As you can see, she's using a cane. And in about a week or two, she's going to have a fall and she's going to break her wrist. And when she gets into the A&E, they're going to patch her up and give her a cast for her wrist. And they may not, or may not look at her vestibular function to see whether or not it has contributed to her fall. But in 80% of people coming in with falls, a lot of times there is a vestibular or inner ear dysfunction in these patients that is not looked for. And then I don't need to tell you who this guy is, but this guy is just getting ready for a very big trip. And he's woken up this morning and he's really dizzy. He's spinning when he sits up, and when he lies back down in the bed, he spins for a short period of time. And he's not sure, he's got a lot of stuff to do. He's got to carry a lot of sacks around, move a lot of things around in the next few weeks, and he's really not sure he can get up and walk safely. So these are our three patients, and they are very typical of patients around the world today who have dizziness, vertigo, or imbalance. So if you look over there in the far left, about 1 in 5 patients at any, or people, sorry, adults at any given time will be complaining of dizziness. If you did a random sample of patients and asked them, have you had dizziness in the last year? 1 in 5 would say yes. And that rises to 1 in 3 when you're over 65. A common cause of dizziness is vestibular vertigo, and this is vertigo that arises as a result of disease or dysfunction in the inner ear. And that is quite a high lifetime prevalence, about 7.4%, and a 1 year prevalence of about 4.8%. So these are people who wake up really acutely dizzy, are very incapacitated by it, have to go to their doctor, have to get medication, have to miss work. And vertigo has a fairly high recurrence rate, around 40%. It accounts for a huge amount of presentations to GPs, particularly in the older adults, about 1 to 2 presentations. And 80% of these patients with vestibular vertigo will seek medical care. They feel so bad. They will end up in A&E, they will end up in ambulances, they will end up certainly in their primary care physician offices. And also in the wider population, balance issues are a big, even without dizziness, balance issues are a big problem. About 35.4%, 1 in 3 adults are unable to stand on foam with their eyes closed. And this was from again, a random sample of US adults done quite a long time ago. And if you stand on a foam mat with your eyes closed, we know as clinicians this, you really need to use your inner ear or vestibular system to achieve this. And if you aren't able to do that, you're not using it. If you're unable to do this and you're unable to, and you've got dizziness, you have a 12-fold increased risk of falling. So these are big problems that and well remediated by physical therapy actually. So we have a lot to offer here. The challenges in getting care to these patients are, first of all, it's considered to be quite a specialised area, dizziness and imbalance. There's a lack of trained physicians, and a survey we did in Europe noted that about 50% of therapists said that vestibular rehabilitation was hard to access or very hard to access in their country. Patients also find it hard to know where to go when they're dizziness and vertiginous because it's like saying I've got pain. It's a symptom and it needs quite a complex diagnostic pathway. So on average, patients will go to about 4 providers before they get a diagnosis. And that's an average. Sometimes it's up to 15 care providers before they actually get a diagnosis. Added to the complexity of this is that there's often more than one cause of dizziness. So in a sample of elderly people, 62% of patients who came in with dizziness had more than one cause for the dizziness. So what we're left with is a very complex and fragmented journey with patients taking many twists and turns, getting little bits of information here, there, and everywhere, but often not getting managed appropriately. So if you think Santa has a hard time navigating his way around the world and getting all the presents in, these patients are really often at the end of their tether by the time they get to a skilled clinician that's able to treat them. Yeah. So what are we talking about? Well, here's your inner ear. It's a fantastic, very intricately, very phylogenetically old organ that is responsible for keeping you balanced and keeping your gaze stable when your head is moving. So it's located in the petrous temple bone. It's not the outer ear, it's not the middle ear of hearing, it's the inner ear, really far in. You can't see it. We have to infer from what we see with the patient what's happening with it because we can't actually see it even if we look into the ear. It's very far in behind. It consists of three semicircular canals, which are just like a little gyroscope, and two sacs called the utricle and the saccule. And together, these five organs give the brain information about where you are in space and also allow you to keep your eyes stable on an object when your head is moving. So you can see a bird's eye view of the semicircular canals here. You can see that they are orientated at 90 degrees to each other, the anterior and the posterior semicircular canal. And also that the anterior canal is in the same plane of the posterior canal of the other side. So the fact that these are coplanar means that they can work together and give the brain very accurate information about where the head is in space. And why it needs to know that is that if you want to see something, you need to be able to move your eyes opposite your head to keep your eyes steady on a target. So your inner ear is busy doing this all the time in the background. And it has a tonic firing rate. So as you're all sitting here listening to me and not moving your heads, there's a tonic firing rate going into your brain saying the brain is not moving. And if you then move your head, one of those inner ears will start increasing its firing rate, one of it will start decreasing its firing rate on the other side, and your brain will know you've moved your head to the right or to the left, and your eyes will then move in the opposite direction so that you can see me clearly if you want to keep looking at me while you're moving your head from side to side. So the symmetry is really important. The symmetry of firing rate at rest is very important. So it's signaling no movement. If some disease happens to one inner ear there, say on the left-hand side, one ear gets knocked out by some virus or some injury, then you're going to get this asymmetry between the two systems. The brain interprets that as movement because that's how it interprets asymmetry, and the patient starts to feel really dizzy and they generate a nystagmus that we can see as clinicians and we can diagnose what's going on with that. So it's a really fascinating system to work with. The other role it has, of course, is in balance. All right. So you need to know where your head is in space in order for yourself to stay balanced. The inner will give you information about where your head is and will allow your central nervous system then to select the appropriate motor strategy to keep your balance and to keep your center of mass within your base of support. So it's always working away in the background and it's helping us move around, see clearly, keep balanced, walk, etc., and do our functional daily tasks. So this is a really lovely app for any of you that are interested in the space. It was developed by the University of Sydney. It's called the AVOR app, so the Angular Vestibular Ocular Reflex app. It's on the App Store. It's only on iOS, unfortunately. But it is a really nice app to use if you're starting to treat these patients. You can give the patient all sorts of problems and you can see what the eye movements will be with it. But just when I'm playing this video, I just want you to see how the two inner ears work together. So as the patients move their head to the right is getting activated and the left is getting inhibited and vice versa. And you can see that as the head moves in one direction, the eyes move in the other direction. So this is what the vestibular system does. It helps keep your eyes steady on a target when your head is moving, using information from both sides that is changing in the symmetry of firing rate. It's either decreasing or increasing from a resting firing rate. So asymmetry is always interpreted as movement by the brain, whether it's there pathologically or whether it's there normally. If your system is not working, this is what you will see if you're riding in a car. And I don't know whether when you're looking at that, how do you feel? I'll just play it once more. If your inner ear is not picking up head movement very well, it will not move your eyes very well, and the world will move as your head is moving. And that's called oscillopsia. So I don't know how you all felt when you looked at that video. It makes me feel a bit unwell, but it certainly makes patients feel unwell and dizzy when they have oscillopsia. So what causes vestibular dysfunction? Kind of about four broad areas. First thing is trauma. So any of you that are working with fallers that may come in with a broken wrist, but if they've hit their head, they may have trauma to their inner ear and trauma to their brain, of course, as well. So patients with traumatic brain injury, concussion, they can often have issues with their inner ear. as a result of this. Neurological conditions can affect the vestibular system directly in the central vestibular system in the brainstem, so in the vestibular nuclei. But there is a massive network of vestibular function all the way up to the cortex, allowing you to navigate. So if you have any sort of neurological problem, you can get vestibular function with that as part of the network of the system. And that's with as physical therapists, we're trying to work out what exactly is being affected and how can we help best rehabilitate that. You may have just disease out at the periphery. So in that lovely end organ I just showed you, you can have disease there. You can lose the hair cells, which are the sensors of the system. They can be killed off by things like aminoglycosides. They can be killed off by viruses. There are diseases like Meniere's disease. That is kind of a fluctuating inner ear problem where the fluid in the inner ear has a problem. And there are all sorts of other issues that can cause the inner ear problems and will give you vestibular dysfunction. And then really one of the biggest groups I think that we deal with is age-related vestibular dysfunction. We know that as we grow older, we lose sensory function in all our senses, right? So our vision goes down, our hearing goes down, your vestibular function also goes down. And I don't think we pay enough attention to this. We know our strength goes down, for instance, and we hear physical therapists talking about, getting people as strong as we can, keeping our bone function strong as well, keeping our vision optimized, but we really have to keep our inner ear and our vestibular system optimized as well. And that means balance exercises, all right? Learning how to do balance exercises, gaze stability exercises, and keeping this as optimal as possible. So there are age-related losses that can lead to vestibular dysfunction as well. So back to our three patients here. So Lisa here has actually got a condition called vestibular migraine. But because she hasn't had treatment very well, or maybe not because of it, but she has also developed a condition called 3PD, which is a chronic vestibular syndrome where she just feels chronically unsteady and dizzy and really will benefit from vestibular rehabilitation in this regard. Also, probably with medication management. Mary has multisensory loss because she is older and her vestibular function is just declining. So she's not using her vestibular system as well as she should. And Santa Claus has got BPPV, which is the commonest cause of vertigo in any age group, but mostly in the elderly. And it's really treatable with one treatment. It's a condition that's caused by loose otoconia, which are little calcium carbonate crystals that are in the inner ear, getting into the wrong place and causing positional vertigo when your head goes down. Again, it's really treatable. If Santa gets to the right person, he can be treated and streeted, as we say, in one go, and he will be back and able to do his rounds on Christmas Eve. So there is treatment available to these patients, and I'm going to go through a little bit about what that is at the moment. So who of patients who got dizziness, vertigo, and balance, who are the best? Oh, I'm really sorry. Did I stop sharing there? Did. Go back again. Hmm. Can you still see my screen? Oh, you can. Sorry, I made you,
Yes.
I actually I maximized you rather than I maximized you rather than my screen. Okay, so who
All
benefits
good.
from vestibular rehabilitation? Here are the groups that benefit from vestibular rehabilitation. Patients who've got those inner ear disorders, all right, that haven't got better. Oh, a lot of times they will get better on their own because the brain's very clever at compensating for problems in the inner ear. But if they don't, they really benefit from vestibular rehab. BPPV, as such as Santa has, they really benefit from vestibular rehab. If they have central vestibular problems, so like a head injury or concussion, they will benefit from it. Parkinson's, stroke, also as well, multiple sclerosis really benefit from this treatment. If they have multifactorial balance abnormalities, such as in the elderly, and also if they've had surgery to their inner ear for things like acoustic neuromas, vestibular schwannomas, or they've had a labyrinthectomy for whatever reason. So these sort of patients are the ones that really do very well when they come into us for treatment. What are the benefits of vestibular rehabilitation? Well, we know that we can reduce symptoms. So we can reduce vertigo and dizziness if we treat these patients. We can increase their gaze stability so that we can decrease that feeling of oscillopsia or that perception of oscillopsia that the world is moving. We can improve their function, their physical function. So we can improve their balance and improve their walking. We can decrease their fall risk, which is really important. Anxiety and depression are much more common in patients with dizziness and vertigo. So we can also improve that. If we get rid of their symptoms and get them more confident about moving, their anxiety tends to go down with that. And there is a lot of evidence to suggest that we improve quality of life when we treat these patients in any age group, but most particularly in the elderly. And just to say that there is now mandated in the World Guidelines for Falls Prevention that in an assessment, a multifactorial falls risk assessment, dizziness and vestibular function should be assessed to performing a Dix-Hallpike test and a head impulse test. And the vestibular community fought long and hard to get this into the falls guideline. And I think this is why the area is starting to receive more attention because we now know that these are really important things to assess when a faller comes into us. So is it effective when we get the treatment? Well, I at last count counted 46 systematic reviews in this area. So back at the 2009 was the first systematic review showing that if you get no treatment at all or you get vestibular rehabilitation, if you have a peripheral vestibular dysfunction, so your inner ear is disordered, then you will be much better off. All right, so that was clearly shown a long time ago. It was one of the first systematic reviews, I think, in physical therapy showing strong efficacy. And since then, we've had many more. So we've had studies in the area of vestibular neuritis, in the area in very acute early. We have now got guidelines from the APTA about how to treat unilateral vestibular hypofunction. We have a systematic review on Meniere's disease, but also in traumatic brain injury, in Parkinson's disease, and in multiple sclerosis. So lots of evidence there to go in and argue with our care providers that we need to be providing this treatment for patients. So the question that I've been working in this area for a long time, and the question that I had was, could we digitize this with all the problems that patients are having, the access problem, the lack of trained clinicians, the fact that they've got to do their exercises, as with all physical therapy, do their exercises at home without us being there. We don't want them coming to clinic all the time. So would there be a role for technology in solving these problems and in getting this treatment to patients when they need it and getting them better faster? So these were the reasons that I came up with when I started developing Vertigenius. I wanted to improve access for patients. I wanted to save time for therapists so they could treat more patients, so that they could do things like prescribing exercises much quicker, that they could see what was happening when the patient was exercising at home. So they could see, I'll talk a little bit about it in a few minutes, but how patients were moving their heads, which is the really key thing with these patients, but also were they doing their exercises and how were they feeling when they were doing their exercises. I wanted to be able to measure adherence, and we now are, as physical therapists, can get reimbursed for looking and monitoring patients remotely, but we need to be able to digitize it to see what they're doing at home because they're obviously going to be doing that. But really importantly for me, it was really around the dosage, right? So could we advance exercise prescription in the field? Can we give patients exercises that are really tailored to them, individualized? We know they work, and can we get some understanding from big data sets about how these exercises work with patients? So I want to take the guesswork out of fit, the frequency, intensity, type, and time. We have some really good guidelines about how to treat these patients, but a lot of them are based on, expert opinion. The randomized controlled trials are good, but we need a lot more data. So we're still really not quite sure how often patients should be doing exercises. So that was the reasons I thought for why we could digitize and why we started to build Vertigenius. And interestingly, a study came out just, I think it was last year or the year before, where they sat patients down and asked them, what are the problems you're having when you're doing your vestibular rehabilitation? And what patients were saying were they were saying things like, I don't really think the exercise works. It's a bit boring. I'm finding it hard to motivate myself to do it. The severity of symptoms, particularly in this group, we ask them to move their heads. It makes them feel unwell and dizzy. So then they start to get discomfort. They may feel unwell after doing the exercises for a period, and they may go, oh, I'm just not going to do these. I'm going to go back. I'm going to wait till I go back to the therapist. They find it hard. We ask these patients to do a kind of distributed practice model where they do their exercises at different times during the day. So they're having trouble managing all this. They had other associated impairments that they wanted taken into consideration. And they're kind of funny looking exercises. I'm going to show you some of them in a minute, but they are funny looking exercises to be doing. So they did perceive that they were a little bit awkward to be doing around, but also they described not really having guidance and feedback about what they're doing, whether they were doing it right at home. And this I hear from patients all the time as well. So we had a little chat with our patients in the waiting room and asked them as well, were they having any problems with doing their vestibular rehabilitation exercises? And you can see up there that the number one problem in over nearly 40% of them was that they made them feel unwell. All right. And that really demotivated them from doing it because the treatment is moving your head, but the treatment is making you feel is bringing on your symptoms as well. They found them hard to remember to do them. They couldn't meet that frequency we were giving them. They didn't know if they were doing them right, if they were doing them too fast or too slow. They didn't feel very motivated and they weren't sure how far they should be moving their head. So lots of stuff there. I thought, oh, this is all about kinematics. If we really knew what the head was doing, then we would learn an awful lot from that. I also was very interested in what the therapists were experiencing. So I wanted to know what problems therapists were having and how they felt this exercise program at home and feedback from them informed what they were doing when they were treating patients. So they came up with fantastic things. Right? So I interviewed therapists around the world and patients, one of them said to me, it's really important feedback. Patients get it wrong quite a lot. They come back with weird and wonderful ways of doing the exercises. I think we've all had that experience as clinicians. When they come back in, we've got to progress and change their exercises without having the full picture because we don't know what they were doing at home. And somebody else said to me, it's essential, it's a variable, and if it remains unknown, you don't know if your clinical reasoning is flawed and you gave them the wrong exercises, or it's right and they're not doing their exercises correctly. So if we had this feedback and we could measure what they were doing at home, we would know all this, right? If we were knew what they were doing at home, we would learn something from that. So these were all the gems that the therapist came back with and felt that technology was a way we could solve these problems. It was a way for connecting us with the patients at home. So we developed a wearable, which I'm going to come to in a few minutes. We developed a wearable head sensor to track the head. So why a wearable and why head kinematics? All right. So we're all about kinematics of everything, right? A lot of the time, the neck. But why do we need to know about the head movement, particularly in these patients? So we know that when patients have dizziness and vertigo and they have vestibular dysfunction, they perform fewer head turns because it makes them feel unwell. So if they're out and about, they won't move their head as much as you and I will. When they do, it'll probably be at a lower velocity. If we get them to do a cycle type movement, they will take longer to cycle through the movements back and forth. They won't decouple their head from their trunk, so they'll move sort of en bloc. If you ask them to do something like move their head when they're walking, they will change what they're doing at their feet so that they can then move their heads. So it will have a dual task interference on gait. So they'll walk a bit slower than they should be because they've got to move their head as well if you ask them to look left and right. They have a lack of control, really good quality motor control of their head. And this again is due to the abnormal signal coming in from the inner ear. And they've got a really increased variability of head movement. So where you and I would be able to do a very nice cadence, slow, quality movement, they have a more judder and jerky movement of their head that's really not necessarily visible to the naked eye, but can be picked up with head sensors. And there's a really lovely work coming out of Johns Hopkins University on this at the moment. And as I said before, moving their head makes them feel symptomatic, but head movement is the therapy. And more importantly, a patient isn't going to come into you and say, I'm making fewer head turns. I'm taking a longer cycle time. They're going to come in and say, I feel awful. And they're going to say, I just can't go to work. But if you have more normal head kinematics, it is associated with better outcomes that we're looking for with our patients. So there is very compelling evidence to measure what is going on in the head with these patients. And this is just a picture or just showing this patient is using Vertigenius. She's wearing the head sensor and she's doing one of our most common exercises there. It's called VOR times 1. This is VOR times 2, where she's instructed to look at a target while she's moving her head. And you might ask her to maybe do very, very fast movements out to one side, which she's doing here. These are newer forms of exercises, or you may get her doing a sinusoidal movement. But the important thing is she's moving her head while keeping her eyes on a target and we're tracking her symptoms and we're increasing the speed and trying to get her back to more normal head kinematics. So this is what Vertigenius is. It was really to be able to deliver a program, not just about head movement. It doesn't just track head movement as well. We also have balance, strengthening, cervical proprioception, lots of different types of exercises in there for any kind of use case where there is a balance disorder, a dizziness or vertiginous disorder. So the wearable head sensor is an IMU. It's got an accelerometer, a gyro, and a magnetometer in it. It tracks the direction of the head movement, obviously the speed of the head movement. And it's paired with an app so that when the patient is doing their exercises, they get real-time feedback as to whether they're performing their exercises against the prescription that we we gave them. So say I prescribe a patient, I see that they can move their heads about 80 beats per minute and they're not very symptomatic. And they can do it for about 30 seconds. I'm going to say, right, I want you to try and get up to a minute doing that. I'm going to prescribe you 80 beats per minute, and you're going to now wear the head sensor. When they're doing their exercises, they hear a beat of 80 beats per minute, and they see the X on the screen changing color, giving them feedback as to whether they've hit the right target. Are they at 80? Are they at 100? Are they at 100? Are they going too fast, too slow, or just right? The Goldilocks effect. And that is where the X will change color and they'll get a color coded feedback. So it's green if they're going right, it's red if they're going too fast, and it's yellow if they're going too slow. So that helps them when they're doing their head motion exercises. They also get balance exercises, they get reading. It tracks what they're doing, and so the sensor picks up the head movement, brings it back into the app, and sends it into the clinician portal. The clinician portal you can see up there on the top right, that's where you manage your patient from, and you can see all the data coming in from them. I'm going to show you a little demo of it in a few minutes. So you have a kind of a master clinic where you can onboard the patient, perform assessments, send them out subjective assessments. You can get information in ahead of time as to how they're doing with all the gold standard outcome measures that we use in the field. You can then prescribe any one of 250 exercises to a patient in lots of different categories, from balance to gaze stability to proprioception to walking exercises to step ups to strengthening. And then when you prescribe it out to the patient, it lands in their phone within a couple of seconds, and their exercises are there. They see a video, they get tracked doing it, they wear their head sensor, they get real-time feedback, and it comes back into the portal. So the loop is closed. So whenever a patient is doing something, you have the opportunity as a therapist to see exactly what they're doing. And if you're making them feel really awful, you can see it very quickly, and you can maybe reduce the duration of the exercise or the speed of the exercises to titrate it, to individualize it to them. And just to say, in this field, individualized treatment has consistently been shown to be superior than a generic handout of exercises that is just given to everybody. It is much better that the exercises are tailored to the individual. So that is vertiginous. It's a very simple interface for the patients to use. When they open up the app, there's just three things for them to do. It's start my program, start my reading, look at my progress. And they pop on the head sensor, it automatically connects, and it takes them through everything. So that is vertiginous in a nutshell. This is a picture of somebody using it. So she's wearing the head sensor, she's doing a gaze stability exercise, and you can see the X on the screen. So you can see the Bluetooth there's because the light blue means that it's turned on. And as she does her exercise, you can see that the X is green because she's at the right speed. It's now yellow because she's going too slow. Now it's back to green. And now it's red because she's going too fast. So it is very hard. She's actually a healthy control, all right? So it is actually very hard to move your head correctly to a beat. So patients obviously have way more issues with this and need a lot more training, all right? But this gives them real-time feedback. If she moves her head in the wrong direction as well, so if she's supposed to be going up and down instead of going left to right, then she'll be told she needs to change direction and move the other way. So that's just an operation. So it is all very well building a system, all right, but this is a medical device. We are registered with the FDA, and it obviously needs to undergo quite a lot of validation before it can be released for use with patients. And so we've been developing this over the last 8 or 9 years. And the first study that we did here in Ireland, and we brought patients in. Or actually, we didn't bring patients because this was during COVID, and we onboarded the patients to Vertigenius. They were all treated remotely, so the therapist actually was on a video call with them, assessing them and prescribing their exercises. So they went through about an 8 to 12 week program of vestibular rehabilitation using Vertigenius, and we measured this what's called the system usability scale. So we wanted to know, do patients find this usable, and also do therapists find it usable, right? How usable is it? And so the system usability scale is a scale of 0 to 100, and you can see here that not acceptable is anywhere sort of 50. They say just go back to the drawing board. You actually have to start again. 70 is okay, and then really 80 to 90 and above are you're on the right road. This is usable. It's highly usable. So what we found was that patients scored it at that point. We've changed it since, but this was quite early on as 82.7, and therapists as 85. So we published that back in 2022, and 82% of patients improved their symptoms. So you can see their numerical rating scales there on the right: dizziness and vertigo, imbalance, anxiety, nausea, and oscillopsia, how they improve. So symptoms did reduce by 50% with the use of the system. So we were very pleased with that. It wasn't a randomized controlled trial, but for the level of medical device that we're at, we needed to show usability and acceptability and safety. So that's what we had done within this study. So this is then the second study we did, and this is a patient that was in the second study. In this study, the patient went home with vertiginous, and it was a sample of MS patients who had vestibular problems. So they all had dizziness and imbalance, and we sent out their subjective questionnaires. So this is just one patient who said her top problem was, I worry about tripping over my apartment. I live by myself. Every time I shower in my overbath shower, I'm afraid of slipping again. I feel dizzy in busy places. And her goal was to feel less worried about falling. I think worrying about that makes me more unsteady. So balance confidence an issue for this patient. So before the patient even came into the clinic, we could see that this was what she wanted to be addressed when she came in. All right. On the left-hand side, you can see here that her dizziness handicap inventory score was 74. This is really high, so anything above 60 is considered to be high. Her dizziness at the start of treatment was 6 out of 10, nausea was 2, imbalance was 4, anxiety was 2, and oscillopsia was 4. Again, we could see this before she came in the door. She did this at home before she came in, and we could see, right, her top problem that needs to be sorted is dizziness, followed by oscillopsia. So there's definitely something going on with the vestibular signal here if she's feeling dizziness and vertiginous. When she was discharged 3 months later, her dizziness had gone down to 2. Now, you will note not to 0, and that's often the case with these patients. We get them back to a manageable level. It doesn't go away completely. Her nausea was gone, her balance was better, her anxiety was better, and her oscillopsia was much better as well. So she had used it there for 3 months. This is her physical function. So her dynamic visual acuity at the start was a 4-line loss. So she had significant, 2 would be abnormal. Post-treatment, she hadn't come back to normal. She had done a little bit better. She was a 3-line loss. She'd improved her gait speed, and she had also improved her gait quality. So the modified dynamic gait index, she'd gone from 4 out of 12 to 9 out of 12. That's a big jump, and it just brings her up out of fall risk territory. So really good, and she was really pleased with her progress. This is our digital measurement of her adherence. All right, so you can see that she got 6 programs. So the little dark teal bar is how many exercises she was given at each program. So that's just kind of little, it's usually around, as we know, golden number for exercises for our patients is about 4. So generally around 6 to 8 exercises for these patients. She the light blue is what she did, and the gray is what she should have done. All right. So you can, if you wanted to estimate a percentage of her adherence there, I would look at that and go, she did about 30% of her exercises, and yet she got this really good benefit. All right. So what that says to me is, are we overdosing our patients, or are we getting it right? And this is what I think digitization is going to solve for us. Did she just need to do that amount of exercises to get that effect? Or if she had done all her exercises, would she have shifted her dynamic visual acuity by that one more line? Would she have got a bit faster with her walking? We don't know. These are all the questions that we still need to answer. But that was her adherence. Here's her symptoms. So every day she opens up the app, you can see her symptoms over time. And you can see here that her dizziness and vertigo stepped its way down over time. Right? It was always going in the right direction. Her imbalance too stepped its way down. Never went back to 0 where she had no problem, but was going in the right direction. And again, when a patient comes in, you can look at this and go, yeah, they're going in the right direction. Or you might say, what's that blip over there? Early on, there's a really high day. And you might say to the patient, what happened on that day? And in our migraineurs, they might say, I had a really bad migraine that day. I couldn't do my exercises and my symptoms were just really bad. So you get lots of information from a snapshot graph like this with the patient. This is the information we get from the head sensor. All right, so this shows you, did she do her exercises? So the dark teal is that gray bar is whether she did her exercises over a given program. The horizontal bars are showing, did she meet the prescription of the speed that we gave her? So if we gave her 80 beats per minute, did she actually meet that, or was she going too fast, which is the light blue, or too slow? So you can see she was a bit hit or miss. 2 bars there, she was going as prescribed. But sometimes she was going a bit too fast and sometimes a bit too slow, indicating it is hard to do this correctly. All right, that they do need feedback when they're doing it. These are her symptoms before and after doing the exercise on her second program. Okay, so before she did, this was a gaze stabilization exercise. So she looked at the target, she had her head sensor on, she was moving her head from side to side. She started at a 4, she ended up at a 5. As the week went on, she didn't increase her symptoms as much, and she was moving her head at 85 beats per minute. At program 6, you can see her symptoms had really reduced and she was moving her head at 125 beats per minute, so much faster. So she was able to move her head faster for a less symptom burden, which is exactly the aim of what we want with vestibular rehabilitation. And we could see it all happening and improving and change her as time was going on. Okay, so that was the second study we did. We also took a look at usability in a little bit more detail with this because they went home with a kind of a kit, right? They went home with the head sensor, and we want to know how they felt about, if they went home and they didn't see a therapist as much, did it mean that they didn't feel as supported? And the high bars there on the right, this is called the SUTAC. It's a User Technology Acceptance Questionnaire. Where there are high scores, it meant they were pretty much in agreement with the positive aspects of the kit. And where the scores are a little bit lower, it meant that they didn't have concerns about care. They thought the people that were treating them were expert. They didn't, there was a bit of equivocalness about the kit as substitution. So you can see that kit as substitution, it's around a 3. It meant that some of them thought the kit could be used in terms instead of the physio, and some of them thought, actually, no, I really want the clinician, the physiotherapist to be there as well. They didn't have major concerns about privacy and discomfort. So, these are all things we need to think about when we're collecting digital data from patients. They're sharing their data with us, but they didn't have major concerns about that. So they were the two major findings that we found with this study. And in the MS patients aggregated, we did find significant improvements in their symptoms as well. So start building the evidence base for vertiginous is really important for us, and we're continuing to do that as we go along. So I'm just going to show you now, I'm coming towards the end of the talk, and I'm just going to show you a video of the system. I don't think I'm going to be able to hear the sound, but you'll be able to see it move. So this is just one of our videos that shows you, gives you kind of an overview of how it works. Let's see if we can play it. Okay. So you probably couldn't hear the music. You couldn't share the sound, so I had this music playing. So just to talk a little bit about the evidence for one of the things we need to think about, and I think we're all starting to dabble in this area since COVID, is tele-rehabilitation, right, and delivering rehabilitation at a distance. And in the area of vestibular rehabilitation, we do have some really good evidence for this actually. So this was a study, a 3-arm trial that was done in the Netherlands, where they randomized patients with chronic dizziness into 3 groups. One got usual care, so going to their doctors. One got web-based care, where it was a a vestibular rehabilitation program on the web that kind of automatically brought them through some exercises. And one group got the blended web and two home visits from a therapist. All right. And what they found was that the patients who got treatment did better than the usual care, so that which was good. All right. So they both did better, but there was actually no difference between the web-based alone and the web-based that had the physical therapist coming to their house twice as well. And so it seemed that once they were doing their exercises, that the effectiveness was I don't want to say we're being put out of a job. We're not. There's definitely benefit. There were some patients who were saying they couldn't do the exercises without the help of a physio. The physio was saying that it was better that they were there to teach them how to do it properly. But they were it was just kind of showing that it was much cheaper for to do a web-based treatment and obviously giving more access to these patients. So it is safe and effective to give in chronic dizziness anyway, to give web-based treatment only to these patients. And adherence does matter. So one of the things that this study showed was that those who did their exercises did much better overall in a kind of a per protocol analysis. We also have a systematic review now for telerehabilitation again, and it has 841 participants in it. Not huge again, but fairly big. And there were significant differences in favor of telerehabilitation on both dizziness, as you can see here in the circle on the forest plot, but also on disability and anxiety. So, it is one of these fields, I think, where we can deliver it's really exercise based. Patients have to do a lot of exercise. We don't have to put our hands on them as much as we would maybe with other types of patient groups. So, it is something that favors tele rehab a little bit more. And we do, of course, have APTA guidelines now for tele rehabilitation saying that we should recommend it. It's at least equivalent for patients with respect to acceptability and satisfaction and adherence and attendance. All right. So that they might feel it's easier to get to a virtual appointment. All right. They don't have to park. They don't have to find childcare. They don't have to find someone to mind their elderly spouse. So it's much easier for them to do it from the comfort of their own home. The outcomes, we still have weak evidence for it, but it is building. So it's just something I think we need to keep an eye on, and it'll probably come down to patient preference, their distance from clinic and things like that as to whether we're going to find this operationalizing long term in the field. So that is all I have to say. Thank you very much. If you'd like to see anything more about VersaGenes, please, you can book a demo there using the QR code, and I would love to answer any questions if anybody has any. Thank you very much.
Thank you so much, Dr. Dara. Yeah, that's really enlightening. It's great. I just want to just tell everyone, Dr. Dara is live from New Zealand. So majority were
No,
viewing.
Ireland.
I knew I'm thinking New Zealand, New Ireland. Oh wow.
It's
I
Ireland.
thought,
Yeah, we're in Europe. Yeah. I'd love
how
to be in
about
New Zealand.
Patrick? How about Patrick? Because I thought he.
Patrick, yeah, works in VersaGenes. He's our commercial officer and he's in Ireland as well, actually. We're all in Ireland.
Oh, okay, okay.
Yeah.
I thought in New
Yeah.
Zealand. I keep putting
Yeah.
there on the chat.
We do
Welcome,
have two
welcome.
now. We do have two people now in the US as well.
Yes, yes, yes. Congratulations. This is new to us. I saw this as well. So we can book a demo for our clinicians. So we just contact you
Yes.
and you can connect with us. All right.
Yeah,
So we
absolutely.
are global here. I saw majority in Asia from Vietnam, of course from Philippines. We have also Abu Dhabi. So where are you located, Dr. Dara? Like the
Yeah,
vertiginous.
so we're registered in the UK, EU, and the US at the moment. And other jurisdictions have different, because it's a medical device. This is not a software. It is a medical device. So each jurisdiction has its own regulations, and we have to meet all those regulations. So at the moment, our focus is Europe and the US because you have to start somewhere, and every market is really big. So yeah, I mean, the ambition obviously would be to be as global as we can to get this treatment to patients as much as we can. But at the moment, that's our focus.
Yeah, because there's an app, but there's a device like the ear.
Yes, yes,
Yeah,
exactly. It is a medical device, so therefore it is, yeah, and it's highly regulated.
I understand. But it's really nice knowing that that has an home exercise platform. It's not only treating the vertigo or the vestibular platform for that. There's also a balance and strengthening exercises that I remember Patrick emphasized when we have a
Yeah,
short note.
absolutely. Yeah, I
Yes.
mean, balance is really what it's about. Dizziness and vertigo cause imbalance, right? But patients get imbalanced for all sorts of different reasons, not just because of dizziness and vertigo, and that needs to be treated. We need to try and treat balance to prevent falls. So yeah, we aim to treat that as well.
So what is it not for, Dr. Dara? So who cannot
So
use it?
who would not use it? So yeah, we were talking about this the other day about the I mean, the contraindications for vestibular rehabilitation would be things like an unstable neck. You don't want somebody doing lots of head movement if they've got any instability whatsoever. Um, Unstable vital signs where there's known carotid artery problems like dissection, things like that. They're really rare though. So it's really clearing the neck for these patients before you do anything and clearing stuff with the physician. I wouldn't be using it for somebody who is has got headache, like really bad unmanaged headaches, because head movement often makes them worse. And they're one of the populations that we have to be really careful with as therapists. We can make them really, really symptomatic by getting them to move their heads. So often they have to be kind of co-managed with medication. So that first patient I was talking to you about, she will do very well with vestibular rehabilitation, but she may need some management of those headaches as well. So that's kind of the populations you wouldn't do. I suppose there's then patients who really aren't good with tech. They're very few and far between now, though. I think we're all getting very tech savvy and it's really simple to use. So I've an 83-year-old using it at the moment with no problems at all, took to it, no problem. So I wouldn't put age as a barrier, but certainly technology use. Some people rarely now are kind of adverse to using technology. I've had maybe one patient in the last few years saying, I just want pen and paper. I don't want to do anything on a phone. So that's sort of who would not be for. Yeah. Medically unwell, unstable patients that just aren't ready for lots of head movement and lots of balance exercises.
Thank you. So there's a question from Arabella. So once we have this for our patient, I remember we have a clinician and a patient platform for itself. So once they have it, until when they can have the device used? Is it
It's
like until
theirs
they
to keep. So
heal?
it's like a hearing aid. They get it and they keep it. It's single use. So it's like getting your crutches or your balance mat or your hearing aid. You get it and it's yours. So, and because we know vertigo recurs, they have it, they keep it, and
Yes.
if they need it again, they bring it back in. So, because it was sitting behind the ear, we made it single use, and it's low cost as well. It's not anything as expensive as a hearing aid. So that was that was the plan from the very start, was that it would be single use.
Thank you. That's interesting. Yeah. So if you have any questions, guys, connect with Dr. Dara. Dr. Dara, if you can put your email and other information on the chat, we really appreciate you. And very
Yeah.
interesting, at least you gave us an overview of the vestibular. We have a little bit of functional outcome measures there. Do they have an outcome measures embedded on the app, like the
Yes, we
showed the
do.
DHA,
Yeah,
DHI, DVA, I mean.
yeah.
Ah,
Yeah.
okay, okay.
So the core outcome measures that the APTA, Vestibular Edge
Mhm.
group came up with, they're in there.
Yes.
So
Ah, okay, the vestibular
so you can
edge.
collect them. So if you wanted for audit purposes for your clinic, like what your clinicians are doing, are they all doing, like what were your DHIs at the start, what were your
Mhm.
DHIs at the end? You can even do things much because the head kinematics are in there. You're going to get really nice information about head kinematics. And no, that's all very novel stuff. Nobody's measuring that at the moment. So, but
Yes.
yeah, the core ones are there: DGI, single leg stance, the CAT-SIB, dynamic visual acuity. You can actually measure the head with the head sensor, making sure the patient is moving their head at the right speed. There's a kind of a speed
Ah,
component to that you have to get them above a certain speed. So yeah, they're all in there. And you can print them out and get them into your electronic patient record then fairly easily. Just trying to
thank you
get
so
it's
much.
Dara at
Yes. Mhm.
vertigenes.com.
Yes, just put it there. Thank you. If you have any more questions, guys, just connect with chat and then we can share to Dr. Dara. We appreciate you, Dr. Dara. I want to share this because we missed to show this a while ago. All right, give me a sec. All right, so just connect there, guys, if you have questions, all right? So we have the Innovator Summit. So we just want to share this because we missed to introduce properly Dr. Dar here. All right, here. Mhm. All right. So for you, majority of you know me very well. I'm Dr. Jenny Yusuf, and we're doing the Innovator Summit for everybody. So we have this as a collaboration and conversation for all the different innovations. I just want to share our vision and mission. So for the long run, you can see our vision is to inspire a community of bold thinkers, just like Dr. Dar and the next speakers, and the different leaders to elevate quality of life for aging adults and communities by advancing innovative and people-first solutions in care and wellness. So our mission is to empower professionals with the knowledge, tools, and connections they need to create meaningful change, improving lives, elevating care for our aging adults, and driving innovation across health and wellness communities. So we have this as our agenda. I supposed to show this a while ago. So we have Dr. Dara Meldrum today. So she discussed about the vertiginous and the different innovations, and she will be followed by Carlos Garcia. He's here right now, and he will talk about the AI driven documentation relief of the Optimus PD technology. All right. So followed by Ian, and then neurostimulation, and then web FCE, and then we have lunch. All right. So these are all the different speakers that we will have on the morning, followed by the evening. We will have in the afternoon session after lunch break, we have Dr. Erica DeMarch from Nushu and Balance Connect, and Patrick Esmond and Phoenix Hipwear for our fall protection technology. So just to close for Dr. Dara, so we have Dr. Dara Meldrum as a leading vestibular physical therapist and researcher with 25 plus years of experience. She has 53 publications and research funding. After identifying major gaps in vestibular exercise adherence, she developed Vertiginous, a tech-driven platform that improves accuracy, engagement, and outcome for patients with vertigo, dizziness, and imbalance. I hope after she explained to us what is vertiginous, we learn a little bit more about vestibular rehab. And if you encounter more patients about dizziness, vestibular rehab, definitely try this particular appliance and the medical appliance and connect in your area. So this is not yet available globally. UK and US is available, but we have many clinicians here. So at least we know it exists and we can share to our patients as well. All right. For our next speaker, thank you, Dr. Dara. For our next, we have Optimus PD. Just want to share with you, we have many EMR software. So we have physical therapy software. So if you are in an outpatient setting, so connect with us and learn more about Optimus PD. It is an EMR designed for PT, occupational therapies, and speech. It is equipped with clinical decision support tools that guide diagnosis and plan of care. It enables providers to compliantly and efficiently improve patient engagement, adherence to treatment, and better overall outcomes. So why we choose it? So our clinical decision support leads to a more specific plan of care and better standardization of care and better overall outcomes. So we have Carlos Puesta Garcia. So he's a physical therapist himself. So he joined Optimus Corp in July of 2022. He's the COO and then also vice president of the Optimus PD, and he will going to tell us more about the AI effect of the Optimus PD. All right. Without further ado, I will going to share the floor to Carlos. All right. Let me see. Carlos, you're already a co-host and you can share your slides. All right. Thank you so
Very
much,
good.
guys.
Thank you,
Welcome.
Dr. Youssef.
Oh, my pleasure.
Good morning, everybody, or in the US, maybe, and good afternoon globally. Let me share my screen here.
Mm-hmm.
All right, hopefully everybody can see that.
Yes.
So yes, Optimus PT is a rehabilitation-specific EMR, electronic medical record software system. It is geared to physical therapists, occupational therapists, and speech language pathologists. We do have some behavioral health specialists, in addition to chiropractors that use the system as well, especially because of the fact that of how it's set up, some of the clinical inference engine opportunities that it offers, and the type of patient populations that we work with. So one of the questions we get is, what is Optimus? Why Optimus? And how is it differentiated from other EMRs in the marketplace? Our system does come with a plethora of features, like a full intake patient portal. We do have a patient-facing app, which I will get into a little bit later in the presentation and what that means. A full scheduling suite, to manage patients on a day-to-day basis. The actual documentation sections that take you through initial evaluations, progress report, daily notes, discharge summaries, based on what might be needed for the patient. If you're working with a different payer, if you need to provide documentation with referral sources and physicians, um, clinical support or the clinical decision support, which I'll be getting to shortly. And then obviously from a practice management standpoint, different analytics, reportings, and then we have different integrations with various billing or revenue cycle management partners that come into the back end. So obviously, as you're documenting, are you billing, for your services and generating claims that you need to be linked to have to Optimus? So is obviously, then why Optimus? How are we different? Why are we special? And what is our, if you will, value proposition? So we house in our EMR a clinical decision support. So what that means is, as a therapist, as a provider is documenting, they're getting real-time feedback based on their tests and measures of, what uh, the clinical results of the documentation is showing. What that means is, and this really started back in 2006, the American Physical Therapy Association, in conjunction with us, was developing clinical practice patterns or practice guidelines. It started in the orthopedic section and then went to the other section. I know there's a lot of vestibular specialists, neuro specialists on this some the neurology section as well developed practice patterns um, that that are based on evidence. As the research comes out, that research is uh, uh,
You're choppy, Carlos.
incorporated into this practice pattern, so therapists know what is diagnosis based on their set of clinical findings. That then obviously feeds into things like, yes, Doctor, can you hear me? Was there a question?
Yeah, no, you're just
Are you
choppy.
able to
You're
hear me?
you're like cutting out. Mm.
Oh, okay. Can you hear me now?
Yes. Mhm.
Yes. Okay. So as I was determined by each section of the eight are edited system. So as you're documenting and completing your tests and measures, you will get a likelihood of and an eventual confirmation, and lets you know you've met the requisites and what the evidence dictates as the minimum standards to for that particular diagnosis. You'll get some treatment recommendations and goals based on the information that you've put into the system. So it becomes a clinical tool, not just a documentation tool. So if you have maybe a therapist that might not be particularly familiar with a diagnosis, the system will guide them through the process. If you're a seasoned therapist, experienced therapist, it's just going to confirm kind of that clinical rationale or thinking that you might have. So if you look at Optimus PT, we are unique. We're not just a software as a service provider. We're not just an EMR. Our parent company owns and operates clinics. Why this is important is, as a software provider, as an EMR provider, we own clinics that have administrative personnel, clinicians. We have billing specialists. We have credentialers, people that work on collections. So all those different roles need to have a place in the software system, and we understand that. We're not trying to build a software to put into your clinic. We have the clinics where we have to meet our own minimum threshold of efficiency, um, and operational success before we deploy any technology into our users. We are in about 730 clinics across the United States. So our own clinics serve as our testing environment, and that's something we're very proud of, because we make sure it meets our standard of success before we move on. Um, as we look at a differentiation, because we have all those roles, clinical, administrative, billing, credentialing, from a customer service standpoint, that core group of support will be able to speak to those specific needs as you might have coming onto our system. So if you're coming on and you need administrative support, we have an administrative person that can speak to your needs. If it's clinical, we have clinical specialists. If it's compliance, um, we can get the compliance experts that we have to troubleshoot or navigate any issues that you might have. We do have a 24-hour support team that's available for needs that you have. Embedded tools in our system, as I described, that clinical decision support is available for you at the point of care as you're treating patients. Our system is built around compliance rules engines. So if you have different requisites from payers or different groups and guidelines you need to follow, the system will prompt you. It'll give you real time um, uh, flagging or alerts based on things that you're doing in the system. So from a billing standpoint, if you're overbilling, the system will prompt you. You're not following the payer rules. If an example with Medicare has a cap for rehabilitation providers. If you're going to reach or exceed that cap, the system will prompt you. Again, it's setting up the guide rails of success for you to use the system. It's obviously very intuitive, very user friendly. There are a lot of templatizations that you can do if you would like to customize to certain ways of treating or documenting that you have. I mentioned before we have a patient-facing app. This is called Optima Me. This app is something that a patient can download. They can pull up all their exercises. They can communicate with the therapist directly. There is a two-way communication feature. The patient is having trouble, they can let their therapist know, and then the therapist can reach back out. You can see patient compliance. So you can see if a patient is doing their exercises or not. And you can obviously prompt them saying, hey, what's going on? Why are you not performing? Or are you having any difficulty? Instead of just waiting for the patient to come in for their next follow-up visit. Therapeutic monitoring, remote therapeutic monitoring are billing codes that Center for Medicare Services brought out in 2022, where if you have software as a medical device, this app would qualify. Patients can be monitored outside of the clinic, and there are reimbursements code where you can receive additional revenue for those services. This is included in your base offering. This is not something that we would charge extra for. We provide as a courtesy to our users and subscribers. I mentioned before, KPIs and analytics reporting. This is just a snapshot of a home screen. This is by role, but where you'd be able to see data that is retrospective. You can look backwards or you can look into the future. What does my schedule look like? What are my new evaluations versus follow-ups? Do I have all my authorizations in place? What is my patient retention? Do I have fall-off cancellations? So it helps you manage your practice by role. From an onboarding standpoint, obviously we, sequentially phase our onboarding from once you've signed on, there is a kickoff call we walk through to determine what are your workflows, what are your needs as a practice. Training is there's obviously training modules as a learning management system that takes you sequentially with videos through the different trainings. We have online training that takes you through to a go live. Once you have your go live, there is still support or needs based on the practice itself. As a rule of thumb, most therapists are documenting day one to really learn the system and the efficiencies behind it. Usually about 4 to 6 weeks is that learning curve. So AI is a big, proponent of what we're doing now, across most, software systems, and how are we phasing this into what Optimus PT is. There's a couple things that we're working on. AI, obviously, we have our, patient portal that receives information from an intake standpoint that then populates into the note. So if patients are onboarding their demographics, insurance information, there is a clinical history that they're also going to be providing. That ports over into the documentation notes. So as a provider, you're not having to complete a full new subjective. The AI is grabbing the information, it's summarizing it, and then it's mapping it out into the different sections. And this would be an example of an evaluation note and how it ported over information. There's two big, exciting, features we're hoping here to roll out in Q1 of next year, between February and March. One is an AI ambient listening. So it's a scribing. What that will allow therapists to do is when they're working a particular patient, they will have. Are you able to hear me?
Yes, it's just cutting on and off. It
Uh,
says
Am
bandwidth
I
is low.
gotcha? Am I back now? Okay,
Yes.
very good. Um, the So I was mentioning and describing the AI, the ambient listening. A therapist will be able to have a full conversation with a patient, and during that session, there will be a dialogue back and forth. There will be, let's say, it's an evaluation, a history. There's going to be some objective measures that are taken. There's going to be a dialogue of a summary or an assessment of what's going on, and then a discussion based on the course of action or the plan. That will all be captured in the ambient AI um, scribing. It'll transcribe that conversation, and what it's going to do is summarize it and again map it out to the different sections of subjective, objective, assessment, and plan. The therapist will then, at the end, once they're done with the patient, go in and be provided this summary. That summary will then allow the patient to make any edits or accept. So you're not going to have to be pointing and clicking and typing or finishing your day saying, I have 8 notes that I have to write. It will all be done for you. You will have to decide as a clinician, does that note reflect what you want it to reflect? Are there any edits, or do you simply accept? So what we're finding, obviously, that's a big exciting feature from a burnout standpoint. As providers, we're getting busier and busier, and it creates less documentation that you have to provide. It allows for more bandwidth in the day, sometimes more productivity. If I'm documenting less, I can see one patient more because I have more room and time in my day. And lastly, we have an AI agentic feature that we're going to be rolling out that will help providers navigate the system. It'll help providers from a searching standpoint. Let's say it's a home exercise program and I don't want to be filtering through. We have a library of over 2,000 exercises to find what I want. I'm just going to type in a general search. That agentic AI will help pull up the exercises I need. It'll also help navigate the system. If I need to pull out information to a specific patient, I will be able to put a general search, and it's going to take me right to that document or to that patient profile that I'm searching. The idea is to bring efficiency and create better bandwidth for our users as they're navigating the system. And the goal is really to be able to treat patients in a better manner, in a clinical manner, with less over reliance on physical data entry and more, systematic AI working in the background for you. So that would conclude, the general background of what Optimus PT is. Again, happy to answer any questions that do come up, but to reach out to me, and I can provide my email in the chat. Feel free to reach out. Our company website, optimuspt.com, has information, and anyone that would benefit from a demo or would like to learn more, we can definitely kind of do a deeper dive into some of these sections to see how this may benefit you.
Thank you, Carlos. Yes, I put it there. If they are from outpatient setting, they can message us that way if they are interested more for the free demo for the Optimus PD. It's really nice if you can really see it and one-on-one. If you have more questions, how the AI scribe works, the difference between and how it can help your practice. All right. So how many outpatient physical therapists or OTs are here? So some are mixed, some are acute. Put on the chat what setting are you in. All right, guys. Thank you. Do you have any questions for Dr. Garcia Cuesta? Dr. Carlos? Yeah, thank you, Carl, for putting your email there. Definitely. And is there a specific state that it cannot be used or it can be used anywhere?
It can be used anywhere. Right now, we're based out of the United States. We have a development team in Taipei. We are in some discussions with some medical systems in China. So
Oh,
we do have a U.S. large presence, some international presence. We are currently working on a light app version of the clinical decision support. So right now, our decision support sits in the Optimus Heavy, the full EMR. We are looking to bring that out to integrate with other systems, or if someone says, hey, I don't need the full EMR, but I would love access to that clinical decision support sort of mainframe or algorithm, that is something that will be coming out shortly.
wonderful. Thank you so much, guys. If you have any questions, feel free, and we can definitely Carlos can answer some of them, all right? Okay. All right. Thank you so much, Carlos. We appreciate you.
Thank you so much for
Okay.
having me. Good day, everybody.
My pleasure, my pleasure. All right. So if ever Carlos will not be here, his email is on the bottom and then we can forward it to him as well. All right. Thank you, guys. All right. Let me share this again. Taylor is asking for the agenda once again. So let me see. So we have Carlos. Thank you so much. So he told us all about Optimus PD. All right. So let me go back. Let me see how to go back here for our here. Here, Taylor, will be our agenda. So we have Dr. Dara this morning, 8:05 to 9. We just finished a short presentation with Carlos talking about Optimus PD technology. So more on EMR automation, AI scribes, and we are now heading to Ian Cutts and also Ed Wilburn will be joining him. So there will be two experts at this time. So from 9:20, maybe 9:30, we will begin soon. So they will discuss osteoporosis, spine rehab, sarcopenia management using vibration therapy and advanced bracing. So we have lots of osteoporosis cases, sarcopenia management. So they will going to talk about whole body vibration for bone density, stabilization strategies for low back pain and post-op spine rehab, evidence-based clinical outcomes and case discussions integrating bracing into PT care. So we have a short break if after them, and we will have Matthew for neuromodulation for pain, concussion recovery using the dolphin neurostimulation. So he will be with us around 10:40 and followed by Bill at Web FCE. So there will be a short lunch break and then we will have the afternoon session The first speaker for the afternoon will be Erica DeMarch. She's the CEO of the Step Connect, and she will talk about the new shoe, which is a different, like a shoes with a very interesting innovation, and Phoenix Hipwear for falls prevention, and of course, DC Care Network. Okay. All right. So we can share this again later if ever. All right. So we have now Copa Healthcare. Thank you so much, Copa. Copa Healthcare are one of our sponsors in the recent Geriatric Rehab Summit. Thank you, Ian. Ian is the president and co-founder of the Copa Healthcare. So Copa Healthcare is they find and supply innovative and useful technologies for management of your musculoskeletal health. So once you hit your 50s, changes are occurring, including decreased bone density, muscle mass and strength, and increased joint stiffness. Sarcopenia, osteoporosis, osteoarthritis, conditions emerge and affect overall quality of life. So these situations become more important as we progress through our 60s. So the aim of Copa Healthcare is to enjoy an active and satisfying daily life. So they're producing and providing different cares of technology to improve and decrease sarcopenia and osteoporosis. All right. Thank you so much for that innovation, Ian. So we have our two speakers this morning. So Ian Cuss is a medical device company president and co-founder and commercial leader with global experience in commercialization, marketing, team development, and expertise in these kinds of innovation in Copa Health. And Ed Wilburn is a senior healthcare executive with proven success in sales leadership and co-inventor of different kinds of patents for different kinds of braces, especially low back and spinomed. All right. Thank you so much, gentlemen. And I give the floor for both of you. You're available. I know Ed and Ian are here, and you are already a co-host, guys. All right. Thank you. Welcome.
Hello, everybody. Good morning, good evening, wherever you are.
Exactly.
Thank you, Jenny. So
My
what we'll
pleasure.
do is I will speak to the low intensity vibration segment of whole body vibration, discussing sarcopenia, balance, falling, and some extent bone. But I'm focusing more for the physical therapists, in this group on fall protection and prevention, rather than bone mineral density specifically. And then Ed is going to discuss the Spinomed brace, which is designed for very effective management of hyperkyphosis and associated problems from that condition. So hopefully this is interesting and useful for the groups listening in and watching today. So let me just do share screen. Bear with me. Can I share my screen, Jenny? Sorry, I'm being a bit slow here.
I don't see it yet. Let me see. Yeah, I can see it now.
Right, good.
And you're a co-host, so you can share.
Right, yes.
And yes, slideshow.
So basically, we're interested in keeping you tall and stopping you falling. So let's talk about whole body vibration. It's reasonably well known, but I think there are still areas where people do not really appreciate the fact that there are two categories of whole body vibration technology. So the parameters that we talk about with whole body vibration are displacement, so the distance traveled up and down of the surface which is lifting the individual, and then the speed or the frequency of those movements, which is generally measured in hertz or numbers of cycles per second. So that has an impact on the acceleration which the plate creates and puts through the person standing upon it. And there are quite important differentiation factors between low intensity, which if we use G-force as the measure, is in the range of 0.2 to 0.4 G. Excuse me. And that relates to clinical research over the last 30 odd years in humans, particularly postmenopausal age group and above. There is quite a lot of research in kids, but I'm not going to discuss that today based on the interest area of this audience in the older population. And then your high intensity vibration is anything above 1 G. So vibration plates which generate those magnitudes can range anywhere from 1 up as high as 15 G force, depending on how much displacement and how much speed. So a low intensity vibration plate, like a Maridine or a Juvent, is fixed. It will not move in any other direction other than up and down. Conversely, a high intensity vibration plate can move in one plane, or it can be multiplanar, or it can even be like a side-by-side alternating, similar to a seesaw or a teeterboard. So when we look at low intensity, one of the early challenges that we had to understand about it was, would the force, because they're very small, transmit through a standing person? So work was done early on to look at force transmission, and we know that the effect will move between the feet and the head. It reduces in its intensity as it progresses up through the skeleton. So if you take a 0.4 G-force acceleration at the feet, then there's a 25% attenuation of that, and it's around 0.3 G at the hip and the lower spine, and it reduces another 50% before it gets into the head. So this is important because it means a person on a low level vibration plate can stand fully upright with straight legs. Now, when we go across to high intensity, the magnitudes are much, much, much bigger. So you're playing with maybe G forces in the range of 5, even as high as 10 G in regularly available platforms. And these are available for people's use at home. So it's not as if they're actually overseen by somebody that's professionally trained. So the safety factor does become very important. Now, there's a human safety standard, ISO 2631, for exposure to vibration because it is pathogenic. So you think about helicopter pilots or people that use jackhammers on road repairs, you know, there are significant vibratory forces. So when you look at a low level vibration plate, it can be used safely for up to 4 hours exposure each 24-hour period. When you're moving into the high magnitude realm, then we're getting exposure limits of about a minute. So I think for clinical specialists, you need to understand the magnitude of the platform, the patient selection, and then correlate risk to clinical benefit. So I think there's an important understanding of vibration magnitude and its use to your patients that you're working with. So I'm just going to show this in an image. This is a low intensity sine wave. As you can see, it's very clean, it's very consistent, it's very gentle. Now, when we go to a high magnitude vibration, and this is a low setting, and then this is a high setting, you can see there's quite a difference in the effects of the force on the water. So, you know, I think one of the main take homes today is whole body vibration is quite broad, but there are two distinct categories, low intensity and high intensity. The cutoff point is 1 G for low intensity, but the actual range of products used in that realm are 0.2, 0.4. The important thing on the devices in that category is they match the dynamic load of the user. So they're smart devices. They've always been designed to put a constant acceleration into the person using it. The higher magnitude vibration plates will create various G forces based on the frequency and the displacement setting, and they don't generally match the load profile of the user. So there are operating differences and factors to think about. So when we look at mechanical forces and musculoskeletal tissue, there's quite an important law of physics, Wolff's law, which basically says form follows function. So take a Roger Federer racket arm, it's got around 35% more bone than the ball throwing arm due to the forces that go through that arm when the tennis racket strikes the ball. Conversely, when a person goes into zero gravity, like space travel, then the bone is being lost at a rate of around 2% a month. So there's a real issue with regard to loading or the absence of loading on the quality of the tissue in those circumstances. And this is an important plank in the discussion as we go forward this morning. Bone as a tissue will decline if it doesn't get enough loading cycles of various magnitudes of force. It can be maintained or it can actually be improved. So depending on where the bone is in life and the exposure to force that bone is getting, it can change its behavior. So we know with osteoporosis, it's a big issue for a long lifetime now, for particularly women, because life expectancy is very long, and menopause creates a sort of bone challenge that men don't face quite so much earlier in life. So management of bone has been and is a very important factor going forward. I think we're also learning now a lot more about muscle and the importance of muscle condition and quality in addition to bone for better musculoskeletal stability and protection in later life as male and female lifetimes are extending out. But Rubin's work showed around 30 years ago that you can affect bone by small numbers of large magnitude forces or large numbers of small magnitude forces. So there are force levels which can have an effect. They have different transduction pathways or whatever, but they will help to maintain and or improve tissue. So bone itself changes a lot as we progress through various decades. So, when you're young, you've got very vibrant connective structure, good modulus in the bone, and it's big. By the time you're 80, it's deconditioned significantly. The size has changed. I'm thinking in terms of vertebrae here. So we know we get height loss. We've got a less rigid, a less plastic structure, and that challenge is one that needs to be managed for many decades. The areas of muscle, though, are also just as important. So again, a midlife individual is going to have a fattier muscle, less type 2A, type 2B muscle fiber compared to a younger individual. The contraction realm, if we look at a soleus muscle in a 27-year-old compared to a 73-year-old, there's a significant drop and loss of contraction activity in the sort of 20 to 50 cycles a second range compared with the younger muscle. So low intensity vibration has been studied for the last 30 years as a method of maybe helping to protect and improve the muscle itself. So this is an animal study, Dr. Z's study, looking at adolescent. The AC is an adolescent versus a baseline control mouse. And then they added vibration in. So what they found with the adolescent versus the baseline mouse is obviously there's a difference in tissue itself, but when the vibration's added, then there's a significant improvement and increase in the amount of particularly fast firing tissue that's present in that muscle. I apologize for this being quite a complex slide, but there are about 4 important points I wanted to try and get across on this. Neuromuscular junction degeneration is a big issue in sarcopenia. Low intensity vibration can help protect the neuromuscular junctions. So over time, period of 4 months, and this is in a mouse model, LIV showed it could increase the strength and the muscle mass and the grip strength of the mice versus their control group. It did this by preserving neurojunction behavior, particularly with regard to DOK7, which is a protein which enables the sort of normal functioning of that neuromuscular junction. So the LIV is helping to protect the levels and actually increase DOK7 levels. It also had an impact on the ERK1/2 muscle breakdown behavior, because that can be a friend or it can be an enemy, to a muscle. So what it helped to do is regulate the atrophy behavior in the muscle by managing the ERK1/2. And out of that came a greater level of protection to type 2A and type 2B muscle fibers, those fast-firing muscle fibers that are contracting in the sort of 30 to 50 to 60 contractions a second. So LIV does promote activity. So Dr. Bibb did some work a few years back, and it shows that, if you've got an LIV, it's increasing the contraction and force behavior in the faster firing range. So in the 40 to 60, 70 hertz range. And then in the older versus the younger animal, the contraction profile in a young mouse, when you compare it then to the old mouse, we've seen this drop off in the 20, 50, 100 hertz range. LIV puts it back. So the low intensity vibration is a different stimulus to protect the sort of quality realm of the muscle, particularly in the fast firing category. So this is a busy slide, but it will just try and sort of explain some of the basic biology. So if we look at that animal with the large hammer, it's going to hit a mesenchymal stem cell. So the mesenchymal stem cell resides in the bone marrow, and it's like a teenager. So it can be a good teenager or a bad teenager. If it's bad, it becomes an adipocyte. And that's increasingly happening as we get older. We're getting more fat in the bone marrow. If you use an LIV stimulus or mechanical force, then you do get increased regulation and production of osteoblasts, which are bone building cells, and you're interested in those. So the LIV has been shown to increase the number and bias the behavior of the mesenchymal stem cells in producing a higher level of osteoblasts, also muscle cells, fibroblasts, chondrocytes, and suppressing adipocytes. On hematopoietic stem cell behavior, it's having an effect on knocking out some of the behavior of the osteoclast to latch on and resorb the bone. So the primary role of LIV, low intensity vibration, is to be anabolic and create more tissue. It has a secondary effect of possibly knocking down some of the osteoclast activity. It's not like an anti-resorptive drug medication that sort of almost finishes the behavior of the osteoclasts, but it just makes the osteoclast life a little bit more difficult. So your net gain should be more useful tissue being produced where that low intensity vibration is being placed through that musculoskeletal tissue. So what does this mean to humans? Because we're interested in fall prevention, I think, and the fractures that result from the falls. So NASA did work in the early 2000s in the preparation of maybe using low intensity vibration as part of long distance space travel. And there was a study done in Houston with adult volunteers laying in bed for 90 days in a 5-degree head down attitude. These were fit, active adult volunteers. So the typical loss profile of balance from the bed rest is very marked at the 90-day compared to the 30-day in terms of this general instability map. Where LIV was used, and LIV was applied to about 55% of the group, they had 10 minutes a day of low intensity vibration, and a harness was applied to attach the person's foot to the device with about 70% of body weight, so quite a force, mimicking a body weight on the plate, because this is analogous to zero gravity. And just 10 minutes each day showed a marked benefit in terms of maintenance of stability and minimization of velocity changes in the actively treated group compared to the control group. Now, there's a orthopedic group in Hong Kong who have been well regarded over the years and are an important fragility fracture research site. So the Chinese University of Hong Kong have been studying whole body vibration in its various forms for over 30 years. And they've done important research in humans in the use of low intensity vibration for the elderly and protection of the elderly. So this study done by Professor Leung and his group and published in 2014 is a 18-month study of women, sort of 60 years and above, who are normal healthy, half had a low intensity vibration protocol and the other half just their usual exercise. And it was somewhat sedentary, but it was a sort of regular behavior as you'd find in that part of the world where people do tend to be more ambulant than possibly over here. So the 18-month study's primary outcome was falls, and then there was some association of fractures to the falls, but the primary outcome was to look at the fall rate in that study. What they found was overall in 18 months with the live users, a 46% fall rate reduction, but that was across numbers of episodes of falls. So in every category, no falls, 1 fall, 2 fall, 3 falls, there was a significant reduction in the vibration group compared to the control group episodes. So this study was then followed up at 30 months. So Dr. Chung did a subgroup analysis of people that had had the vibration, people that had never had the vibration, and there was a cessation of the vibration for 12 months between month 18 and month 30. So again, I apologize for the slide, but blue is the vibration and the flesh color is the control group. So in balancing ability, there's a general enhancement at 18 months and a maintenance of that out at 30 months. So the balancing ability capability is not getting lost, even though the live hasn't been used for the prior 12 months. And it's the same with dominant leg and non-dominant leg muscle strength. There's hardly any change between month 18 and month 20. Bone is tougher to show. What we know from the study doesn't really show very much with regard to bone mineral density at the hip and spine. What we did see is if they subgroup and analyze the compliance, so the compliance is 100 minutes of low-level vibration a week, 5 times 20. So if people were at that level with their DEXA scores in bone mineral density, both at hip and spine, between month 12 and month 18, there were positive changes in their bone mineral density measured by DEXA in both the femur and also in the lower spine. So there is a sort of level of low intensity vibration that you need each day, particularly with bone if you're at a later age group. And that's around 20 minutes each day. So this is very important because it then comes to, well, where can you deploy low intensity vibration in a care continuum? So the next paper will just discuss hip fractures, because that's a big issue, and I know it's one that you're addressing every single day in your clinical practice. So the same group took a batch of trochanteric hip fractures, average age 80 to 83, male, female patients, but obviously a predominance 2/3 female. And they did standard of care with live versus standard of care for management of those fractures following surgery. For context, the study was originally designed around about 2017, 2018. So it then goes through its ethics committee approval and ready to be funded. It's a grant-funded study from the Hong Kong government. Along comes COVID, so they can't recruit anybody. So they had to change the protocol, which was originally going to be 6 months of LIV, down to 14 days of LIV, because they could treat those individuals while those individuals were inpatients at the hospital. So this is a point I just want to share with you to think about. If we're going to deploy LIV post-operatively in the United States, where does it live? Where do you put it? SNFs, home base for the patient? Can it be in a hospital, based on your patient throughput factors? So that's an important element, because the study protocol started the LIV, which is 14 days, 20 minutes a day of low intensity vibration, in a range between post-op day 1 and post-op day 20. So it can start quickly. So this is an important factor. You cannot put a hip fracture on a high magnitude vibration plate. With proper oversight and patient selection, you can consider to use a low intensity vibration plate with a patient that has a hip fracture. So it's not reckless, it's not dangerous, it's not contraindicated. It can be done, but it requires proper oversight. Now, the study itself was 6 months. So it was 14 days of LIV and then review the patients at 6 months. They looked at osseous union with CT scans at week 6 and saw better bone integration around the fracture site at 6 months. And both groups, control and LIV, were healed at week 52 using radiographic assessment of the fracture. In quadriceps muscle strength, they saw significant improvements at week 26 compared to the controls. Balance was more of a challenge because you can't do, sway analysis and balance assessments on people one day after fracture. So they had to use week 6 to week 26 as the period to assess those patients. But again, they found in the vibration group significant improvement in overall stability index and also timed up and go at week 26 compared to week 6. The SF36s were very good in terms of the patients that had had LIV compared to those that didn't. So this is something that should be thought about in fragility hip fracture management in the US with surgeons and PTs and other people that are overseeing care. It does appear to be useful. The challenge is, where can you deploy the LIV? Where can it be? So if the patient care pathway allows interaction with it after surgery for around a 14-day period, it's helpful. It appears to be helpful in the outcome for that patient. Arthroplasty, like hip replacements and knees, haven't been studied, but the hip fracture is a real challenge because it's generally a more difficult group, and there's obviously massive implications for those individuals that have the hip fractures in staying alive, quality of life, future risk, etc. So everything that could be done for them should be thought about seriously, and this area seems to need some consideration. So clinically, low intensity vibration is safe, it maintains balance, it increases leg muscle strength, it maintains muscle function and protection of fast firing muscle fibers, and it significantly reduces falls. So the commercial devices, there's a Maradyne, which I work with. There's another one called a Juvent in the United States. Maradyne's available around the world. It's a class 2 treatment device for osteoporosis, postural stability, and a range of other things outside the United States. Inside the United States, it's a class 1 powered exercise device, as are all the other whole body vibration products. So the Maradyne is manufactured in Germany. It's a 0.4G device, and it has 10-minute sessions of use. So if you'd like to know more, you can contact me at ian@copahealth.us, and I'd love to talk to you further if this is of interest. If you're outside of the US, I can put you in contact with the manufacturer based in Germany, and they have a worldwide distribution network in place. So I'd like to finish now and then maybe introduce my colleague Ed Wilborn, who's going to talk about Spinomed, spinal ptosis. Thank you very much.
Thanks, Ian.
Thanks, Ian. Great presentation.
Let me pin Ed first. Let me see. Okay, let me add you. All right, go ahead, Ed. Welcome.
Thank you, Jenny. Thanks so much for the opportunity today to present to the group. Very much appreciate it. Let me move this into presentation mode. Okay, so Spinomed is what we're going to be talking about today, and we're going to be focused on osteoporotic patients, as Ian mentioned earlier, and hyperkyphosis related to those conditions, and vertebral compression fractures. So I felt like it was a good idea to start this conversation off with just a snapshot of how impactful osteoporosis is within the United States. I understand that we have international attendees today, but most of my information as far as prevalence are going to be constrained to the US. But when you think about the women over 65, that's 27%. The women over 65 are going to end up with osteoporosis. The other number that I think is really important on this slide, I mean, they're all really important, but the one that stands out to me is the 2/3 of vertebral compression fractures that are undiagnosed or asymptomatic. And when you think about those numbers and you think about the fracture risk cascade or the vertebral fracture cascade component where you 12x after 2 fractures, this is a really big issue. So hopefully what we're doing here can help reduce some of that risk for sure. So there are many clinical signs of osteoporosis, but we're going to focus on 3 specific areas: increasing kyphosis, reduced muscle strength, and increased risk of falls. Each one of those areas certainly is positively impacted by physical therapy. And at Spinomed, all the way from its inception, and I was fortunate enough to be the lead on the team that introduced it back in 2003. So I've been with this a long time. I've seen how it impacts patients and how it can become part of a great comprehensive rehab program. So I love this quote, and it really speaks to what the mission of the Spinomed is. And that's really to return a patient that's suffering from osteoporosis and the vertebral compression fractures and hyperkyphosis that often come along with it to a higher quality of life. So I feel like this quote pretty much sums that up, and it's from one of the most recent studies on the Spinomed. It's now 26 years old worldwide, and it's been on the US market for 23 years, and it's in its 5th generation. It's been constantly refined over the last 2.5 decades, and it really has become a very easy product to fit as well as live with on a day-to-day basis for the patient. It is Medicare reimbursed. It has been since 2006, and it does require professional fitting, and we'll get in a little bit of that a little later. Also, it enjoys many clinician endorsements across the US and worldwide. Some of those you'll know, that's people like Sarah Meeks and Margaret Martin. And those are both proponents of the Spinomed. And so I think it's important to start off the conversation in the Spinomed with the science behind the Spinomed. Most of the time when you're looking at bracing solutions, there's not a tremendous amount of science behind it. There's practical applications and clinical evidence, but from science published peer-reviewed science. There's not a lot out there. This study really changed the way the market or the caregivers think about bracing. Prior to the Spinomed, you really were looking at things like Jewett style bracing, cash style bracing, body jackets, LSOs with sternal extensions, a lot of different types of products, and they're all excellent products for their specific applications. But the osteoporotic 65-year-old woman who is a bit sedentary now, or not quite as active, higher risk of advanced sarcopenia if you brace them, right? And you really end up with disuse atrophy. It's a big problem. And those previous iterations of TLSOs really, they were really developed for a more traumatic type of application. So we'll talk a little bit more about the science and the numbers in the next few slides. What's important, I think, about the Spinomed, the original Spinomed study, is that there were 62 women in the study, and every one of them the average age was 73 years old, and everyone had to have at least one radiographically proven vertebral compression fracture. The average was 2.1 per patient. Minimal angle of kyphosis was 60 degrees. And so I think what that demonstrates is these were the patients you see in your clinic every day, right? These are not unusual patients. They're pretty much what you see. And the treatment course was 2 hours a day over the course of 6 months, and that was twice. So it was a 12-month study, and the second 6 months validated what the first 6 months did. And also important to know is that physical therapy was not included during the course of the study, so we could isolate the impact of the Spinomed on this patient population. So, quick review of the numbers that came from this study. And it's also important to know that multiple studies have come after this original one in 2004, and they've all validated and expanded on the applications and areas of focus. The numbers, I think, on here that we really want to look at for this discussion, core muscle strength, right? So Ian touched on a lot of muscle thought in the live presentation. The Spinomed continues that theme. Back extensor strength enhancement, 73%, and abdominal flexor strength, 58% increases, just 2 hours a day while the patient's up and around and active. So it's also, I think, at this point, important to note that this is a patient population. You have to have patients in the Spinomed that have the ability to move around. They have the ability to get up and walk and do things like that. If you're not a patient that's going to be able to do that, then the Spinomed's definitely not the right choice for you. The other areas that I think really stand out to me are the decrease in average daily pain. We have so much talk about opioids and other pain modulation products out there. A 38% reduction in average daily pain is pretty significant. And then the last two, and all of these are related to a decrease in angle of kyphosis, but the decrease in body sway certainly can cross over into the thought of fall reduction or fall risk reduction. I mentioned earlier that the original study has been followed up multiple times and validated, but also expanded into areas that weren't in consideration with the first one. And one of those areas is vertebral augmentation. So things like kyphoplasty, vertebroplasty, and there's some other unique devices out there also for reestablishing vertebral body height and reducing the acute pain of patients that are dealing with vertebral compression fractures that have been diagnosed. And from the very early stages of the Spinamed and speaking with the doctors that were performing these procedures, became clear that the Spinamed was a good adjunct because those procedures do a great job at what they're targeted to do, which is reduce pain and return vertebral body height. But what isn't often included are referrals to physical therapy for core strengthening, for postural alignment training to take pressure off the anterior edge of the vertebrae. So the Spinamed is promoted as a tool to use as an adjunct for those types of procedures. Again, we always push the idea of comprehensive rehab programs. So should always include physical therapy referral, and the Spinamed continues on a daily basis what the PTs are doing in the clinic. And so what we've proven in this study has a positive long-term effect on straightening of the vertebrae. So I think it should be considered for sure as an adjunct to vertebral augmentation. How does the Spinamed work? Really, when you think about the old style of bracing and the one that most physicians and PTs are still familiar with, you immobilize a person. You don't really want them to move around, and the risk of doing it that way for a 65 plus population, of course, as we mentioned, is the atrophy issue in the core muscle strength. So Spinamed uses biofeedback. Think about it as a TLSA or a spinal orthosis that is actually providing a therapeutic effect to the area that it's also stabilizing. So when you think about that, and you look at this picture, you can see that the arrows are cueing. And what's really happening here is that first picture where you see the straps in pink going around the shoulder and over the shoulder. What actually happens with the Spinamed? We fit it in the patient's most upright position. It's a struggle sometimes for them to get to that position during fitting, but that's where we fit them so that we always guide them back there when they're wearing the Spinamed. So every day they put the Spinamed on, there's a therapeutic effect occurring while they're wearing it. And as you move around, if you twist, if you squat down to pick something up off the floor, whatever, gardening, whatever you're doing, it's constantly working with you to remind you to be in proper postural alignment. And that's how you end up strengthening the core muscles. It's important to remind patients when they're wearing the Spinamed, especially if they're pretty deconditioned, if they've been sedentary for a while, they're probably going to end up dealing with some muscle soreness, so you'd want to back down the time from the hour to start to maybe 15-minute segments, and then just increase it over a few weeks. And as they become stronger, their muscles will become less sore, and they'll be able to do more. Indications for the Spinamed. Pretty straightforward. Hyperkyphosis for chronic back pain and vertebral compression fractures. That's really what we're focusing on for this discussion today. Where it doesn't belong is in an unstable fracture that needs to be immobilized. So if you've had an accident or something along those lines, and you really need to have your torso immobilized, then the Spinamed's not the product for you to consider. Again, it's the 5th generation of the product, constant refinement over the last 2.5 decades. It is easy for the patient to live with. It's light, it's easily concealable underneath a jacket or a sweater. So the patients that wear these, often they're the older women, and they really don't want to take a walk around the neighborhood looking like they're wearing a brace. It's really important to them. And so Spinamed's easy to hide underneath your clothes. it's evolved into a very easy product to fit in the clinic. And over the years, it's also evolved into an easier product for patients to wear. It's got innovations such as shoulder straps that make it easy for them to put in their preform, so they don't. It's a little easier than even putting on a jacket. So yeah, how do you obtain a Spinemed? So prescription only. So it's really important. So you're going to, for it to be reimbursed by Medicare, and of course the private insurers follow Medicare guidelines, you're going to need a prescription that comes directly from an office visit. And your prescription is going to be faxed over to a clinic that'll fit it. And most of the Spinemeds are fit in the O&P clinic. So by an orthotist, a trained orthotist understands how to use the Spinemed is the most frequent way that patients receive them. We do have PT clinics that dispense the Spinemed. It works really well for the PT clinics that want to get involved because they're seeing these patients all the time, and they can make the minor adjustments very quickly. And there's reimbursement in there for them. So, but they do have to have a DME POS registration to be able to actually bill Medicare. DME providers that have been trained on how to fit the Spinemed, also another option to receive them. There are some physician offices that dispense the Spinemeds through their clinics. And of course, they're available in the VAs. So that really sums up the Spinemed. And if you're in a facility that would like to consider using the Spinemed for your patients, just contact me. I'll be happy to talk about it from your clinic's specific and unique needs. And that'll do it. So,
Thank you, Ed.
questions?
Yes, Percival has a question, and most probably about Spinemed, but you already indicate some of the indications such as kyphoscoliosis. But how about kyphosis? How about scoliosis? He asked. Is this
Yeah,
in
great
you?
question. We get that often because a lot of patients that are in this category have kyphoscoliosis issues going on. And in that realm, it does a nice job on the kyphotic element only. It really doesn't have the capacity to handle multi-dimensional type of applications like you'd see in scoliosis. So not indicated for scoliosis. But if you are kyphoscoliosis patient, yes, but we'll handle the kyphotic element.
Yes, all right. No worries, Percival. And also, if you have any questions, guys, for Ian as well about the low vibration plate or therapy, definitely check and post it on the chat as well. All right. So, Ian, I just want to go back because we have both of you on the session. The low vibration plate or therapy, you specify that there's a specific, that's why the low vibration is specifically for bone to activate the osteoblast formation, things like that. So can you say that, because I see already the demonstration of the high intensity. Are you saying it's bad to have the high intensity? Is it only for disease or affected people, the low vibration like fracture and then osteoporosis, or how about normal people
Yeah, I
without
think
any issues?
so I think if you categorize um, low intensity vibration is really therapeutic. High intensity is more exercise. So if you're a younger athlete that's looking for more power, so maybe somebody playing basketball who wants to jump better or running faster, power plate or a product like that is very useful because it strengthens you and you're already quite capable person. But if you're 75 and have a minus 3.5 T-score, and you're at risk of falling over, then probably it's too powerful. So that's when you would look at something like a Maridine or a Juvent. If you've got increasing frailty or you have tissue degeneration, then that's really where it begins to be useful. I'm not advocating fracture management. It's not a cleared device in the United States for bone integration. It does do it. But what it does is give the physical therapist and the rehabilitation specialists another piece of equipment that you can use with people that are maybe recovering after surgery or who have got fall risk, where you can use this safely. Low intensity isn't yet investigated for neuromuscular degeneration conditions, like Parkinson's or some of the other rehabilitation challenges that you see. High intensity has been, but at low frequency. So a big magnitude acceleration at 5 or 10 times a second versus 30 times a second is perfectly reasonable because it doesn't pose a risk. If you're then using a big magnitude acceleration at 30 times a second, you're running the risk of percussive injury to the brain, amongst other problems, right? So I think for clinical providers, you need to have a sort of a quadrant which says risk, safety, clinical indication, and then what am I trying to achieve with the patient, and choose the appropriate product based on the patient's circumstances. So areas we don't have any proof and where we stay well away from: women that are pregnant, and generally, I think in the older population, you can look at frailty or risk in the individuals. Some people do get affected negatively by low intensity vibration because it's quite quick and fast. If they've got inner ear problems, maybe these little crystals that you find in the ear, it might be antagonistic. Individuals that are maybe hypersensitive, have dizziness or problems associated with that, maybe they've had past neurotrauma, then it possibly is going to be antagonistic. But 95 to 98 people in every 100 are going to use a low intensity vibration plate without any real challenges at all. And most of them like it because it's quite pleasant. It's not unpleasant.
Good to know. Thank you so much, Ian. Because we have many like high intensity vibration right now. So at least you emphasize that these are more on therapeutic. This was more on strengthening. But overall, vibration therapy is very good, especially for our aging and older adults, for osteopenia, osteoporosis, and sarcopenia as well, for with all those evidence base that you shared.
Jenny, I'd just like to say that the CDC recommends low intensity vibration as an intervention for fall protection in the older age group. And I think that's not really well known. So
Yeah.
I think
Thank you.
as yourselves, as specialists interested in the older age group,
Yes.
you need to look at it and think, yeah, can we deploy this? Because individuals need it every day. So that's going to be the challenge, depending on where they are, You can't just go and use it twice a week like you can do a high magnitude vibration plate. You need low intensity every single day. And in the older age group, probably twice a day, 2 times 10 minutes.
You say about the skilled nursing facility. How about the assisted living facility?
Yeah, absolutely.
Because I think that, but you emphasize, do you need a script for them to
Oh.
participate? Okay, so that will be more an ed for the school. All
Yeah, and then
right.
for
So
medical
this one can
providers,
use.
if you're using it, you can use it for, neuromuscular re-education.
Yes.
You can use it as one-on-one physical therapy intervention. So if you're using CPT codes like 97110, 97112, they're appropriate if it's one-on-one. A lot of practices now, it's cash use. I think for locations, though, definitely elderly facilities, if they've got a gym, then they ought to have a low intensity vibration device in there that people can use. So if there are community based facilities, then this is actually very helpful because it helps with circulation as well. It will help with stasis and clearing fluid from the lower extremities. So if people are more sedentary, it's a very safe, easy exercise that's going to improve their tissue, and it isn't a big challenge for them to do. And if you've got bad weather like ice and snow and cold weather where people can't go out as much, then live is very easy to do, and it gives them something that they're not getting in their normal ambulation. So
Good point.
more we can learn about it and utilize it, I think it's a good thing.
Yes. So guys, if you have any questions about the the vibration plate itself, just connect to Ian. Ian, on the sample, it shows a standing frame where they can hold it,
Yeah.
right? So they're standing. Is there like a sample that the wheelchair or they can sit or something like that?
Yeah, we can't use a wheelchair, so the Maradines and the Juvents, you need to stand on them, and they note that there's a load on them, and then they accelerate matching the load on the device. So they need a loading footprint from a standing person. So a high magnitude plate, sometimes you just turn it on and it moves. So you can rest your feet on it, or you can sit on it, or you can do other things. But with the low level vibration plates, the Juvents and the Maradines, they're designed to match the dynamic load and create a constant acceleration into that standing person. We just sell the stand initially if somebody's had, say, a surgery or they're more unstable, then they've got something to hold. Generally, people just buy the Maradine and stand on it, and it's a free standing item. You might have it next to a countertop or a table or a high back chair or something, but you can stand on it perfectly safely, and it's not going to cause any problems for you. So it makes it very portable. They only weigh 9 kilos, and they're easy to move about. So for individuals or for care providers, they're very easy to work with.
Thank you. All right. So, Ian, just kindly put your email in our chat. Definitely, if they want to connect with you, I know you showed it already on the PowerPoint as well. Thank you so much. Also,
Thank you.
Ed, thank you so much for this interesting presentation. I want to emphasize and highlight that you emphasize is a biofeedback. And we as clinicians, it's true, we have lots of compression fracture. We have lots of aging and older adults who have fallen, and then I'm now in acute setting. So I see more and more with that. And I don't see much of the Spinomed being used. We're still on the whole like compression brace, the traditional brace that is very tight. And I feel that they're really close more on, and that can add if it's continued how many weeks they will use that. Some of them are 6 to 8 weeks, like with those like spinal percussion, so that can add some of the weakness on their core group. So but your spinomed, you emphasize that it will strengthen the back extensors and everything. Is that that's why you model it that way, the bio feedback of the brace itself? I miss, oh, Ed, I think the signal. Yeah, I think I lost Ed, but that's really good how the Spinomed looks like.
Reimbursed for another TLSO for 5 years. So it's important consideration. If they previously received a TLSO that's a couple years old, then we've seen positive results in petitioning or appealing a decision on those. But Medicare guidelines, one TLSO every 5 years. So that's an important consideration when you're thinking about how to work with a bracing product on these patients. But just a real quick summary on what I said that you might have missed. The Medicare guidelines for TLSO, TLSOs, I just put it that way. If you've received one TLSO, you're not going to be able to receive another one typically for 5 years. So if you've been braced in something that is really restraining, you may have a little bit of a battle to get a Spinamed covered after already having received one of those more restrictive braces. So it's a consideration to think about the Spinamed before you actually order that first brace.
So that's really important. It's just like a DME that you
It is.
cannot order within the 5 years
Right.
plan. All right. Thank you so much, Ed. You put also your information here,
I do.
right? I believe so. Okay. Thank you, guys. I appreciate you. Sorry for this short, I was out, but definitely this is really interesting. We emphasize osteoporosis and then the different innovations for our musculoskeletal issues. Guys, if you have any concerns or more understanding or outcome measures that you want to check with Ed and Ian, connect with them, all right? So we'll take a short break and we will have Matthew as our next speaker. He's here already. We will learn more about neurostimulation using the dolphin. I heard it before, but I want to really want to learn more from Matthew, and I spoke with Dr. Bruce at one point. It's only 30 minutes, it's not enough, and I was surprised with how many things it can be used. And Matthew will just show us some few things of its benefits. Thank you so much, guys. All right. Appreciate you, speakers. All
Thank
right.
you.
It's
Thank you,
my
Jenny.
pleasure. Yes. All right. Let me see quickly. We'll go back to our, just to have like our here. So we can show our, all right. So this was our speakers. Thank you so much, Ian. Thank you so much, Ed. And Phoenix Hipware, I appreciate you, Natasha. She is also one of our sponsor in the recent geriatric rehab summit. So Phoenix Hipware is our innovative hip protection, gives you the confidence to keep moving, knowing you have a better chance of getting back after a fall, so you can keep living the life. So it's a hip protector. It has protective shields with layers of high performing latest structures and very comfortable. Nobody even knows that you're wearing it, and very flexible. It's a 3D format and very lightweight. Compared to some hip protectors, it's like a padding. So this is really nice. All right. So we will have a break before we have Matthew to introduce. Matthew will be discussing the neuromodulation for pain, concussion, and recovery using the Dolphin Neurostimulator. After a car accident sidelined his career, Matt discovered neurofunctional techniques that transferred his recovery and inspired him to help others. He is now the founder of Body Science Therapy, Performance, and Wellness in Ontario, focusing on root cause approaches for lasting physical and mental health. I miss that part that this was in you're in a car accident, that's why you have this passion. All right. That you're a better example because you experienced this and you know that it worked. And is this in Ontario, Canada? Matthew, you're in
Yes.
Canada?
Yeah, we're near Toronto. Yeah, near Toronto, Ontario, Canada.
Yeah,
Yeah.
just like
Yeah.
Bruce.
Yes. Yeah, very close. Yeah.
See, I told you we are all over right now. I'm from Delaware, Matthew. I know we first
Fantastic.
met.
Yeah.
Yes. And we
That's great.
have a short break, okay? And I know
Perfect.
you're ready, but
Yeah,
let
no
me
problem.
see.
Take your time.
We'll just take a short break, most probably 5 minutes, because Matthew is here. If you want to use the loo or restroom, definitely, okay? And then we have, all right. Thank you, guys. Okay, let's take a few minutes break. And definitely, this is also one of our summit. Just want to share with you. I appreciate all of you joining right now. This is a free because of our different sponsors who supported us during the Geriatric Rehab Summit. And definitely, I really want to connect with different technologies and innovators. So it's a fundraising event. So Future Foundation Global, I am the treasurer and a part of proceeds of the Global Geriatric Rehab Summit and Innovator Summit. With those helps are we partly help and assist the Future Foundation. So Future Foundation Global, founded in 2016 by Dr. Kansi and Dr. Ben Aguila as an FAU NRMF alumni organization. So I'm an alumni of the school as well. Future Foundation achieved significant advocacy milestone. As of December 31, 2022, the alumni chapter concluded giving way to Future Foundation Global. So it is a nonprofit continuing its legacy of transformative programs and advocacy. So during the Future Foundation, we have two scholars. They're doing a doctorate of physical therapy. When we go back to Philippines, we try to do some like webinars to share the different knowledge and different courses to our Philippine-based therapists. And definitely, I tried my best to share always our summits to our Philippine-based therapists so they will be able to know more. What's the updates now in US space or globally, right? So thank you guys for tuning in. And once we have our break ended, I will give the floor to Matthew. All right? Thank you. So let I lost the chat. So the previous messages and everything. All right. So attendees. Okay, so some attendees. If you have any questions, guys, definitely connect there. And I'm not sure, Tran, are you still raising your hands and want to have some questions? If ever, just put your questions here on the chat as well. All right. So in 1 minute, I will put in pin.
I have a PowerPoint presentation. Should I start loading it
Yeah.
up? Yeah.
So you can play with it while they're getting
Okay.
ready.
Okay.
So we can see if it's doing well.
That's a good idea. Is that showing up?
Yes.
Yeah.
So
Can you
what's the
still?
time now there, Matthew?
It's 10:30 here.
10:30. Oh, we have the same time.
Same time.
Okay. Yes.
Perfect.
Mhm.
Yeah, that's a good question. You have speakers from all over. I think you have someone from
Yes.
Ireland and that. Yeah.
Yeah, our speaker, Dara, is from New Ireland. They're from
Fantastic.
Vertiginius. And then I have my colleagues from United Arab Emirates. I work in UAE at some point for
Uh,
5 years. I
wow.
don't see any of my colleagues in Saudi Arabia, but they are all over as well. But we have lots of physical therapists here based in US, and also lots of registrants. They're not able to come maybe live because they're aware it is recorded.
Oh yeah.
And we have also, now it's evening in Philippines,
Right.
and we have also in Vietnam. So I don't know the time in Vietnam,
Wow.
guys. Dang and Tran, you're still here. I think they are almost close to Philippines because they are Asia.
Okay.
So I believe so. All right.
That's
So it's
great.
10:30. Are you like 10:30 or 10:35? So I just want to be sure. But I can give you the floor so you can have more questions and everything.
Tran says
All right.
10:30 p.m. Thanks for sticking with us. It's
Exactly
getting
right.
close to bedtime.
See, so that's the
I look-
same. Ah, okay. Because in Philippines, it is 11:30. They have one
Vietnam.
hour
Oh
they
yeah. Oh,
change.
11:30. Yeah.
So now we are the same with Vietnam.
That's
I
my
only
bedtime for
change
sure.
it. Mhm.
Yeah.
We are morning and it's night in Philippines. I have my family there, so I know. Yeah.
Oh,
All
fantastic.
right. I'll give the floor to you, Matthew.
Okay, thank you. Yeah, thank you, Dr. Jenny. So, yeah, as the introduction mentioned, I won't spend too much time on my story and that kind of thing, but I will tell a bit of a story about how I got introduced to the dolphin neurostim. And if you can't hear me or have any questions, please throw it in the chat. So yeah, as the introduction mentioned, I was in a car accident after graduating from physio school. That was in 2013. I was going to try and show it, but there's a scar on my wrist here. I broke my scaphoid, had two surgeries. Conventional therapy, got me so far. And then I started to plateau. And it was around that time that I started looking for different techniques. I had been attracted to various neurofunctional techniques that involved addressing the nervous system as the root cause rather than more so looking at the muscles and bones and that in particular. I'd always had an interest in neurology. Like that's why I became a physiotherapist, was to work in stroke rehab. But then when I actually had my placements there, I realized I didn't enjoy it. But I still had this passion for the nervous system. And I really felt like that was at the root of a lot of what we're working with. So yeah, I guess the way that I was introduced to the dolphin neurostim was kind of funny because I own our clinic, Body Science Therapy, and one of our sort of things is that we don't really use modalities in the clinic. So you're not going to come here and see the classical ultrasound and TENS machines and IFC and stuff like that. So to be honest, if I just saw the dolphin neurostim online and saw like one of these units, I probably would have just kept going. I don't know if I would have even given it a chance because we were kind of anti-modality, let's say. But a friend of mine used it on me. So I sprained my ankle carrying one of my kids down a snow hill. And I sprained it in January 3 years ago. And it was still swollen after getting some treatment. And it was still swollen after maybe 2 months. And a friend of mine had learned the dolphin neurostim approach. And I thought, okay, let's give it a shot. So he used it on me. And the next day, I looked at my ankle and I was shocked to see how much the swelling had gone down. I was so excited that I took a picture of my ankle and I sent it to everybody in the clinic. I wish I had a before and after picture to compare because it was remarkable. And so I shared that picture with everybody and I said, guys, like there's something to this. Like we need to learn this. So I immediately started taking their courses, and the concussion protocol is what I'm going to talk to you a bit about today. So we're not going to get too heavy into the science, but a bit of background on the dolphin neurostim. So it's a microcurrent point stimulator. It's a direct current device. So as opposed to some modalities that use alternating current, this device uses direct current, and it's a very low intensity, low frequency current. So it's not like when you use electroacupuncture or some of the TENS machines that are going to cause muscle stimulations and you see the muscles contracting. It's not like that. It's much more gentle, but it's very precise. And it uses a frequency and an amplitude that's in the range that optimizes healing for the body. So we know that a small dose of current, so less than 1 milliamp, is going to enhance healing, promote ATP production, cell communication, blood flow, protein synthesis, all these good things. And if we go beyond that and start to get higher, we actually see the opposite effects. And this was a big eye opener for me because I had been using some of those devices for years, with electroacupuncture in particular. And then I learned that it can actually have detrimental effects on the healing process. And some of those devices can get as high as like 40 to 50 milliamps, where we want to stay less than 1 milliamp and even into the 500 microamp sort of range. So the dolphin neurostim, as I mentioned, it's about 2 hertz, less than 1 milliamp. You can play with the dial here to adjust your frequency. We try to stay in the middle around the 500 microamps level. I think that's where most of the healing occurs, but we do have some room to play with it there. And the other thing that was really sort of a game changer for me with this approach was the focus on the autonomic nervous system. So, in physio school, like we learn about it, we learn about some of the cranial nerves, and we kind of mentioned the vagus nerve is one of them. We learn about some of the sacral nerves, but really our education is focused on the brain and the spinal cord and the peripheral nerves, and which nerve causes which muscle to contract when, and what does it do, and what bone does it move, and that kind of thing. And so we had some awareness of what the autonomic nervous system was, but more so just in definition and not in terms of actual application in a practical sense of how to assess it and how to treat it and what can happen if we do assess and treat it. The way I like to look at the autonomic nervous system now is that it's like a reservoir of potential, because for so long in my practice, I've been practicing for over 10 years now, I may have been influencing it indirectly without even really knowing, but now that I'm actually looking at it, assessing it, treating it, targeting it, the outcomes are phenomenal. So here are some of the benefits of the Dolphin NeuroStim. There are all these studies listed here. You can go on the Dolphin NeuroStim website to really dig into the studies, access them there, take a good look at them. But it has very good effects on reducing pain. We see great reductions in pain even from the first visit. You can improve vagus nerve tone, heart rate variability, which we know is just so important and has actually been indicated as a measure of longevity and overall health. That's essentially our adaptability to external stimuli within the nervous system and cardiorespiratory system. One of my favorite things is the third bullet point here, releasing scar tissue. So as I mentioned, I had 2 surgeries on my wrist, and so I 100% have scar tissue here. And I'm just thinking about when my surgeon, who was absolutely incredible, phenomenal, like he told me at the second surgery he would go in and get rid of the scar tissue, which it did seem to be that way for a moment, but then more scar tissue tends to develop with more surgeries. So I've been treating scars for about 10 years now, and this is by far the most effective technique that I've been exposed to. But a scar discussion would be a whole other presentation. We also get enhanced cellular transport. We reduce inflammation. Like I said in the beginning, when I was treated with it and addressed my ankle inflammation, the effects, the reduction in inflammation by the next day was remarkable. And we can also regulate hormones, and this is a huge topic nowadays. And again, this is probably a much bigger presentation, but we know menopause is a huge discussion nowadays as well, and hormones are a big factor. And all of these are related to the autonomic nervous system. So we're not going to focus too much on the central and peripheral nervous system, but these are all linked to autonomics. As I mentioned, like as physiotherapists, we're typically not educated in a very in-depth manner on the autonomic nervous system. We are educated in an in-depth manner on the central and peripheral nervous systems, but we learn what the autonomic nervous system is, and it's kind of more just some awareness of it, but not exactly how to assess and treat it. And since I've been shifting to more of an autonomic nervous system focus, the results have been phenomenal. Like it's our kinesiologist made a joke the other day that we used to call her area in the gym the kin corner, and now she calls it the crying corner, because just about every week somebody's coming to her with a story about how much they've healed and how much we've changed their life. And we just had another one yesterday about their surgeon literally called what happened a miracle, and I don't think surgeons use that term too often in terms of a bone healing protocol. But it's just been amazing. If you can unlock the potential of the autonomic nervous system, amazing things happen. And there's also a very interesting study, I think it was done about 10 or 15 years ago, that concluded that 75 to 90% of all diseases that can related to that cause death are stress related, and the other 10 to 25% are more like trauma based. So we know that stress and ANS dysfunction is definitely affecting our health and longevity. So a few of the, here's some markers from the studies that I mentioned earlier. So here's some of the benefits of microcurrent point stimulation therapy in terms of pain management. And what's interesting here is you'll notice, there's various modalities listed here, and the MPS has the greatest effect. But what's interesting here is the low back protocol tends to do the best. We're going to go through pain, heart rate variability, and some other factors. And it's actually the low back protocol that tends to rank the highest, even more than the vagal stim. And the reason for that is because if we're thinking about the autonomic nervous system, we have to think about in-depth markers related to stress, things that can contribute to sympathetic upregulation, causing parasympathetic downregulation. So if we look at the pelvis, we look at the hips, we look at the sacrum, we look at the spine, we would like all of that to be nicely aligned, like your classic traditional chiropractic philosophy or osteopathic, because the body doesn't like nerve compression, right? Like we like when nerves are compressed, cortisol is released, and the brain doesn't know necessarily why the cortisol is there. It just knows it's there, and it's going to elicit an appropriate stress response in response to the cortisol release. So if we can normalize, if we can create some symmetry in the hips, the piriformis, the sacrum, the spine, decrease nerve compression, we get all these amazing influences on the autonomic nervous system, and which include pain here. And we can see on the next slide, ATP enhancement, which is just incredible, like 400 to 700% improvements in ATP production. And this is one of the reasons why people come in for treatment and they're like, oh my God, I can't believe how fast I'm healing. Like even post-surgery, like very quick rates of healing, like fracture healing. Like it's really, really amazing. I believe the next one is on HRV. And so, yeah, then the effect on HRV is just amazing as well. And again, we see the low back protocol at the top, and that's just because of what I mentioned earlier. If we can create some more balance in the autonomic nervous system, then things are going to function better. We're going to put the body in more of a healing state where it can do what it's designed to do. We just need to give it a little nudge and help it be in that healing state and keep everything nice and aligned. And just a little side note, I used to wonder, like, do we need to be doing things like vagal stim? Do we need to be doing these treatments? Like, aren't our bodies smart enough and designed to heal on their own? And I think the answer is yes, they are, but it's hard in just the way that our environment is designed right now. We have things, I'm not trying to fear monger, but like working against us, like there's things like pollutants in the air, the water, the food that create stress in our body. There's emotional stress that we don't have the necessarily appropriate tools to work through. And then we have the physical stressors like scars and sacral misalignments and jaw misalignments and nerve compression. And so I think it's really important to look deeply into these types of therapies that address the autonomic nervous system, because it's kind of hard when we have all these things working against us. So these are the primary applications. There's several of them. First, we have the pain management. So you can see a picture here of someone applying the dolphin neurostim to acupuncture points along the spine called shoe points. And depending on what protocol you're looking at, what the patient's complaint is, you'll apply the MPS into different areas of the spine here. That's similar to what you would see with like a low back treatment, except obviously it would be a little lower. Then we have the scar release. We could do a whole other presentation just on scars. It's phenomenal how much scars impact the autonomic nervous system and can contribute to things like autoimmune diseases. And I say that with confidence because I've seen resolution of some by treating scars. And then the vagal stim, which is great as well. And you can see here, the lady in the picture has the vagal stim clipped onto her ears. So I often recommend my patients buy the unit so they can use it at home. Some of them are surprised because it means probably less visits to come see me, but I think that the outcomes are just that much better if they can do the therapy at home and stimulate the vagus nerve directly after we've resolved some of the issues that are down-regulating the parasympathetic system. Then it's time to stimulate the vagal nerve and try to boost it back up. These are some of my favorite applications. So we have the sensory balancing. This is another one that people can use at home. I know this reference is probably going to be outdated soon, if not already, but I feel like Gumby after doing the sensory balancing protocol, putting a pad on the neck and the feet as you see in the picture there. So what's happening there is we have the pad on the feet. It's essentially applied to one of the acupuncture points at the feet, kidney 1, and then the microcurrent is running up through the body to the neck, and it's circulating back through. And this is an incredible treatment for peripheral neuropathy, which is probably a bigger problem than we might realize. And again, people can do it at home, which they just love. The pelvic floor portion, I'm just getting introduced to that myself, but even that being said, I've treated some of my wife's pelvic floor issues through doing actually the same protocol that I'm going to explain later today for the concussion protocol. And my wife had been going to a very good pelvic floor therapist. She used to work at our clinic, very highly trained, very reputable, in high demand. And her symptoms would fluctuate. They were definitely better, but they would kind of go up and down. I did the protocol and some of the pain management points, the protocol that I'll explain later, and the pain management points, and it just knocked it out, gone. Even with many sorts of aggravating factors. No, it did start to creep back a little bit later, but I think that's because after you do the therapy, you do need to like strengthen the muscles and sort of rebuild strength in tissues that had been compromised for some time. But it was, it was amazing. And then we have the concussion and brain recovery. I could tell many stories about that, but I'm just going to tell one today. And that's what we're going to get into in a few minutes. So yeah, as I mentioned, I own a clinic called Body Science Therapy, Performance and Wellness. I've always been interested in the brain and root cause healing. I didn't like what I saw in some clinics when I first graduated from physio school in 2013, where it felt like patients were just coming to the clinic to do exercises and get put on machines, and I didn't see the value in it, to be honest, and I was a little turned off from it. And again, that's why if I had seen this device just online or something, I probably would have passed it right by, because I'd say, no, I'm not that type of therapist. But no, it's a very deep-rooted root cause approach. So this is a picture of our group here. Our kinesiologist is hiding in the back there. She's the one we call it, she says she works in the crying corner, because she helps me out with treatments, and we just see some amazing things. But we generally treat orthopedic conditions. We do treat concussions, which I'll talk a bit about. Pelvic floor is something that's gaining popularity within the clinic. We now have a clinician training in pelvic floor therapy. We do get some neuro cases as well. It's mainly because of the type of treatment we do, though. Like, we're not necessarily like neurophysiotherapists who are trained in necessarily like stroke rehab techniques. So we always encourage people to continue with those outpatient clinics. But when they come to see us, their effects of treatment are enhanced, and they do get better faster. And in general, we get the difficult to treat cases. It's, pretty much every week we're hearing you're my last hope and that kind of stuff. And it's amazing when you can actually give those people hope. We just heard that story again yesterday too. So the day my practice changed was when I had the ankle sprain and was treated with the Dolphin Neurostim and saw the effects, and I was just amazed at them. And that was one example of when my practice changed. And I started taking the intro course and learning the basics of pain management. And then I took the concussion course, and I was talking with a friend of mine. So I play hockey a few times a week. And I was talking to one of the guys I sit with in the dressing room, and he was talking about his daughter who had a concussion 2 years ago. Actually, she had 5 concussions within 2 years. And at this point, when we were talking, it had been 2 years of her going through different therapies. And sorry, I'm going to try not to get emotional with lots of different therapies, and she just wasn't getting better. And, I said, okay, I'll give it a shot. Like, let's take a stab at it. So her main symptoms were, the classics, the headaches, dizziness, vertigo. The dizziness, vertigo was a big one. It was, I would probably say, debilitating. Light and sound sensitivity was really affecting her quality of life. her and her dad are big hockey fans. They had a tradition where they would go to the Toronto Maple Leaf games every year together, and they couldn't anymore because of the concussion symptoms and the sensitivity. So that was definitely affecting her quality of life. She's a teacher, and so she had to take a year off work, so she wasn't working, wasn't doing the meaningful things in her life, and it was really impacting her. So there's always the mental emotional component of post-concussion syndrome. She had cervical issues, as you see listed below, hypertonic C-spine, restricted C-spine joints, and then the fatigue as well. So upon examination, we found some of those things. The VOMs and the VOR, like the concussion testing, increased her symptoms. The Buffalo concussion treadmill test was positive. So that's where we put them on the treadmill and see if that stimulates more symptoms, which it did. So based on this assessment, the plan was, okay, let's target her cerebrovascular system. So, she's going to do the sub-threshold exercise training, which means when we do the Buffalo concussion treadmill test, if your symptoms come on at, a certain heart rate, then you train at 80% of that heart rate to allow your system to accommodate and acclimatize to it. But it wasn't working. Treating her neck, as I'll get into, helped the headaches, but her dizziness was actually getting worse. And sometimes she would come for treatments. I'm not talking about dolphin neurostim, I'm talking about other treatments we were doing. Sometimes she would come for treatments and she'd feel worse for like 3 days, a week after. And we were doing some eye retraining as well. So the first goal was to get her back to work. So we tried all these things. We were trained in complete concussion management. She had so we were doing physiotherapy, chiropractic, massage, electroacupuncture, different muscle testing techniques to treat receptor dysfunctions. She had been to a naturopath. She had tried functional neurology. I'm not sure exactly what that meant in her case. I think sometimes it's a lot of different eye movements and nerve stimulations. And I put the money up here just because so her dad and I still play hockey together, and when I see him and we sort of reminisce about this, he always mentions the money. He mentions that he just shakes his head, like she spent so much money over that time, those few years leading up to our treatment with the dolphin. I think I listed about everything there. We tried some vestibular techniques. The cerebral means the cerebrovascular blood flow. And then we got the psychological. So she had tried a lot of different approaches. And in physio school, we don't get a ton of education on concussions, at least when I was in there. It was which was 2011 to 2013. I think we essentially had like an afternoon lecture on what a concussion is and, refer to an MD sort of thing. So as I mentioned, she was getting treatment at our clinic, seeing myself, our chiropractor, our massage therapist, and the headaches were getting better, but overall the recovery was kind of up and down. Some symptoms were still very bad, particularly the vestibular symptoms. She was telling me, I remember at one treatment, she said she just moved a rug as they were rearranging furniture in her house, and that was it. That set her off, like vestibular issues for days. Sometimes she would get dizziness aggravation from our treatments. So I thought, okay, I got to try something different because this isn't working. I just completed the Dolphin Neurostim concussion seminar, which is focused on targeting the autonomic nervous system to improve brain healing. And there's all these different points that you see listed here. We're not going to really get into all of them, but it's just here for awareness. And one stage of the protocol is to treat the liver. So I thought, all right, let's give it a shot. Like, I'm not sort of prejudiced to any treatment technique. It's just got to work. I thought, let's try this liver cooling and balancing thing. You see the liver balancing points listed in the picture here. So when they explain this step in the course, they explain how in Chinese medicine, there's different elements involved, right? There's 5 elements. We have fire, earth, metal, water, wood, and they all are related to different organs and systems and things like that. And we have different ways to stimulate them through the body using, traditionally acupuncture, but we can stimulate them using the dolphin microcurrent. So the approach here is focused on the liver, and if the liver gets too hot, the liver's wood, and if it gets too hot, it heats up the heart. And in Chinese medicine, the heart is essentially the center for cognitive processing and decision making, and what we would typically think of as like the brain functions. And I remember actually, as I was preparing for this presentation, that I had done a project on ancient Egypt when I was in like grade 2 or something. And I remember them saying the same thing, that the heart was actually valued more than the brain. And to the point where when they're doing mummifications, they take the brain out and they actually might take the heart out and mummify it and then put it back in because it was so much more valued. I remember thinking that was so strange at the time, but it stuck with me. So that's essentially the thought process here, that the liver heats up the heart and the heart is the way to the brain. So I applied the liver cooling and brain healing protocols, and immediately the dizziness improved. And I thought, that's very strange. I didn't even touch her head, right? Or neck. In fact, when we did, it made it worse. So I did the liver cooling, the dizziness improved. So I thought, let's keep going. So I kept going with the brain healing protocols. We did the sagittal suture along the top of the head. We did Jing points, which are points in the fingers and toes. We did auricular. There's battlefield acupuncture in the ear, and something called a nervous system reset. Then the patient comes back, I think it was a few days or a week later. She said that night she did feel tender on the top of her head. She kind of felt like things were changing. And then in her words, she woke up the next day feeling perfectly fine. And I thought, this is wild. Okay, let's keep going. So then we did more sutures. There's several major sutures in the head to treat. We treated the hips and back. So as I mentioned earlier in the presentation, if we do the protocol that addresses the hips and back, it really helps to balance the nervous system. So this just enhanced things more. So we treated the hips and back for her concussion, which I never, ever, ever would have considered in all my training. And then she said, head-wise, I'm feeling good. The approach is working. So we were getting real results. And we actually ended up working on other stuff, just like a rib that would go out from time to time or that kind of thing. And this is what really struck home for me. That's a picture of Courtney and her dad. Her dad's the guy I play hockey with. And he came over to me in the dressing room and he said, I just got to thank you. And I said, why? He said, you gave me my daughter back. And that was like a really moving moment for me. Guys don't usually talk that way to each other, let alone in the hockey dressing room. So he really meant it. And he still seems thankful to this day. So this is a picture of them after all the treatment and after she was recovered from the concussion. And this is them at a Toronto Maple Leafs game together. So they could go back to their yearly traditions of going to the games together. So it not only, and that's when I also realized, like, it wasn't when we're treating people, it's not only about them. Like, there's a bigger effect that happens too, because now his quality of life is restored as well. He can have that father-daughter time back. So it was just a really big impact that I'm really grateful to be a part of. And then this was amazing too. I get chills. Like, so Courtney was here a few weeks ago doing a testimonial with us, which Dr. Bruce and his team will have available shortly. But we have a whole video of Courtney and I sitting down together, reminiscing about this whole process. And I didn't know this until 2 weeks ago, but she actually she wouldn't start a family. She couldn't start a family until the concussion was resolved. And it wasn't until that we treated her and she got back to normal that she was ready to start that part of her life. And I never knew that. And that was just such an amazing thing. So her family plans, life plans were paused. And after the concussion therapy, she now is conceived. And that's her baby there. There's a picture of them in the clinic when she came to do the testimonial. Her husband, Ryan, her baby, Wesley. And there's something I was going to say, but I feel like a little off track talking about that. So it's just been a really amazing experience, and her quality of life has been changed drastically. And so this was a huge experience for me, and I just thought I would take the time to share. Oh, that was the other thing. When as I was telling this story to our team, I kind of had my head down, just focusing, recalling information, whatever. And I looked up, and a bunch of them had tears just rolling down their face because they had seen Courtney and her baby that day, but they didn't understand all of the connection and the process and what went into it. So yeah, so that's all I have to say based on the presentation. But I'm an open book. I'll do my best to answer any questions that there are. If not, I can throw my information in the chat, and I'm more than happy to either connect you guys with Dr. Bruce and the Center for Pain and Stress Research, or answer questions myself. So thank you for taking the time to listen.
My pleasure. So we have you until 11:20. So if you want to add more information, feel free. But guys, if we can go back, Matthew, on one of the slide of
Yeah.
the you're trying to
Which one?
increase. There's a graphic of
Oh.
increasing the ATP.
Mm-hmm.
Yeah, the benefits of the MPS therapy, or is it the point
Yeah, MPS,
stimulator?
microcurrent point stimulator. Yeah.
Okay, microcurrent points. So there is an ATP enhancement, and
Mm-hmm.
then there's also an increase in HRV. Can
Right.
you emphasize why it's important? What is ATP first, the adenosine
Got
triphosphate?
it.
Why it's important, and why it's important to enhance those both
Yeah, that's a
for
great
us? Yeah.
question.
Thank you. Mhm.
Yeah, no problem. So as you mentioned, the ATP, the adenosine triphosphate. I mean, if we think back to maybe undergrad for many of us and some postgrad stuff, that's essentially like the energy in the body, and we need the ATP to, break apart into the ADP to help stimulate the energy production cycle, which is required for healing. Right. So if we don't have enough ATP production, then healing will be delayed or, just kind of slower. And more ATP is going to lead to faster healing and better healing. And I think probably just even better overall vitality.
Mhm.
And then the HRV is something that seems to be talked about more and more. So that's heart rate variability. So the heart rate variability is the ability of our heart rate to adapt to, or sorry, our
Mhm.
cardiovascular nervous system to adapt to different stimuli. So we don't want to look at a heart rate and see that it's just the same heart rate all the time. It should vary a little bit based on what we're doing, right? So for example, when we're performing some exercise, we want to see that when we stop the exercise, our system can adapt and kind of calm down and come back to a baseline. You might also think of it as like a homeostatic response or
Mhm.
a system through the body.
Yeah, so
Yeah.
that's really cool because I'm not always focusing on that, you know. We just know more
Yeah.
on like the better heart rate, but we, especially in cardiac rehab, they are
Mm,
very focusing on increasing that heart rate for the max heart rate, and then,
yeah.
but it is really good to know that the MPS or microcurrent point stimulator
Hmm.
therapy affects that itself, and now we need to
Yeah.
focus that the higher the heart rate variability, the greater the stress, and the resilience they have.
Right.
And yeah, it's like
Yeah.
another, although we know heart rate already as a
Yeah.
vital sign, but it can
Right.
add as another like a vital sign
Yeah.
indicator for us.
It's
Yeah.
almost like a functional application of a vital sign or something like that. Like it's a very good measure of your overall, like adaptability. And I've done some protocols. I treat a couple of athletes, professional, semi-professional, and I've seen it too, where when we're doing this regularly, they recover so fast when they're training. Like they don't get as much of the muscle soreness. They can progress their exercises faster. Like the adaptability of the nervous system just, as you see, greatly improves. So yeah.
So when we have Matthew, when we got the dolphin neurostimulator,
Mhm.
we have also like a book with all the different points
Yeah.
or neuro.
Yeah,
Yeah,
it comes
because
with
I
a few
remember
different
that.
books. Yeah, so it comes with a video about how to set it up and apply it. And then it comes with different books with protocols. So there's one book with like protocols for ankle pain, neck pain, headaches, menstrual
Mhm.
cramps. The menstrual cramps protocol is so effective. Amazing. I've done it
Menstrual.
on it. Yeah, we have some like younger girls working at the front desk, and
Mhm.
some of them told me about the bad menstrual cramps they get, and I've done it. We're 2 for 2 on resolving them, and it generally lasted about 3 months. But like two of them said they had brutal cramps where they'd be bent over in pain and that kind of thing, and gone. So it's there's so many applications for this technique.
Mhm.
It's yeah.
Yeah, you have many applications, right? But in your
Hmm.
practice, what's the level of your application? Is it more on scar, concussion,
Mm.
or like and then a little bit one I got already this wonderful story. I can picture it already. We always have lots of wins,
Yeah.
right? But we always have like a particular that we always share. But with
Yeah.
all those stories that you have, like how you categorize like these are majority are scar. You said you're learning more on the pelvic, but how about your clinic?
Yeah.
What's your
Yeah.
average?
So it's mostly the funny thing is pretty much like no matter what someone comes in with, I'm like hunting for scars to treat first.
Mm.
So the scars are so influential on our nervous system. We can see very big decreases in cortisol levels after treating scars. We
Oh,
see
okay.
immediate changes in fascial tension. And the amazing thing is the widespread effect through the body. So not only through, hormonally through cortisol, but you can see it electrically. I mean, see it electrically is a funny way to put it, but you see like muscles get stronger within the session. You see fascial tension releasing, and you can palpate that through a few areas in the body, like the shins and head. And so the ironic thing, and I don't know if it's ironic, but like when if somebody comes in with a concussion, I might actually look for scars in their body first because the scar tension from, let's say, a C-section is gonna like pull if my shirt is the scar, it kind of pulls on the fascia. Sorry, if my shirt is the fascia, the
Mhm.
scar pulls on the fascia and can pull all the way up to the head. So old traumas can create current tension in areas like the head and neck, and you add a concussion onto that, and it's just compounded. So sometimes, actually, most times, I'll actually go for the scars first to start relieving tension, help to balance the autonomic nervous system because scars will add more stress and put you in this sympathetic response, just that response at like
Mhm.
baseline, start to balance it out, and then start going through like the liver cooling and the sutures in the ear and stuff like that. So the scar treatments have been phenomenal. I mean, if you want, I can just go through more stories, but if you have any other questions, I can do that too.
Yeah, this is new to me, especially the liver cooling term. Like the heart is the fire.
Mm.
I just know that heart is like a muscle, very
Yeah.
muscle organ that we need to
Yeah.
strengthen.
Right.
I explained to them that's why aerobic strengthening, aerobic
Hmm.
stamina, conditioning. But
Yeah.
you have a certain language that
Mm.
liver that we will
Good
learn
point.
more on the when we learn more on dry needling and acupuncture you mix it
Hmm.
because as
Yeah.
you talk about the fascia itself and
Yeah.
if people will learn more about the fascia itself once you have it's like anatomy train we're treating like
Yes.
the patient comes because he has a knee problem,
Yeah.
but as a therapist, automatically you will treat the knee. But if you learn more about this because you
Yeah.
have more background, I think you're also a chiropractor. I see. Is
Oh,
it?
I'm a physiotherapist, but
Ah,
whatever.
okay,
Yeah.
okay. Ito ay DC. No, I saw a DC. But
Oh, okay.
when you learn more about this as a background, you're
Yeah.
very seeing them holistically, deeper
Yes.
dive
Yes. Yes.
that like what
Yeah.
you said, you're looking for a scar, but they came from a
Yeah.
concussion. That's now
Yeah.
how you deal, which is
Yeah.
really interesting, which is good.
Yeah. Yeah. And the
And
nice thing was, sorry, did you want to add something?
yeah, 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 go
Like,
ahead. Mhm.
like I had, as I mentioned, like I had been practicing a lot of different techniques before the dolphin neurostip, and that was because of the injury to my hand. So I had been exposed to techniques that clearly showed that if I treat somebody's ankle, like their hip can get better, or these and maybe even further reaching sometimes. So I was already seeing those sort of effects, not to this scale, but I had seen it. So when the dolphin neuroserum was introduced to me, and this concept of like, oh, I can treat a scar on someone's elbow and their core strength can get better. Like that was not so far-fetched for me. I was all in on that. I think the challenge sometimes is when, you meet a patient for the first time who isn't familiar with this way of thinking and maybe wasn't referred by a colleague or a friend, and they just kind of come in off the street, and I'm like, hey, I know you came in here for your concussion, but I want to treat that scar on your shin. And they might be like, hold on, let's back up a little bit. But the results are there, and to this point we get so many friends and family referrals because of what we're doing, that most people just come in and they're like, hey, I heard what you guys are doing is great, just do your thing, like do whatever you want. So in those cases it's great because they already have a trust with us, and we already can just jump into this very holistic approach. And to your point, you're absolutely right. I think one of the challenges probably for new practitioners is getting comfortable with the language of, like a liver meridian, and then the philosophy of like the liver can affect the heart, and like, wait, we're treating the heart for like cognition and stuff like that, right? But yeah, I mean, it's got to work, right?
Yeah, and this is a lot to talk about because you just specify just in one slide you have more than five benefits of that. And
Right.
this is
Yeah.
only a one tool. This is just a small one tool, but there's lots of benefits. And if we
Yeah.
as a physical therapist add it on as another tool in our
Yeah.
toolbox, this is really amazing because I
Yeah.
always try different courses. I always emphasize this in my course summits. Like I'm an educator, physical therapist, but I always emphasize the new clinicians, students, and new therapists that we need to invest in
Yeah.
ourselves. That's
Yeah.
why I always attend courses. I am an advocator of educational summits and
For
made it
sure.
affordable to different countries or globally because
Amazing.
once we learn more,
Yeah.
like now I'm learning from
Yeah.
you. I'm always listening to all the speaker. I'm learning from you. Then once I learn something, I applied it to my patients, right?
Yeah.
So
Yeah.
who
Absolutely.
are the beneficiaries? Our patients.
Yeah. Yeah. And their families, right? Yeah.
Exactly. And
Yeah.
then a
Yeah.
good win for us because they appreciate that and then
Hmm.
are we're just going home with another win. And then
Yeah.
sometimes it affects us when we cannot really see how can I treat Mrs. Smith?
Yeah.
Like
Yeah.
you always thinking how can I help her more, which is really very good
Absolutely.
that we have this thing. Thank
Like
you so much,
yeah,
Matthew.
no problem. No problem. And thanks for hosting this, Dr. Jenny. I really appreciate
My pleasure.
it.
Please, try to put your information there,
Yeah,
Matthew,
absolutely.
on the chat as well. And then definitely they will connect with you. And I appreciate you joining us live from Canada. I
Yeah,
told to Bruce that I was in Victoria at one point and Vancouver. Never been in Ontario though. But definitely, guys, if you have more questions to Matthew, connect with him and you can ask more, then they can definitely connect. And then if you have any questions about the dolphin stimulator, connect with me and I can check with Dr. Bruce and Matthew, all those connect with you with the team and Het All right. Thank you
perfect.
so much, Matthew. And we
Thank
have
you.
also, we learn from you. We appreciate great learning every day.
Awesome. I'm
Any closing remarks, Matt?
I thank you for having me. I'm an open book. I've been so moved by this therapy. I have more stories to share. So if you wanted to do, if anybody has questions, if you want to do another chat, I'm more than happy to do it. And yeah, just happy to help try to change the world in any way I can.
Yeah, I'll definitely invite you with a podcast so we can
Oh
chat
yeah,
more and then your
fantastic.
stories too. I
Okay, sounds
appreciate
great.
you. Thank
Thank you.
you.
Thank you. Thank you,
My
everyone. Bye.
pleasure. All right. So thank you so much. I really that's usually the win, guys, when you're doing you invite speakers, you invite experts, So we have, thank you so much, Matt. And then we have Bill today for our next speaker. We will learn more. Let me see. All right. So Bill is DAPT is the co-founder and clinical lead behind Web FCE. Thank you for Web FCE for sponsoring us for the recent Geriatric Rehab Summit. So it's a web-based platform for functional capacity evaluation or fall assessments with nearly 4 decades of physical therapy experience in Pennsylvania. He specializes in functional capacity evaluations, work injury rehab, and evidence-based assessment. So, drawing on years on clinical testing and practical insights, he helped design the Web FCE, and the FCE is more accurate and affordable. So, we have Bill today, and definitely we will learn more about it. All right. I made you as the co-host, Bill. You have the floor. You're still on, what do you call that? You're muted, Bill, just to be sure. I don't know if you're speaking. But we can see your
There we go. Can you hear me now?
Yes,
Okay.
I'm thinking you're talking, but I can see your PowerPoint, and then you're good to go if you're ready.
All righty. So yes, we are a web or based internet program. We do several assessments, as Dr. Jenny mentioned, with occupational testing, health testing. We do fitness testing. We do performance testing. We can be used in a wide range of medical areas. The physicians use this, physical therapists, occupational therapists. The one I'm going to show today is our fall risk assessment. Now, this was initially based off of Michelle Lusardi's study in 2017. She was the geriatric head of the APT at the time. And basically what she did is she looked at 2,300 abstracts, and from there, she narrowed it down to find the different areas that will determine a person's probability of falling. And she looked at 3 separate sections. She looked at the medical history, the outcome questionnaires, and performance tests. Now, any therapist knows, or even physician, that there's plenty of assessments out there in each of those realms with medical history, with outcome questionnaires, and with performance tests. So what she did is she looked to find the ones that were the most accurate and precise in determining the probability of falling in a 12-month period. Okay, so she did a very rigorous study. She narrowed it down to 300, and from there she narrowed it down to 12 items. Essentially, there was 5 medical history questions that you see here, simply yes or no. 2 outcome questionnaires, the Falls Efficacy International and the GDS-15, Geriatric Depression Scale, and the 5 performance tests. Now, from these, the studies, the people had to have pre-test probabilities, post-test probabilities. They had to have people that did fall and people that didn't fall. And they had a certain number of patients that had to be involved in the study. So she took a very vigorous look at this. And these are the 12 items that combined that she used to determine the probability of falling. And behind the scene with these particular assessments is some significant mathematical algorithms that take the pre-test probability of a prior test, make it the post-test, and from the post-test, it's the pre-test. So there's a lot of math behind this, as simple as it may look, that when we actually called her and told her we did this, started doing this program for her, she was excited because we took something, research and actually made it clinically applicable and usable, and without taking up too much time. But however, it's not to take away of all the different things that are behind it. We do have the studies down here. And we've taken this since we've brought out this program, and we've enhanced it. Initially with her program, you had to do all 12 assessments And from there, you would get a probability of falling. Well, the first thing that we came across with questions from people who started using this is of the 5 performance tests, the Berg balance is the one that takes the most time. Okay. However, if they perform well in these other 4, there's really no purpose to do the Berg balance test. So the first thing we did was to make the Berg balance test optional. That is the one with the highest post-test probability. However, people performing well in these 4 items, there's no need to do that particular test. You don't lose accuracy with the test. The next option, what we did was then we allowed the people to choose of the 12 items, which items they wanted to use. So we came in here and we created protocols, of which the original, the APTSR5 was all 12. And then the APTSR4, that's without the Berg balance. But then we found people like different combinations of measurements. Some like doing both outcome questionnaires, some didn't. They found that some people didn't particularly want to fill out the depression scale. They felt uncomfortable, so they used just the false efficacy scale. So essentially, you can choose any combination of these 12 items and use it as your protocol for your given office that you're doing it. Okay, so once you choose a protocol, you don't have to worry about somebody else coming in doing testing. It'll take them right through the test initially. So if we go back, and this particular one, the APTSR4, is basically the questionnaires without the Berg balance. And again, it's 5 medical history questions here. As you answer these questions, you're going to see that the probability will change automatically. So when we're starting from scratch, it's going to give you a live probability assessment of that person's risk of falling as you answer each question, as you do each outcome questionnaire, as you do the performance tests. And of the 3 areas, of course, the performance tests are the most important because they're the ones actually assessing functional ability. So when we get to the other measurements, we have the GDS-15 and the false efficacy scale. Now, you can take these, you can have them fill them out on a tablet. It will automatically score them. Leaves you area to make any comments if you want to. You can either print it out in English or Spanish, have them fill it out, and then enter it yourself. And we actually have a third option where you can actually send this through a portal. Okay, I want the false efficacy, I want the medical history, I want it in English or Spanish. I can send it to their cell phone or email. And when they fill that out, these areas, the 5 medical history questions, the falls in this case, will be automatically filled out. So that part of the test can be completed before the patient even comes in. If it's a more higher assessment, if you're in assisted living, you simply can do them in there, one-on-one with the patient. Now, the measurements themselves, there's 5 of them. So, for instance, you're going to go into the 5 times sit to stand. It's going to show a little picture of it. Okay, it's going to give you 1 to 2 trials of it. And it's going to give you their rank according to their age and sex. Okay, when Michelle did her study, she assumed a 30%. And then from there, what's your risk of falling based on your performance of one of these given tests? We took it further and we got the norms basically on a 10-year spectrum. So in your 50s, in your 60s, in your 70s. So we made it a little bit more accurate because we're comparing it to actual age groups. And essentially, it'll give you a percentile rank. It will give them a basic functional category, the deficit from the norm. And as you're testing, it's always going to give you the norm here. And it's going to give you a fall risk, either low, high, or increased. And it's also going to show you the cutoff. And the reason that we show the cutoff here is if this person, once they're over 12 seconds, okay, the probability of falling is increased. Now, if they're way under the probability of falling, then there's no risk for me to do a second test because it's not going to change my probability. Or if they're way over it, there's no need for me to do a second one because I know it's not going to, the probability of falling is not going to change. So this way, by looking at this 12 seconds, I'm C is at 9. There's really no need to do another one because he's far enough behind, above or below the cutoff that you don't need to do the additional test. Now, you can always do additional tests if you want to. And it also gives you an area to make comments about that particular task. Another thing that we added to her particular study is the ability to check unable. Okay. The reason is this test is a test that maybe you tried. However, they weren't able to do the sit to stand. They just didn't have the muscle strength to do the sit to stand. Okay, so what it does is it drops it down to a 0.1 percentile rank and a 999% deficit. So it still gives you ability to calculate a probability for this person of falling with the addition of the sit to stand test, which is basically looking at your strength of your lower extremities. Now, the next time they come in, maybe they're able to do it this time, and you're able to get a measurement, a more precise measurement. So we do have that option in here, and we found that, especially with this one, that helps out with the people performing their tests. Because remember, initially you had to do all 12. So if you did 11 of them, they got to that 12th one, they couldn't do it. Initially, you couldn't generate a report. This one's allowing you to do it throughout. And again, as you click in each one of these, it's going to show you the procedure. So you never have to wonder, how do I do this particular procedure? Because you're going to make sure you do them right. They're simple tests, but you still have to do them correctly. And you can also see if they had a prior test right off the bat, how are they progressing with this test that they're taking? So it gives you a quick snapshot of each test when you're in there. Again, always an area to make comments if you want, pain, fatigue, dizziness, whatever it happens to be. And the ability to say you attempted it, but you weren't able to perform it. Now, once you perform all these tests, okay, it's going to give you an overall probability. So basically what this is saying is this person has a 58% probability of falling in the next 12 months based on his age and sex group. Okay, so it's not just saying it's a high risk and increased risk, is actually giving you a percentage. So it's a lot more precise, and it's based on different probabilities and algorithms. Again, this looks very simple. They used to have calculators. I think they may still have online on the APTA. Is you would have to go in and do the calculator, determine the probability, throw in the next one, and determine the probability. And that takes a lot of time, okay? Even just to change one of them. Here, it's done automatically by the computer. So it allows you to breeze through this section here to get your overall probability. Another part that we added to it was goals, interventions, and final comments. And the reason is, again, if you're using it for physical therapy, occupational therapy, or really any medical field, whenever you find a deficit, you want to give some goals. So what this will do, it will auto-generate goals for each deficit that's found in the performance test and the outcome questionnaires. Okay, I simply hit auto generate. Okay, and then it'll give me a short-term and a long-term goal. And then if you have a goal, then you basically want some interventions. So for each goal that I have, it's going to give me a basic intervention. Okay, for single leg stances, focus on the following: standing balance. We have a longer format that's built out where we make it a paragraph for each one of these interventions. And it's also going to generate overall comments. So it's going to give you an overall assessment based on the test that you did. And again, this is automatically generated. So basically it's saving the clinician time. Okay, you're getting accurate measurements, but now you have more time with the patient versus all the time that you have to spend with documentation. The other thing that we have in here is this will automatically generate, it will give home exercises to the patient based on their probability of falling. Okay, so the different ones that you have, and again, they're nice ones. They're done in English or Spanish. If you want to send them a basic exercise program, you can check that off. Now, initially, it will check off some of these based on their probability of falling. It allows you to add or remove different ones. If you want to add or remove a given test, you can simply just come in here. Well, we don't need the exercise yet. We want a little comprehensive home assessment instead of a basic home assessment. Again, I can do these in English or Spanish, and then I can send these to the patient. So now you got very nice, engaging home program for this patient that can be sent electronically or given to them, right in the office, hard copies if they're there. And initially, it will generate a set of home programs based on the probability, but it always gives you the option to add a particular home program or to delete that particular program. So when you're in the measurement sections, once you go through the test, now we also have this set up because we found that the physicians, in particular orthopedics, were now using this program while they're seeing the other patients coming in for other assessments. So basically, they're coming in for maybe a strained shoulder, whatever it happens to be, but they can run a fall risk assessment, which is now mandated by the CDC, not only to do it once a year if they've fallen, but to do it once a year whether or not they've fallen or not. Okay, so this allows them to get this quick assessment in. And it's kind of a win-win situation for the orthopedist, for the physical therapist, for the insurance company. The number one, the patient learns that they're at a risk of fall, learns how to do different mediation to prevent the fall. So thus they don't fall. So the insurance doesn't have to put out the money for a broken hip. And since this is a billable under the code 97750, the people performing the test can also add to their revenue. So it's kind of a win-win situation with this. And once you've filled this entire thing out, you're simply going to hit preview. And basically, your assessment's going to look like this. You're going to find this very engaging for the patient. It has all the numbers that you need if you're going through insurances. You can import their image on here if you want to make it personalized, more personalized. But essentially, it will give you a breakdown of the probability. So here's their overall probability. And then it'll break down each one. 50%, we're at increased risk, 17% high, 33% we're good, low risk. And then the bottom part of the cover letter actually shows you, let's see if I can increase this a little bit here. The different tests that you did, the outcome questionnaires you took. Here's your score. Here's what's normal, what it should be. Here's the cutoff, whether or not you're going to fall or not going to fall. And here's where you fall in the range, either high risk, low risk, or no risk for each of the assessments. But then it takes that further, again, for the patient to understand. It gives a quick description of what this test is. It shows them, this is your potential for falling. In this case, it's low for the sit to stand. They did pretty well. It will show progress over time. Okay, so as they come in, they take each test. You're seeing, are they getting better or are they getting worse? And also kind of helps guide your treatment. If they're continually are scoring low, in her case, she's still below average, even though she's improving, I want to, get more interventions that involve lower extremity strengthening. And we kind of made it more acceptable to the patient. If you're using a female patient, it'll show a female patient. If you're using a male, it'll show a male. But it also gives you, there's your score. Here's the population mean. Here's your deficit from the mean. Here's your fall risk for this particular task. And here's your progress from the last time. So again, it has all the information that you need to bill it if you're going through insurance companies. It will take each test that you've done. So now we have the tug test. Now that's going to look at the ability to do transfers, the ability to walk, the ability to turn. Okay, so that's looking at a lot more things than just maybe lower extremity strength with the 5-time sit to stand. Again, progress over time. Then we look at the single leg stance, which is basically looking at static balance. Now here she has an issue with this particular one. It's at a higher end. Okay, she's actually getting regression. So we need to maybe work more on static. And the same with dynamic. Okay, the self-paced walk speed. Both of those. So now we got to look at more at balance, both static and dynamic for training to help, improve it. And basically then it'll take the outcome questionnaires and where they score based on the outcome questionnaire. And then finally, here's your automatic generated goals, your interventions, and the final conclusions or overall comments based on the study that you did. Okay, again, remember, this is automatically generated. At any point, you can intervene in here. You can add additional assessments, take assessments out, change your goals. That's up to you, but it will give you them automatically initially if you choose them. If you don't choose goals, interventions, etc., it keeps it off the report. And as I said, this is based off research. So all these studies or all these tests, these are the studies that are based off this research. Now, again, many people do different types, maybe it's the 30-second sit to stand or different types of tests to determine the fall risk. However, we went with Michelle Lasardi because she did the research, okay? And again, she looked at 100 different performance tests, maybe outcome questionnaires. And the ones that she chose were the ones that were the most accurate and precise, okay? They had the best post-test probability to determine the risk of falling. So the references are always included. the actual outcome questionnaire is concluded. In this case, they just filled out the false efficacy scale, so you can compare that to a prior test. And then we even have this option here where physicians can use this, and it will auto-generate a script for them. You know, they want a referral to PT. The risk was very high. I want them 3-4 times a week for 6 weeks. I want to include the Otago program and a follow-up in 30 to 60 days. Now, again, the physician's able to go through here. They want to make some modifications in each one of these sections, add or subtract. It gives them the option to do it. But initially, it will auto-generate this script, which they can then send to therapy, physical therapy, occupational therapy, whatever it happens to be. And it's, you know, it's basically taking time that the physician doesn't have to worry about it. Okay, it's auto-generated. Now here's the home exercises, again, that are auto-generated, not just exercises, but information. So if we go down here, we got these exercises. Here tells them about medications they may be taking, you know, what's the proper footwear, how to get up from a fall. Here's a checklist to help make your house more safe. And again, with this particular report, you can send this to them automatically, electronically, to the cell phone, to the computer, to the email. You can print out a hard copy. Now I could come back here and change any test that I wanted to. Maybe I want to get a better assessment of the 5-time sit-to stands. I can go in here and assess this. And if it comes up with a different number, when I hit preview, it's automatically generated. If I had to do that manually, that would be a lot of work. Okay, so it wouldn't be realistic to do. Or I could decide, you know what, let's get a little bit better on the outcome questionnaires. We'll have them fill out the GDS as well. It may change the probability, it may not, but it gives a little bit more accurate. Now, the thing with the studies, you know, initially it was 12. Okay, but basically you don't have to do the 12. And they found with more recent studies that as small as the APR SR3, APT SR3, which is just doing 3 tests, was more accurate actually than the study. Okay, so you're not losing accuracy so much if you want to streamline your testing. That's why up above here, we gave you the options to create a protocol for your clinic based on what you need to look. Of course, there's always the full one at the APTSR5, does all 12 assessments. And again, this is not going to take you very long. Okay, with the Berg balance, this may take you 20, 25 minutes. Without the Berg, you know, this may take you 10, 15 minutes. If you've already sent out the outcome questionnaires to the patients, you know, that might be 5, 10 minutes right there for the person to fill that out. So these assessments are very quick to do. However, you had to do them manually, they would take yourself some time. Now, in the clinics, especially with physicians, we even have a little quick performance test to make it easy and easier for them to bring this into the clinic. They chose these tests. So for the clinician coming in, it's got it all on one page. So they get up, you know, they can click a little video here, show the patient. I just want you to do the tug test. This is basically what it is. You're coming down, sitting back down. You can do your 1 to 2 trials. It'll give you a risk. I move right down here to the 5-time sit-to-stand, self-paced, and the single leg stance. So we put this in here again. This is more to streamline it. It also kind of helps with the patient as well, gives them an idea of the tasks that they're performing. That's a simple measurement here. We do always include the studies here. We even have an instructional video, which will basically go over kind of like I just did with this particular assessment. And as far as our other assessments, one that's commonly used in relation to this, and it's based off the Fullerton Functional Fitness Test by Reiki and Jones, we call the Senior Fitness Test. And essentially, you know, you want to determine their fall risk, but maybe you also want to determine their fitness. So you can look at their fitness, do the different tests. Let me kind of increase this a little bit. The 2-minute step test for cardio, flexibility, the upper back stretch, the chair sit and reach test for low extremity, muscle strength for the elderly. You basically do an arm curls or 8 pounds or 5 pounds, the sit to stand, and then the timed up and go. Okay, and again, these are very easy to read. Our format's very similar for whatever test that you happen to do. We do a functional fitness for age 18 all the way up to 94. We do pre-employment screens. We do functional fitness testing. We do outcome questionnaires. We do performance testings, for injuries, status post MBA, work-related injuries. We're not doing a full-blown assessment. So we have many assessments out there. But in particular, it kind of goes tandem with the fall risk is now let's see what this person's fitness level is. And again, using the basic fitness tests that are used in assisted living, basic cardio, flexibility, muscle strength, and balance. It's going to, again, break it down. What's their level? 63% are excellent, 13% very fit, 25% unfit. It then breaks it down for them. Okay, your score, normal range, health grade, your fitness range. It will color coordinate. Again, if you do the vital signs, it'll color coordinate them. And similar to the fall risk, it will show the different tests to the patient that they took. Again, their progress over time, gives their classification. And at the end, as usual, all our assessments online that we have are based off research, peer-reviewed studies, the most recent ones out there that they do on those particular subjects. When you go back to a given patient that you have on schedule, basically, when you're in that patient's file, you can see all the tests that were done for that patient. Okay, you got the PDFs. You can see the breakdown. Here's the work evaluations, FCEs, work evals. We got occupational, job demand, employment screens. If you want to go over to the health and fitness, there's the body roundness, the functional fitness, the health risk assessment, and the outcome questionnaires. We even are working on cognitive risk assessments, of which you can send these. Initially, you can send them immediately. You can get them to the patient, fax or email, quick note. Here's that health risk assessment we did on you, and send it to them. So the ease of getting this information to the insurance company or to the clinician themselves or to the physician, whoever it is, it's just a click of a button. In the main screen, now we do have in the educational section here, okay, you're able to print out different brochures, your logo on there about, we do health risk assessments, or we do fall risk assessments, or we do functional capacity assessments. You can just simply, we put your own logo on there. Everything's generated towards your company. We have PowerPoint presentations. There are 10 slides or so that you can modify, adjust that if you want to go out and promote this to a given workplace. We found that work wellnesses love doing the fitness testing and the health risk assessment. If you're going to work on doing functional capacity evaluations. And we have all the procedures here. Okay, so we have it, the manual procedures for each different one. You can actually even get certified in these for the health risk, the fall risk, the senior fitness, and get CEUs if you're a PT or OT. 7 of them for the functional capacity. You can take the exam. You don't need to get certified to use these, but that's available as well. Let me get back to D. Hannah here. So essentially, with our assessments, they're all backed with peer-reviewed studies, magazines. They all give the research behind it, included with every study. They're very flexible. All these different tests allows you to tailor toward the way that you like to do it, but still maintain the benefit of that particular thing that you're assessing. Basically, for our fall risk, that kind of sums it up. Just give you a quick tour there of the other assessments that they do. And if there's any questions, I can certainly answer them for you.
Thank you, Bill.
Yeah.
All right, so let me see if you have any questions, guys. So definitely thank you for the demo. Like lots of outcome measures Bill showed there already. So that's really good.
Yeah, we cover both the health side, the occupational side, Our physical performance testing looks at range of motion, looks at manual muscle testing, handheld dynamometry, pressure threshold testing that you can set up protocols post motor vehicle accident, post workers injury, or just somebody coming in for an assessment. They're on a smaller scale. We have the full scale FCE, which again is probably the state of the art that's out there. Is extremely comprehensive. However, it's easily to onboard for people that have never done FCEs. We do these type of demos. You can just go online to webfc.com and sign up for a demonstration of any of these particular assessments that we have that you're interested. If you're into occupational medicine, if you're into health medicine or straight out physical therapy, occupational testing, and you can schedule a time and we'll take you through each program. We also, with our assessment is here, we don't have contracts with any of our things. It's basically pay as you go or pay for what you use. There's no sign-ups on a yearly basis, renewals. So basically, the assessment here, you're just paying for what you do. Okay. We don't sell the equipment as a lot of other places do. We don't make money off the equipment. The equipment that you have in any clinic basically is sufficient to do almost all this testing that we mentioned here. So basically it's just for the assessment part. And again, with our education, our customer service, we have Drew. Anytime you have a question, and as many times as you have a question until you understand the particular program, we always engage and we want you to call. Our programs, even the deciding to do different programs, have come from the actual people that use this. Okay. We've continually modified our programs based on the use. Ours are more of a living software programs. They change with the time. They change with different assessments of newer things that come out there. We take input from everybody that uses this. And if it makes sense and it's something that can be used globally on our assessments, we put them in. If it's something maybe very specific to that, the IT program, the programs can modify your particular assessment that you're choosing to fit that in there. Maybe you don't like to look at this particular section or this a certain way. Sometimes they can modify that just for you. So we modify this on a global basis. We update our routines. We update our testing based on what we get from the clients out there, and continual research with the different assessments that we do.
Interesting. Yeah, so this will be more, if they are in outpatient setting, definitely this is a good functional FCE for them because majority of them are using this, right?
Yes, the
So,
FCE is very, if they've never done an FCE, okay, it's pretty encompassing, okay? And it used to be 3 to 4 hour FCE, 3 to 4 hour write up your program, or write up your results, okay? That's what kept most people away from FCEs. Now with the generation of the computers, and in particular our program, when you're testing this person, once they walk out their door, you're 90% done with your report. It organizes it no matter how many times you change it into the format that's required and needed to understand, your overall assessment. We went with the APTA, who in April 2018 came out with an outline of what an FCE should be. That's included, that we have that in the educational portion. So it outlines, and you can see that we follow step for step everything through the APTA, and we're also based off the DOT, which is the Dictionary of Occupational Titles. They're the ones that created different job factor tasks, 30 of them, sitting, standing, crawling, walking, reaching, grasping, and defined a job based on frequency. Now, there's so many moving parts to an FCE that you really would, in the old days, have to be on the ball to what you need to do, but we've even turbo-taxed our FCE to the point that when you choose a job, say I choose a truck driver, it will turbo tax you through it. It'll tell you which tests to do. Okay, it will tell you to do this test. It'll tell you if then based on that test, does the person have a restriction? Okay, so it also allows for the more seasoned tester to go outside those boundaries to add additional tests or maybe skip a few tests. So, this FCE that we've made, that was our flagship, and that's basically why we're called Web FCE because that's what we first came out with, functional capacity testing. But as I said earlier, many people came out with what about fall risk assessments? What about pre-employment testing? What about outcome? What about performance testing? So that's what we've added over time. We're soon going to be subdividing into two different groups. We're going to have our Web FCE, which will be basically the occupational testing, and then Health, which will have the health assessments that include the health risk assessment, the fall risk assessment, et cetera. So we're expanding as we go. And we're kind of different than most places is we appreciate people calling us and asking questions. It's not a bother to us. As I said, we use that to make ourselves better.
Good point. Thank you. So that's where innovations kick in. That's why, right?
Pardon?
That's what we call the innovations. Yeah,
Yes.
innovate.
Yes.
All right. Thank you. So guys, if you have Bill, kindly put your email here. I put the webfce.com already. And then that way if they have any concerns, any questions, and at the end of this event, we will also send some of the speakers information for them for more resources or to contact you guys. So thank you so much, Bill, for this opportunity and for supporting us as well for both Geriatric and Innovator Summit. Appreciate you, Bill, and the
And
team.
thank you for having us again. We always appreciate your invitation.
My pleasure. Yes. Many of our colleagues, they are in outpatient settings, some are in acute. So we always want to learn more from you guys. So thank you. All right, guys. We have a break for your lunch. And if ever you are in different time zone, definitely stay with us. We will have another three speakers this afternoon. And let me share my slide here. So this is Bill. Thank you for
Thank,
your presentation
thank you.
and my pleasure. All right. So Web FCE, that's what we learned today. So the only complete web-based platform for your practice. Grow your practice and increase revenue with FCE software and health risk assessment tools.
And again, they
Web.
can go on that site and schedule for a demo of any particular, we do them in the morning, evenings, and night. We see people, we do these with people in Australia, Hawaii, all over the place. So you pick the time that you want to go over a particular program, and I can do a similar presentation for whatever particular assessment that you're looking for.
You mean, Bill, you are available globally? They can use it anywhere.
Yes, we have a very large in Australia that use the fall risk and the functional capacity testing. We have some
Mhm.
in South Africa. We have in some of the islands, and we have in Hawaii. Canada uses us, so we are globally based. We do have the
Nice.
option too, since in the United States we're the only ones that use the English or the non-metric system. When you go to these other countries where they use metric, you can simply choose metric, and every measurement that you have for the testing is done metric.
How about in Asia, Bill? We have audience here from United Arab Emirates and Philippines and Vietnam.
We may have some in the Philippines. If Drew, who's usually on here when we do demonstration, he's the guy who keeps track of where we're at. But I think we do have them in the Philippines. I know we have some, I think, around in Barbados. Again, Australia is a very big one, and Canada as well. But
Oh,
we are available, and again on the different platforms that use metric, which is most of them around the world. That's a simple click of a button, and everything's changed to metric for them.
amazing. Thank you so much. Appreciate that. It's a HIPAA compliant too, guys. Evidence-based
Yeah,
tools, help PTOTs and Chiro clinics, add a new line of service, increase revenue. So their software is fast and easy to learn. So check out with Drew or with Bill if you have more concerns, all right?
thank you.
Yeah, so we're doing this. I just shared this for our future foundation. This is like if you find value with this is a free event, but definitely check out the Future Foundation Global. You can donate for us $5 or $10. Any amount will do. So it's our first year to have a booth in the Academy of Physical Therapy Association, CSM, this coming next year, 2026. So with our sponsors, supporters, we really appreciate their help. So if you guys find value with this amazing courses we have, summits, definitely join us and support our cause today. And that's for our future foundation. That's a direct link to the foundation global. All right.
Thank
And
you.
we have a break, so that's our lunch break. This afternoon, we will have Erica DeMarch for our first speaker. And then we have Dizzy Care Network for with Patrick Esmond. And the last speaker will be Natasha Williams for Phoenix Hipwear. All right. So join us later. Okay.
Thank you.
Thanks, Bill. Appreciate you. All right, we have a 30 minutes break, guys. And after lunch, we'll see Erica DeMarch around 12:30 instead of 12:45. Okay. See you soon, guys. Join us. Yeah. Yeah. So I just paused the recording and then we can record again for the 12:30. All right. Stay with us, guys. I don't know what's your lunch or dinner, maybe. Depends on where you are. You can share some anything later on. It's okay. Session. So at least we have a good break, lunch break for here in US base. And I don't know what you call like a morning snack if you are in Vietnam and in Asia, like Philippines. It's around 1 o'clock right now there. All right. Thank you so much for staying with us. And for our afternoon session, we have Erica DeMarch. She will going to talk about advanced balance assessment, perception training, gait technology using Nushu, and of course, Balance Connect. Erica DeMarch is a physical therapist with over 20 years of clinical expertise, offers a fun, functional, and science-backed approach to training balance. Their portable and affordable devices use multi-sensory feedback and multimodal training to maximize motor learning performance. All right. So she will going to show us the different innovations. Just there will be two nice, great innovations she will going to share with us. And it's really new to me, the new shoe part, because Balance Connect is available already. And these are really nice coordination, motor, and also very fun activities that's shared by occupational therapists and physical therapists alike. All right. So I will going to stop sharing and give the floor to Erica. Welcome, Erica.
Hi, thank you. Here, I'll share
My
my.
pleasure. All right.
Okay. All right. So thank you again for the invitation today. I'm excited to share both Step and Connect and my role in motor learning and looking at augmented feedback to improve both balance and gait. I've been
Erica,
working.
can you increase the volume on your part? I increased mine already, just to be sure.
Let me see. I'm sorry. It might. I might have to decrease. Let's see. Is that
I can
better?
hear you though. Yes, yes, I
Yeah.
can hear you. Just want to be louder on your part. Thank
Okay.
you.
You're welcome. So yes, I've been working with engineers the last few years and really see the importance of technology, but also the importance of both physical therapists and occupational therapists and clinicians in making sure that that clinical utility is happening in our practice. So recently I met Olgak Ergonoman. He is a co-founder of the company Magnus and developed Nushu. So I've been using a click to give that positive feedback, looking at auditory feedback with Step and Connect, and they were using vibration. So something that we both were looking at of how does augmented feedback give that reward to our patients that they're using that movement. So I'm going to be talking about Nushu today also because I've been working closely with them on helping them expand to the US and both looking at how we can use augmented feedback. So I think the first is, if we were in person, I would have everybody be trying to step on the foot pads that I developed, get a feel of the different textures. If you were using the new shoe, you would be able to put the shoes on and feel the vibration. But since we're virtually, I'm going to just show a few quick videos just to kind of introduce you to both products before we go into more of the details. So here is just one video of the Balance Matter system, and you could see the different applications that I have used in the clinic. Then you're going to go all the way into stride, walk back, walk forward. Your head straight when you rotate. Sure, 1. Push, try it again. Push down and go. 1, 2. That's it. 2, 1, 2. Get that rhythm. Yep, so I want you to just try to figure out how do you leave the laser light up while you get that back clicker. That's your goal. So that was a little introduction of the Balance Matter system, of just a few different exercises before I go into it. And I'm going to just show part of this video. You'll see some other videos. Because I think if you, one thing I like about this video is what he's talking about, how it made a difference in his life. And I think the importance of technology, right? We can create all this new technology, but the main importance is what is it doing for our patients? How does that improve what they're doing day to day? So here's just part of the video of introducing New Shoe.
Hello, my name is Matt Eagles. I'm 54 years old and I got diagnosed with Parkinson's in 1975, so I guess I've had it 48 years now. What motivated me to try the shoes was a desire to walk better and have a better quality of life, and my first experience was just phenomenal. I had a huge smile on my face. I was walking without my stick. I was able to turn around without falling over. It was just incredible, and I cannot express enough what a difference it makes. It really is quite incredible. I believe the vibration helps me because it kind of rewards me for moving, which may sound bizarre to somebody that's not involved in this, but whenever I lift my foot it vibrates, and it's a really nice feeling, and it's almost like, it's like a big hand clap or a clap of encouragement, if you like, to move around, and that's something that I've never really had. And it just fills me full of joy and happiness. It's great.
So that I'm not going to do the whole video because I'm going to show some other ones, but it's on their YouTube channel. But really looking at, you know, how does vibration, what is that kind of reward? We're going to be talking about that motor learning aspect of it. So I'm going to first introduce a little bit more on New Shoe. So this is the shoe right now has sensors in the sole of the shoe. It's almost like you're having two iPhones in your shoe that is collecting data. So I'm going to talk a little bit about the gait analytics that it's providing, but then it's also giving you vibration. And we'll talk more about the different vibration settings, but the really innovative part about this is you can actually get vibration at different phases of gait. So you can have it just during the swing phase. That's what you just saw. Matt was able to initiate that movement so that they're not having freezing a gait. But it can also be during that stance phase for somebody who feels like they can't stand on that one foot very longer. So you're getting that vibration. And another novel part of this product is there is AI integrated into this product. So as somebody continues to walk, especially if they're using this at home, it starts to learn their movement patterns and become smart and know when that vibration should be provided to improve that person's gait. So this product has both, similar to the Step and Connect system, it has both for the clinic and for the end user to be used at home. So in the clinic, I'll show you examples as a therapist, what I've been using and some clinics here and in Europe have been doing. Also, I would say the workflow in Europe, most neurologists right now in Switzerland are using this instead of just telling the patient to walk down the hallway, they're actually getting all the analytics for their gait and are able to make adjustments for medication or DBS and really help with that decision making. For the patient user, they have the feedback. So there's an app associated for both that you are getting that feedback, but then they also can have that data and exercises. So you'll see we're going to talk about the different feedback mechanisms, the exercises that they can do with it, and then also just really tracking their progress and data. So I thought the best would kind of go over a case, a few cases, so that we can kind of understand how you would use it in your workflow. So this is a gentleman who's 68 years old, another gentleman with freezing of gait. And I want you to think of what would you, so beforehand, what would you do while you're watching all of this? How would you analyze his gait? What do you have available to you in the clinic right now? And how would you be documenting this? So if I was using the New Shoe product, there's an app and you could see that there's all these different tests that you can actually use. So you would pick what test. If it was just generic walking outside, you can do a time test if you're looking at endurance. There's posturography, there's other aspects of it. So basically you pick which test, say it's a timed up and go, and then you pick which type of vibration. So usually I'd start with a baseline of saying no vibration. So I know how that person is walking, similar to what we just saw with Matt. What was his walking without vibration? You get all your data, and then you repeat that test and see with different vibration settings. So are you getting vibration only at heel strike? Are you getting it during swing? There's different settings that you can set it up. And on the app, it's really intuitive that there's a little eye, and it basically tells you what each test is if you're not familiar with the test. So these are all the tests that are currently available on the app that you can use. One part that I really love about this product is it's not just something that you use in lab. You can, I had one patient, she was fine walking indoors, and you're gonna see some videos of her. She got more comfortable, but she was really fearful to walk outdoors. So I was able to capture the difference of her gait speed indoors versus outdoors, and then make that as a goal that we're trying to improve her participation in the community. So here is the gentleman. I want you to watch his video of him walking. You're going to see it with the vibration and without the vibration. And then I'll show you his metrics. But really start thinking about what would you, how would you document this? Or what are you observing? See how much effort it's taking him, especially during that turn. And I'll talk about some of the responders versus non-responders. This gentleman really responded strong to the feedback, and you can see how much better he walked. So I know it's a little harder to be interactive right now. If you wanted to put even in the chat button, what are you currently using to measure gait? For me, I use, a stopwatch looking at gait speed. There's a few apps that I use. But what are you using to look at the differences in his stride length, in his heel strike angle, looking at variability of his walking? Maybe they take a few really good steps and then their steps get shorter. How are you capturing all of that? And that was something that I kept meeting with engineers and even looking at Step and Connect, and something I was missing. And I really believe that we need, similar to some doctors looking at, I gave a conference the other day to patients, and I asked who knows their gait speed. Nobody raised their hand, but that's considered a 6 vital sign, right? But we know our blood pressure, we might know our cholesterol. So how do we actually look at each of these profiles, and how does that make a difference in our walking? All right. Let's see. So now if you look at, this is his gait metrics, right? So this is something that you're able to get with the new shoe. So you can actually do a comparison report of that it automates for you for no stimulation versus stimulation. You can also do a report of different dates of the same test. So it's looking at his stride length. If you look at, this is the mean versus the standard deviation. So if it's looking at 0.56 is his stride length, and 0.59, but then with the stimulation, he went up to 1.14. So if you look at the same for velocity, 0.33, he went up to 1.06. The heel strike angle, it was 8.99. And it went up to 16.34. So really looking, and the right was affected a little bit more. So you're still using your clinical skills, but then this kind of starts telling you how much he's improving, what is his dorsiflexion range of motion, what can we look at to improve even more. So the new shoe is validated. They did different tests to look at validation, looking at the gold standard analysis of the gait right and looking at different cameras to make sure that and motion sensors to make sure that collecting the right data. So the nice part about this is that it is a little bit more mobile than being able to use some of the walkways and things that are being used in research we can actually now use in the clinic more easily. And like I said, you can actually use this outside. I've also done assessments walking through doorways or in environments where if somebody is walking might change, so you can make it more real life. I've been working with them to change their a little bit more user-friendly for some of their assessments. So this is something that is in the works right now. So you would have a framework to be able to test them at preferred gait speed, their maximal gait speed, and their dual task. And then you can see where they are and if they went up and down, so you can see pre and post. And then you're able to actually see if there's a minimal detectable change. So if there's a change in that, how much are they changing for each of those parameters? So you might be looking at speed or cadence or stride length, and then you can look at their variability in gait. So here's just a little bit zoomed in so that you're able to see those different numbers. So they are working and really want feedback from therapists of what is meaningful for us to see and how would that change your gait. Because if somebody's maximal gait speed doesn't really change that much from their preferred, how do we work? What are we working on? Are we only working on their comfort gait speed? Are we working on dual task? So we have a little bit more understanding of what happens to their parameters. So why is this important? There is so much research on looking at correlations with increased adverse events such as falls or hospitalization if you have a gait speed less than 0.7 meters per second. But the good news, if you get 0.1 meters per second, you have better well-being versus if you decrease that, you have longer hospital stays, increased cost, higher disability. So tons of research. So if we're able to collect that, we can show our patient, look, you have just that 1.1 meters per second change, you have better well-being. We know that you're making a change. So I think this is important to look at. Stride length, also research on this, looking at 0.64 meters, predicted outcomes such as falls, disability, mortality. So how do we tell our client, you know, you're at this level that we really want to make sure that we can get you above that level. Increased variability, tons of research on variability, on looking at that stride time and increasing falls. So maybe somebody's walking speed is really good, but it's really variable, or maybe they have increased variability with dual task. So how do we work on that? Just kind of showing you, I'm not going to show you all the research, but here's another article that was looking at the combination of gait measures and your clinical skills to look at fallers versus non-fallers in Parkinson's disease. So foot strike angle was the highest discriminative ability to be able to detect that. So here with the new shoe, you're actually able to look at that foot strike angle and then seeing that cutoff and seeing those changes. So again, I'm just pulling up his data again that we just looked at. So now we know his stride length was below initially that 0.64 meters, but with the stimulation, he got above that. So now he has that decreased fall risk, right? Stride velocity was 0.33 below 0.7, 7 is a fall risk. He got above that. So the heel strike angle, if you were below 14, that was considered a fall risk. He was below that. He did go above it on the left, not on the right. So that would be something. What else can we work on? Does he have that mobility? How do we change that to get all of those parameters up? So here's another example. This patient came to me after a cerebellar stroke. She had rehab at home. And unfortunately, after 2 visits, she was discharged from PT from the therapist at home, and then a week later had a fall outside. So after she had that fall outside, she was really, really fearful of falling, and basically told me that she kind of just was thinking that she was going to be in her house the rest of her life, that she wasn't going to be able to go back out with her friends and restaurants and to get out because of her risk for falling. So here we started the new shoes, and her some of her descriptions are just really well describing what she feels. So listen to her video.
The shoes really help when they're vibrating, help me walk better, because since I had a stroke, my feet are almost like paralyzed, like they feel numb all the time. And this gives them back like a feeling, so it makes walking more like it used to be.
And she keeps doing this with her hands. Every time she puts it on, she's like, my feet are waking up. Like, and it's such, she just smiles. She's like, I forget how much I love the feeling of these. So that confidence of knowing where her feet are. And I'll show you a little bit more. So I'm going to show you 2 other videos because I think it's really important to know. And this first video really struck me a little bit because I've been working with people after a stroke for a long time. And I think sometimes we forget, she looks like she's doing really well sometimes, and I think we forget that she still doesn't have that quality of life. So she made a really strong comment that I think technology can really help.
I think there's a group of people like me who aren't so severely affected, but are slightly affected, who really need to be reached out to, because our way of life is different. Not as bad as other people, but still significantly not as good as it used to be. These shoes make me feel more mobile, more alive. I can feel my feet. I think we're a group of people that are not on purpose ignored.
And I think this was just I added this video because I think this is important to know. She keeps reading all these forums for stroke rehab, and she keeps telling me, I'm not that bad, Erica, but she's not doing the things that she wants to do. So she's still, her quality of life, she was still not going out. She lives alone. How do we get her to be able to go to her? She was a personal chef. She loves going out to eat, so how do we get somebody to do that? So here's one more video of her describing how it feels when she wears the shoes. Oops. Sorry.
I think one of the most important things is whatever I'm doing, when you put the vibration on, it makes my brain shoot to that area so that I can pay better attention.
So every time she talked to me, I'm like, you're describing this quite well. So I think she really kind of felt differently when she was able to use that. So here's all the different vibration settings that you can put on. So for her, I actually used the ground vibration over here. So when she was in stance phase, that's when she couldn't feel it. That's when she actually had that vibration every time that she had one foot on the ground. So you can pick which vibration setting that you want and see which one helps them the most. So you could see this is her now walking outside where she was. I wish I captured, because I didn't have the shoes when I started to work with her, but she took such little steps and I had to hold her hand. She did not want to walk outside in the beginning. So now she's walking all around her neighborhood. Another goal of hers was to get on and off the ground. Here, she felt like her legs were really heavy, so I put the swing to give her a little bit of a boost. So here
you're going to feel that vibration when you swing your leg up to come to standing. Okay. Bring your left foot forward a little bit more.
So there we were working on Lord to stand. That was also when she had that fall, she could not get up from outside. So that was something that she really wanted to work on.
You're gonna.
So the importance of feedback. This is something that I really have been looking over the last 10 years, is really looking at how do we change somebody's motor learning? How do we increase that awareness of their movements? So the auditory feedback from Step and Connect really helps with that heel toe patterns, or versus somebody taking a step, where is their foot in space? So being able, you saw that video, the first video, as she stepped back, we were trying to increase hip extension, but she kept leaning forward. So I was giving her that laser light to try to isolate hip extension as she steps back. The vibration feedback, you just saw a bunch of videos looking at different phases of gait. What is your goal that you're working on? Are you trying to improve stability and awareness? Are you trying to get increased stride or initiation of gait? This is, I'm not going to go into this, but this is a great article if you want to look a little bit more on motor learning and looking at the different aspects for gait. And I think this, the different populations, I just spoke about only 2 different types of populations today so far, stroke and Parkinson's. But that location, that practice environment, I think similar, getting into that real world setting is super important versus just walking in the clinic. And I'm going to even translate that a little bit. You'll see some videos of looking at some functional tasks I think is just as important. So these are just the motor learning principles, the practice structure, how you're using that, the feedback delivery. I think our words are super important in how we describe the feedback that we're trying to provide. So I teach courses on that to go into more detail, but I think it's something that we should be all aware of. And then how are you measuring that learning? So great article that goes into the different aspects of motor learning. And I'll share the slides so you can have the references. So reflect a little bit. What kind of feedback are you using in your rehab right now? Are you using auditory feedback? You might be using a metronome. Maybe you have the Balance Matter system. Are you using visual feedback? Maybe a mirror. Are you using tactile feedback? Maybe your own hands to help somebody. And when are you giving it to them? Is it real time, like the products I just described? Are you giving it after the movement? Tons of research on different tasks, the complexity of tasks, of when you provide feedback. But I think it's important to start to reflect on why and when you're giving feedback. So there's different feedback modalities. So vision's going to really help with that spatial versus audition, or auditory feedback is going to help you with that rhythm, the speed, the timing of motions. And then haptics is going to actually give you a combination of that temporal and that spatial. So you're getting that vibration at a certain part, but then you're also able to see how much you're moving. So I loved Matt talking about how it felt like he was getting a little clap or like a little pat on the back every time he took a step. He felt that vibration. That motivation is super important for our patients. And sometimes our verbal, it's a little different of us saying good job versus that real-time feedback. When you hear that click, you know you did a good job. When you felt that vibration, you did a good job. So it's non-judgmental. It's just, they're getting that feedback right away. The product for Nushu actually does have a setting that you can change and do affirmation or negative feedback. So when they don't take a good step, they can get feedback, or they can get feedback when they take a good step. So I've been playing around and asking my patients, do you want positive or negative feedback? So far, nobody told me negative feedback. You can change that to see what improves. And I think improving that performance, being able to show somebody their data to say, look, this is the size of step you're taking, or this is what happens when you dual task. They get more awareness of those movements to start improving. So auditory feedback really is helping with that step symmetry, looking at that temporal parts of movement. Some of my patients, I have them step or march on the clicker foot pads. They don't realize that their speed is their comfort speed. So we talk about exercises we give to patients at home. Are we asking them to go at their comfort speed, slower, faster? That does change their movement patterns, and that does relate to everyday life. If they're rushing to go to answer the door, what happens to their movement patterns? So I think it's important as a training aspect that we can start training that. So here's one example using the Balance Matter system. This gentleman, I think sit to stand, if you think of the timing of your weight shift, is really important. So if you are How many times a patient will say, I plop, or their spouse will say they plop every time they go down, but it's their timing of how they weight shift. It might not be their eccentric control. So the auditory feedback for him, this gentleman is blind too, so the auditory feedback really helped him because a lot of the visual stuff he could not do since he can't see. So his cue was to keep the clickers quiet when you're sitting down, and then right when you're the seat is on, or your butt is on the seat, then you can hear that click.
Excellent. Make sure you breathe.
So the speed of the clicks, he clicked one side quicker than the other, and there you heard the click too quick as he sat down, right?
Excellent. Which one was the best one?
What's that?
Which one was the best one?
I think the last one.
Why was that?
Me. Well, I think I just got my muscle memory working.
Good. Yeah, that was better control, that last one.
So I think it's also important that summary feedback to see what the patient's perception is compared to your perception. I thought the last one was his best one, and he also did. So did he feel that? What was different? So I think that's important also in motor learning. The use of vibration, I'm not going to go into the full science based on this lecture today, but it's been around for a long time. So I just put a quick timeline of there was one article looking at the effects of muscle vibration and gait control, and it was a review of the literature. And it's been around looking at massage, looking at, the muscle spindles for a long time, all the way in the 1800s. I would say in the 1990s to 2000s, they really started to explore vibration in rehab in the aging population. So how we're looking at that is a little bit different, but the science has been there for a while. Regarding gait, there's two different ways. You can use vibration throughout the entire gait cycle, or you can use it during the specific phases like I just explained. So there's different ways of looking at subthreshold, or looking at the frequency or the intensity of the vibration. And then if you look at the vibration scientific principles, we're stimulating the muscle spindles. Are we looking at the stretch reflex? There are some studies that actually just go right on the muscle belly to do vibration, but it's more in the lab, like a controlled setting, to see what happens. There's the neuromuscular control, that communication between the brain and the muscle, looking at that sensory processing. Are we increasing proprioception, similar to what Deborah was talking about, increasing more awareness of her foot and knowing where it is? And then there is some research on bone health, stimulating the osteoblast activity, a lot with the vibration plates and things like that. Right now, Nushu is doing some studies in across the world, but there are some studies here in the U.S. Looking at freezing a gait, looking at different ways feedback is. So these are a few studies out there, and if people have some more questions, I'm happy to share some of those studies. Or if you look on the clinicaltrials.gov, you'll be able to see the abstracts of these studies. So how it might modify gait. You're inputting for this device, we're getting it at the heel, right? So you're getting that input. Are you stimulating those muscle spindles and proprioceptors? You're increasing that sensory activation. And then that's that sensory motor cortex activation, that you're getting that sensory integration there. And then that improves your motor output. So is that improving your gait initiation or your stance time, depending on what phase of gait that you're trying to work on? But then, of course, the most important is if you feel safer and more confident, then you're going to be walking more. So I think, if I can get a patient to walk more, that's going to be my biggest outcome for her. So here's another example of a gentleman that was a really strong responders. And I will let you know, there are some people, I'm showing a few with strong responders. There are some people who it takes a few more visits to respond, or I just use it as an adjunct in my therapy session. So just like I would use a metronome, I might use the metronome setting for vibration if I want to pace and try to get their speed, or I might use it to improve and kind of get their priming their system for balance. So there's different ways to use it for different clinical populations, and that's what the research we're trying to find out what person responds differently for this. So here's a gentleman with Parkinson's and also had freezing a gait. That's where a lot of the research is starting. But after he did this, his wife, I spoke to his wife on the call a week later, and he was able to go and unload her car with the groceries. And she said in 10 years, he was not able to help her with that. So for him to be able to walk with the groceries, not use his walker, that's a dual tasking and not freezing, was a big quality of life improvement. And you can see that she can't even keep up with him in the other video.
He is using his red thing to run. We'll see what happens here.
So here you can see he was using the laser light and the U-step walker, which was helping him a little bit, but not as much as the vibration in this example. So there is some research on looking at the different visual stimulation, auditory stimulation, and somatosensory for freezing of gait. Tons of more research. I'm working with some experts in the field to understand this at a different level, to understand at what protocols do we do, who responds, and what type of vibration are you providing to be able to help with these different aspects for freezing a gait. Another great article that talked about, the evidence of looking at vibration and for freezing a gait, and the science behind that from this article is it an external cue related effect? Is it related to cognitive and intentional resources, or this enhanced proprioceptive processing? So I think this is more and more research will give us better understandings of what's happening at the brain level. So here's another example, and I put this one in here recently because I'm thinking of the holidays. I just saw this client yesterday, and here I just want to show an example of how I was using for him just to increase kind of that output. So for him, he was telling me he's a little worried about Christmas coming and getting off from the table. So we think of sit to stand, but sit to stand with a table in front of you is a lot different than sit to stand with just nothing in front of you. So for him, I used the swing vibration. He also has Parkinson's, to try to lift that leg up a little bit more. So we were working on that control.
Yep, definitely. So that being able to swing that leg, so then you have enough room to be able to swing that next leg. Yep, definitely.
So for him, we were trying to increase that amplitude of his swing so he can swing that opposite leg and then do his sit to stand from that table, versus he kind of felt like he was getting stuck. So if he actually just put his foot, with a less of an angle there, even half of that, then the other foot, he would have to do this multiple times and kind of get stuck. But then when he kept telling me about different things he was working on, it was almost that same motion, getting in and out of the tub. We did the same thing. We just kept the shoes on just for practice, trying to increase that size of motion. Now he has to go up a little bit higher.
More effort, or about the same? And then go back, and then I'll put it back on.
So again, this is just trying to show how we can increase that. Here's another example. I used the metronome vibration. So for this patient, the speed of her motion, we were trying to improve. So right now she does calf raises pretty slow. So this was trying to increase the power, and especially on one side. So you can change the vibration to 60 beats per minute, whatever you want for it. And here's another example of him weight shifting. So if he only weight shifts a little bit, he will not feel the vibration. If he weight shifts further, he'll feel the vibration more.
Now don't lift as high and see if you don't feel it.
So
no vibration. Now go a little bit more until you feel it.
There.
So I think it's important sometimes to have that augmented. So he didn't understand why he could not stand on one foot. So once I started to show him his weight shift wasn't further enough, and using that vibration, he cannot feel the vibration until he shifted a certain amount of, helped him understand that he was weight shifting too little. So I think I'd like to show you when I'm starting to work with Magnus, more and more new technologies coming out from their company. So I showed you a little bit about the dashboard and some of these new metrics that's coming out. There's going to be new vibration modes. So right now I showed you a bunch of vibration, but they keep coming up with new different settings and based on therapist feedback. So we want some therapist feedback. So the new mode that's coming in is going to be if it's coupled with movement. So the faster you move, the more vibration you feel. So that will be something that we can use for exercises. Having different exercise modules on the app will be available next year. I'm going to be helping teach some courses coming in the beginning of next year on how to use the vibration in your settings. And then also probably the end of next year, they don't know exactly when, they're doing some research with Carnegie Mellon. They're doing some exer games. So I met with their technical team last week. So I do want to show you, I thought it was pretty fun. This is in the works. It's not out yet, but kind of showing you, I was impressed with some of the progressive stuff that was coming out. Let's see, I don't know why it's pausing for a second. I'll try one more time.
Welcome to Camp Move Well, a playful set of PT-inspired minigames. Heel raise lifts players onto their toes to peek over the fence and spot what's changed. Leg raise lets seated players kick balloons upward and form words as they move. And sidestep trains balance and reaction by stepping to keep animals away from your picnic. 3 engaging activities designed to make movement motivating and meaningful. The therapist selects today's activity, heel raise. The PT can adjust the exercise difficulty by setting a target heel raise angle. This allows the experience to match each patient's specific abilities and therapeutic goals. During the exercise, the PT interface shows real-time metrics from the smart shoes, including height, consistency, and repetition quality. These insights give therapists a clearer view of performance and support more precise guidance. The interface also allows therapists to add cognitive challenges. One option is the random butterfly count. By pressing the built-in dice button, the PT generates a random number between 1 and 8. This represents how many butterflies of a specific color will appear during the game. The interface shows the exact number rolled, giving therapists an easy reference as they ask patients to identify and recall what they see on screen. Another option is the spot the difference task. With simple plus and minus buttons, therapists can add or remove objects in the scene. Whenever a new object is spawned, like the windmill, the house, or the mini freezer, it immediately appears in the game world. At the same time, the UI lists every active object, providing therapists with a clear answer key as they guide the patient through the comparison task. Therapists can also remove objects with the minus button to help patients compare more easily. We also built in a mechanic that simulates fatigue. If a patient holds a heel raise for too long beyond the threshold set by the therapist, the screen gradually becomes blurry. This encourages patients to perform more repetitions instead of relying on prolonged holds, keeping the exercise aligned with PT best practices. Our next activity is leg raise. Players lift their legs repeatedly to send a balloon upward, and after enough repetitions, it rises carrying a letter. The goal is to keep moving while forming a word from the balloons floating above. When the word is completed, all balloons pop and a new set appears. This spelling task keeps players thinking and engaged, supporting cognitive stimulation and better carryover during their repetitions. Next, we have sidestepping, our reactive stepping minigame. Small animals rush toward your picnic blanket, hoping to borrow your food. The player shifts their weight and steps with the correct foot to match each color cue, scaring the animals away. This repeated switching between the dominant and non-dominant foot helps train balance, weight shifting, and fall prevention skills, while the color matching adds an engaging cognitive layer to the exercise. Our minigames were shaped not only by research and the guidance of expert physical therapists, but also by real playtests inside PT clinics. working alongside patients facing neurological mobility challenges. In those sessions, we saw how a small moment of play could spark focus, confidence, and joy. It showed us what rehabilitation can become when movement feels meaningful and hopeful. That is the heart of our vision, from rehab to play, and from play to progress.
Trying to get it off, sorry. Let's see, it's freezing over here now for me. Let's see.
What they see on screen.
There we go. So that was just one example of something that's coming soon that will be next year. Right now, all the gait metrics and the exercises will come first before we get some of the interactive, but it is in research right now. These are different products. You can go on their website to kind of look a little bit more. I think they're updating their website soon that you'll be able to see more of the research on there, but I'm happy to share some of those research articles. Sorry, I don't know why, there we go. And then for the Step and Connect, similar to before, I was talking about, we have a clinic system and then we have a home system. So different systems that you are able to purchase. I keep trying to, there we go. So if you have any questions right now, I am starting, like I said, to expand some of the Nushu in the US. It is more popular right now in Switzerland and in Europe. So I'm going to different facilities. So if anybody's interested, please email me and we can set up a demo. For everybody attending this conference, we're giving 10% off and then some more education. I will be in Chicago next week training a staff. So if anybody's in the Chicago area, I might have time to do a quick demo. And I'll be in New York and New Jersey the following, and I'm in Denver. But if, you know, it would be more for next year unless you're in those two locations. But if there's any questions, thanks for listening to learn a little bit more about motor learning and different types of feedback for gait and balance.
Thank you, Erica. All right, we still have a little bit of time, Erica. Can you show exactly, you have the video in the beginning, right? So
Yeah.
if you have, maybe you can get some sample exercises of the Step Connect itself, the one that is in YouTube or something like that. So they can see more about
You want to
the
see more
balance. Yeah, yeah.
videos?
Yes, yeah, sure.
Let me see, I might be able to. So if you go on, I wonder if I can, let me stop this share. On my
Yeah.
website, and for some reason my computer is freezing a lot right now. So I'm having a hard time with my mouse as I was doing that. So I'm trying to see if I can switch. So we'll see. But on my website definitely has a lot of different exercises and on social media that you can look at. So there's exercises that will help you, you know, I use the Clock Yourself app that you can be stepping to different targets. You're able to really think of like, there's a podcast from NPR that says Everything Clicks. Great podcast if you want to look at just like motor learning. And what I like about that podcast is there could be examples of how to use the product, but you need to understand what you're trying to improve. What is that task? Once you understand that task, you'll be able to understand what type of feedback and when to provide that feedback. So if somebody's doing sit to stand, I use the clickers. You know, is it during their rise or is it during their sitting? Is it to try to take a bigger step? I do maximal step length test. If you're changing direction, sidestepping. So I work a lot in the transverse plane, having somebody working with turns. So that's another example. I have a video that you can do 2 different laser lights. And then when they see that laser light, then they step to that target to try to increase that angle of step and that center of mass control for that weight shift. So I would probably, sorry, it's freezing right now, so I can't use it, but I would probably go on my website if you're interested, or if anybody has questions, I'm happy to send a bunch of other videos.
Thank you. And you can just put the website here in the chat. That way they can watch it on YouTube and the different resources or podcasts that you want to share for us to check. Thank you so much, Erica. Appreciate
Thank
it.
you. Thank
It's
you.
really interesting. I didn't know about the games that will be coming up. So that's new about the
Yeah,
new
so
shoe. Yeah.
There's a lot of new research coming out. So, but yeah, thank you again for your time. And I look forward to hopefully talking to somebody soon.
Yes, thank you. All
Thanks.
right, that's one of our great innovations. That's really cool. All right, so I just want to check on as well. Patrick is here already, but before Patrick going to present, we have a short video just want to share with you by Monique, all right? So feel free to check it out. Thanks, Erica. Mon, are you available to show the video before Patrick present? Mhm. Let me introduce Patrick while waiting. See. All right. So we have Erica. Thank you so much, Erica, for that wonderful innovations we learned from you. All right, so let me see here. And we have Patrick for our next speaker, but we're going to show a little bit short video later. So Patrick is, we're going to discuss all about the Dizzy Care Network. But before that, just want you to know that Patrick Esmond is a CEO and co-founder at Vestibular First and Dizzy Care Network, and he is the APTA Board of Directors as a public member. So he is a technology entrepreneur and inventor. He is a leading complex projects across multiple industries and stages of growth, have a proven track record of successful program management, strategic planning, innovative and scalable systems, business process optimization, and client relationship management. So he's skilled in managing multicultural, multi-locations teams, and different technology. So I met him in one of the CSM a few years ago, and he has his engineer, and he's showing us because it's vestibular, they are in the vestibular first. We have this ear, the inner ear, Patrick, I remember, and it's so cool. I know it's out right now, some models, the inner ear model. And he is in the process of making it like glow in the dark. So that's
The
really
electronic
cool. And
version.
yes, so he can definitely check with us. All right. All right. So let me see. Maybe I can just share later the video. I'm not sure if Monique can show it to us, but I'll give the floor to Patrick
Sure.
to discuss about why Dizzy Care Network is important, and then why is dizziness is very disabling for us, and why it's important for us to know the different vestibular therapies locally. All right. I have the
That
floor
sounds
to
great.
you. Thank
Yeah.
you.
Just so I'm trying to see if the sound options can come through. It's not letting me share the sound from my computer for some reason.
Let's
Um,
see. Mhm.
so
Oh,
I'm
for
not
us
sure if I have
too.
the right, I don't know if I have the right access. I know
Okay.
Erica was able to do it, but
Yeah.
I'm not, it's grayed out on my end, so I'm not sure if that's going to be a problem or not.
So for us as well, I thought that we cannot share also some of that, but let us see what's your
Okay.
maybe it can play because we're thinking as
All right,
well.
we'll go from there. We'll see if that works, and if not, I can always provide the link to the video
Okay,
after.
let me see. Thank you.
Yeah. Well, thank you very much for having me, Dr. Jenny. I really appreciate the time to discuss the new project that we're working on. We've had this is a few years in the planning. But essentially, we're trying to address a very prominent issue for individuals with dizziness, which is finding the right clinician, finding that first point of contact in order to start their journey. And so we actually bought a technology that was developed at Mayo Clinic because they had the same problem. And Dr. Jenny, let me know if the audio is coming through or not.
Yeah, the audio. I
It's not.
cannot hear. Yeah.
It's not. Okay. Well, I'll share this video after. But basically what it describes is, we can kind of go through the problem for the patient side, is that it's a very complex reason that you seek medical care, but it's frequently undiagnosed or misdiagnosed. And the patients typically undergo unnecessary imaging, lab tests, and specialists before they even get to the root cause. And on average, and this is a statistic from Veda, that the average patient sees about 4 to 5 providers about 6 months, over a 6 month period, before they even get a diagnosis. And that was also the same problem that Mayo Clinic had. They have an integrated dizziness clinic, and they found that they were having patients bounce around their own clinic. And so they were like, okay, well, how do we solve this? So they, just like they have, do we start with ENT? Do we start with neurology? They kind of, again, they bounce around, and that leads to the uncertainty and delay in care. And then essentially the clinicians are frustrated too, because they're there to help, and they end up seeing a patient that they ultimately can't help. So, and this is a post from Veda. This is kind of highlighting why we started Dizzy Care Network. They ended up doing a research. So essentially, they were wanting to do what they're calling an automated triage, which is based on patient symptoms alone, patient reported symptoms. How do we get them to the right clinician before they even have a chance to do any diagnostic tests? And I will post this. This is actually up on our website, dizzy.care. But essentially what they did is they hand coded and then use machine learning and AI to develop thresholds of answers. So they found patterns in a validated questionnaire, and then based on the outcomes of that, they developed symptom clusters, not a diagnosis, but those symptom clusters then help them direct them to the right clinician. So it's pretty clear from the patient side, they have a shorter time to diagnosis. They end up the preferences are determined by the patient, because we did a survey of patients and it surprised me, but the number one thing that they cared about was the shortest appointment time. They certainly wanted an experienced clinician, but they would prefer a 2 week appointment over a 2 month appointment, even if the person in 2 weeks didn't have the same skill level. That surprised me in the data, but I can understand if you're feeling terrible and you just want to, you need to get into somebody. So that's our system also allows that patient to do that as well. We also pre-screen. So a big concern with our medical board was someone going to our site with a stroke or a heart attack and them not seeking immediate care. So we spent a lot of time to make sure that we had pre-screening questions so that way they can get right to the ER if we identify that it actually is a much more serious issue. The other thing is from the benefit side is they don't have to do as many tests or specialist visits. And we hear a lot from the clinicians how busy their schedule is. And this is one way that we can help with that, essentially, is they're going to see the patients that they are optimized to treat. Last but not least, the unnecessary procedures. So there are a number of procedures that some are not that invasive, however, they are not that comfortable either. So by avoiding unnecessary procedures, and also the one benefit Mayo Clinic found is, and this is probably not surprising, but if you give a referral to a surgeon, you are more likely to get surgery. And they found that this route, they actually had a lower rate of surgery because they were getting routed not through the surgical route first. They were getting to a route that had non-surgical intervention first. And that's actually that's a shoe-in for PT in general, because PTs tend to, if they're not the first person to be seen, if they go right to a surgeon, the data shows that surgery is more prominent, even if PT could have solved that in the beginning. All right, so the patient preferences side, this doesn't have audio, so this should be able to show. So essentially from the interface, the patient's allowed to select and sort by our match score, the availability, or distance. And then within that, they're able to view details of the clinician before they even choose them. So they get to see the discipline they're in, they get to see what insurance they take, and then they're able to either select or review the different options. And these are clinicians that have already reviewed the history and have acknowledged that this is a good fit for their clinic and experience. We want to make sure that it's a two-way agreement. So this is not a directory. This is the clinician reviews the patient case first, and then the patient selects from the clinicians that have acknowledged that they're a good fit for the clinic. On the clinician side, there are many benefits. So first and foremost is they get ideal patients. They get patients that are going to be right in their scope of practice, that they're going to be able to help them. So, the example I give a lot is if you're a patient that has Meniere's, your first stop should not be a PT. As much as I love PTs, a PT really doesn't have the tools necessary to formally diagnose or to start your journey. Now, they certainly help on the vestibular rehab side, but the very first step should not be a PT. And there are on the other side, there's a lot of ENTs, for example, that don't do canalith repositioning maneuvers. So if you have a patient that has BPPV, you don't want to, they shouldn't go to the ENT first. They should go to someone who can do the like the Epley or the different different maneuvers. So this is kind of getting the patient to the optimal clinician the first time instead of then bouncing around. The other thing they found is we have a very comprehensive report that's generated, and that report actually we were able to measure this, that the eval times are cut in half. So because this report is so comprehensive and structured in the way that we did, it makes it really easy for clinicians to kind of get right to it. They might clarify a couple pieces of information or ask a few questions that maybe they want to know based on their own experience, but they don't have to guess and start from scratch every time. They're starting kind of hitting the ground running. They also maintain control by indicating their availability. So they are not, if they are on vacation, if they're really, really busy in the clinic, they can choose not to accept the patient, before the patient even sees them. So it saves them phone calls, it saves them, back and forth with scheduling. It gives the clinician a lot of control over their schedule and availability. And this really, this ultimately is about removing the back and forth. So instead of going to the ENT and then the neurologist and then a cardiologist and then a PT and then back, it really just gets them to the right place the first time. So how we started, so this was developed in 2019 as an internal tool for Mayo Clinic, and they have an integrated dizzy clinic. They did not want the same problem that happens kind of in the rest of the world. In 2020, they licensed it to a company called Inno.Health in Denmark, where they did additional development work to make it web-based. The initial tool was built in to Mayo Clinic's EMR and EHR system. So Inno.Health essentially took that and expanded it and made it a website. So that way it was available. Then in 2023, we purchased it. And we wanted to change the scope a tiny bit because InnoHealth, they had a focus on large systems, similar to Mayo. And where we really identified, the biggest opportunity was the independent clinicians and the ones that were the outpatient PTs, the ones that were not fully, not in health system, maybe did not have a full EMR and weren't ready to integrate this. So we ended up, that's kind of where we start today. So we are focusing on independent practices, although the system does support multi-site and large health systems. We want to be able to start from where we see the low-hanging fruit, which is the mobile PT, or I have a single site clinic and I'm starting a vestibular practice. This is a way to get patients that you'll be able to successfully treat. And we did launch this year. This is an old slide. So we launched this year. That is 1 year off. Although we did launch in Philly, we have now scaled out to nationwide. So we are covering, we're launching just in the US for right now, just to make sure that all the pieces are working. But there's no reason why this would not work internationally. Almost all of this is developed. It's all based on zip code or some sort of location. So the clinician has a zip code and the patient has a zip code. And as long as they're in the range that the patient is willing to travel, then that's a potential match. One thing that we're really happy about is our clinical report. So we built this from the ground up. And I have the benefit of being married to a vestibular PT who is very busy, and she really stressed that the very first page of the report needs to basically tell me exactly what I need to know. So she worked with me, although I do have a data analytics background. This is a lot of her feedback on what are the core measures I need right up front. Breakdown by symptoms, triggers, and duration. And so that first sheet, a clinician can look at it. It takes less than a minute, and they'll be able to very quickly see, okay, is this a good fit for my clinic? Now, the report itself is pages long, but we optimized the initial view when you're just determining whether you want to view the patient data or not, or have the patient in your clinic or not. And then the rest of it gives you, it's the full DHI. We have other validated instruments as well as ear health, eye health. We go and we ask, it's pretty comprehensive. Although on average, it only takes about 10 minutes for a patient to fill out. And they can do it all from their phone, a tablet, or their computer. And we designed it also to where they can start from their computer, continue on their tablet, and then finish it on their phone. So it's device agnostic. You can switch between the devices, between each session. You can do 10 minutes, take a break, go back. Oh, you're waiting in the waiting room somewhere, pull out your phone, and it'll pick up right where you left off. And then it'll continue the process. So where we're going from here. So we have our Greater Philadelphia launch, and then we're building research grade data. So we want to be able to, right now we have 10 symptom clusters, and we want to expand that to the full 28 that we know have a symptom of dizziness. And we're going to do that by essentially having the clinicians who are using the system help us train the data. So essentially, once the patient comes in, after that appointment's confirmed, they will say, oh, yep, actually it was BPPV, or, oh, I actually found this and I found this. And then after that information gets in, we'll be able to essentially retrain and improve the algorithm, not only to match the patients better, but also identify symptom clusters that were not part of the initial Mayo Clinic pilot. And the next level after we are comfortable with that being that kind of running smoothly is really working with primary care and emergency departments to make sure that after they have screened and ruled out the more serious issues that have dizziness as a symptom, that they refer them to us, and then we help generate the referral. And they can work, our system can generate the referral, get signed off by the primary care, and then get them to the clinician they need. So that's going to be after we have a little bit more time in the market and make sure that everybody's happy. I want to make sure the patients are getting matched and they're happy with the system. There's no confusion in any of the steps. And then we also want to make sure that this is something that's going to work for the clinicians. You know, they're busy and they have a lot going on. So we don't want this to add any administrative burden. We only really want this to improve their workflow and improve outcomes. And that's pretty much it. So right now, everything's live. So if there's clinicians in the US that want to join, just go to dizzy.care, click I am a clinician, and then you can fill out the pre-registration. We do have some baseline level of experience that you need, but most clinicians with 1 to 2 years of experience and if they have some additional vestibular training, you don't have to be an expert in it, but you need to have a little bit more than just what you got in school. And as long as you meet those requirements, then we're ready to have you as part of our network. And that is my presentation. Thank you very much for listening.
Thank you, Patrick. Yeah, so this will be more on clinicians based. Doesn't need to be occupational therapists, physical therapists, as long they have vestibular background and
It's
then a little bit
multidisciplinary.
advanced. Mhm.
Yep, it could be anybody. We have, as long as the goal of our system is to get them to someone who can help provide a diagnosis. And this is not about whether a PT is allowed to this is not about gatekeeping about who can and can't. Our
Mhm.
system doesn't really care about that. Like, even this is not an insurance thing. This is there is no reason why a PT can't diagnose BPPV with the right training. If they have the right skills and tool set, then they're able to go back in and they're able to be a clinician in our network. If they do not do diagnosis, whether formally or informally, then if they only do treatment, for example, then they would not be a good fit because our initial goal is to get them to find a diagnosis.
Yeah. Yeah.
Yep,
So there's
exactly.
an ENT in the network too. You say
Oh
something
yeah,
about the ENT.
we
Yeah.
have. Oh yeah, we have.
Audiologist, you know.
Yep, we have ENTs, neurologists, and the one group that is often forgotten here is the psych group. So we have
Oh,
psychiatrists and psychologists as well, because
interesting.
that actually is, and if it's not a primary cause, which it's rare, but it does happen, kind of a psychosomatic response.
Mhm.
At the very least, a lot of people going through this have a lot of anxiety and it triggers a lot of items. So we have a way for them to be internally referred to those who not only have specialty in dizziness, but also on the mental health side.
Good point. Yeah, because even I say also the audiologists because they're
Oh,
different than
audiologists. Yep.
different than
Yep.
the ENT, and then they made it now with the vestibular rehab network. It's new to me about the psych. See, that's why good that
Yep.
you emphasize. I didn't know that they can be also in the umbrella. Especially that's a good point.
Yeah, it's not as common for that to be the primary
Yeah.
reason, but it's almost always goes along with having, I mean, if you think about it, any kind of
Mhm.
disease is going to cause anxiety and stress. And
Oh, okay.
now, again, there are cases where that ends up being the primary reason, but we have them included, and that was actually built into the Mayo model as well. That was really important for that part to be included. But yeah, so the one change that we did, so Mayo, the way they had it designed is um, they had every discipline had kind of mutually exclusive tests. So, ENT did these tests and audiology did these tests, and everything was kind of bucketed. We recognize, and that's kind of one change that we did in our system is like we know that there are vestibular audiologists, there are vestibular PTs, there
Yeah.
are ENTs that want nothing to do with positional testing, and that's fine.
Okay.
Like they just focus on Meniere's or superior canal dehiscence.
Ah.
So the idea is, let's say I'm an ENT and I don't want to see positional vertigo patients, that's fine. Like when you register for your account, you just don't select any of the positional tests as things that you want to provide. And then our system will not route you patients with positional vertigo. But if you're an audiologist who does, regular audiologic exams, but also do positional testing, then you're going to get the positional vertigo patients. You're going to get BPPV in addition to some Meniere's, because you need to be able to confirm it with an audio test with Meniere's, for example. So we are multidisciplinary, and then we also, it's on a per clinician basis. So, and let's say that you're an audiologist who then adds vestibular. You just log into your profile, add the additional tests now that you kind of meet our baseline level of skill, and then any new patients in your area that need those services will get matched to you. So it grows as you grow as a professional and you add skills and experience, you will grow as well in our network.
Yeah. So do they, excuse me, do they need to pay for the as part of the network, like something like in their account?
So right now everything is free until we figure out that it works. And I'll be very direct about this. Like we know it works inside a pretty insulated setup in
Mm-hmm.
Mayo. This has never been proven to work at scale. So right now we want to make sure that the matches are working correctly and that
Nice.
the system is working. At some point we will have some sort of monetization, but whether that ends up being a monthly thing that people just pay. Maybe it's on a per
Okay.
referral. We've also had patients reach out to us and say, "Hey, I would pay you for my kind of report, like a very
Okay.
consolidated, analyzed report, and then you give, instead of a list of anonymous clinicians, give me a list of all the people in my area and
Around
your
it.
rank score." So we left the kind of business model after we proved like this is like what's called a minimum viable product. Like we
Mm-hmm.
want if the matches are not working, then no business model is going to support it. So right now it's free, and it'll always be free to have a profile. So that's something that we definitely see a benefit of if let's say that you have a I don't know an uncle in Nevada, if
Okay.
you're a clinician in our network, you will be able to log in
Okay.
internally and then actually help find someone for your uncle within the network, and you'll be able to see all the tests they can do, the level of experience, like a very very detailed profile to be able to do internal referrals, and that will always be free.
That's really good. Thank you so much, Patrick. That's really very important nowadays, like a
Thanks for
proper
having me.
platform. My pleasure. So I like when you emphasize they don't need to go to a surgeon or this and then they will, because that's their expertise. So let them be diagnosed with the specialist and then that's the closest range, knowing it's different dizziness and everything. Thank
Yep,
you. We
absolutely. Thank
appreciate
you so
your,
much. Yeah, have a great rest of your seminar and thank you for including me.
my pleasure. Thank you for all you do. All right.
Thank
So
you.
that's
Have a
really
great rest of your
appreciate.
day.
You
All right,
too, you
bye-bye.
too. Bye for now. If you have question, connect with Patrick. Patrick, please put your
I'll put that in the
email,
chat.
the vestibular first, your email
Yep,
on the chat. And
will
also
do.
after this, we will send the recording to you guys and we will put all the emails of the speakers in the summary of all our recordings via email. All right. So
Thank you
thank
so
you
much.
again.
All right.
And Monique, if you are available, I will give you the floor so you can share a short like video before our next speaker, Natasha. Okay? Go ahead. Let me see. Mm, yeah, it's not really. We cannot hear it. Yeah. I don't know. Oh, okay. So we just want to share this nice video describing what is vestibular. migraine versus dizziness, but we will just forward this to you guys. Looks like we cannot hear the audio. We cannot hear also the audio. Good, the other speakers was able to share this. All right, that's okay, Monique. We'll send it via email to them. All right, thank you. All right, I'll just introduce Natasha now. Thanks, Mon. Mhm. All right, so we just ended. Patrick, thank you so much for introducing us to Dizzy Care Network. We appreciate you and all your work, and also Helena's work for vestibular rehab, rehabilitation and neuro. All right, so we discussed about Optimus PT. They are physical therapy EMR software that we learned this morning with Carlos Garcia Cuesta. If you are in outpatient setting, guys, connect with us and you will have email me and we can book a free demonstration with Carlos. And they have an AI scribe, so it will be a very fast like EMR for your outpatient setting. And for our last speaker, we have Natasha Williams for Phoenix Hipwear. She will going to discuss about innovative fall protection technology, a great hip protectors for aging adults. She's based in New Zealand, and Natasha recognized for her expertise in fall prevention, co-authored the clinical paper, and served on National Osteoporosis Foundation's leadership teams. She developed an advanced 3D printed hip protector with impact lab and carbon and remains committed to helping aging individuals stay active and independent through Phoenix Hipwear. All right, I'll give the floor. We're so fast paced right now. Our time is earlier than expected, but that's okay because it's already midnight in your place, guys, in Asia. And definitely we have Natasha. Thank you for your flexibility, Natasha.
Of course.
What's the
No
time
problem.
now in New Zealand?
It is 7:50 a.m. on Sunday. So I've started my Sunday now.
All right. Yeah, we are still Saturday. Good
Yeah,
one.
you're getting ready to go relax for the evening, and I'm
Yeah.
just yeah,
And
I'm done
Sunday
myself.
now.
Sunday
Sunday
now.
now in Asia. All right.
Yeah.
Okay. I'll give you the floor. Thank you so much, Natasha. Welcome.
Thank you, thank you. Hey, it's wonderful to be here. Appreciate the opportunity to share what we're doing with Phoenix Hipwear. I understand that you've all had some amazing sessions, and it's been a long day, so I'm not going to talk for too long. So let me just make sure I get all that ready. Why is it not letting me share sound? Okay. It's not going to let me share my sound, but that's
Yeah.
okay.
Even us, yeah.
Yeah, okay. No, that's fine. I'll just talk whenever there's people talking that I know the script so well. I'm just going to hide my little floating control. Bear with me for a minute while I hide all my there, then I can actually see what I'm doing. Okay, so yeah, hip protection. I'm going to presume a little bit that most people have heard of hip protection as a concept, a shield that sits over the greater trochanter area and helps to reduce the risk of a hip fracture and fall. And I'm going to talk a little bit about where we've come and how ours is very different to what you might already know about hip protection. Yeah, we always talk about now our product is all about it's so slim, you'll forget you're wearing them, but obviously incredibly strong. So if there's a fall, you'll remember why you were wearing them. So move my screen. Let me move that. Okay. Won't go into too much detail because I know you all know that hip fractures devastate lives. The projected numbers by 2025, which we've just obviously going through, was going to be around about half a million hip fractures in the US. Around about 9 out of 10 hip fractures are the result of a fall. Yes, there are some spontaneous ones where people are so osteoporotic that they move. We can't help with that. This is all about the falls, hip fractures. So obviously statistics are terrible. We all know around a quarter who have one die in the year following. Those people who were living previously in their own home often cannot return to their own home and need to go to a care setting. And then what we also look at as being a really a terrible outcome is those people whose mobility and life is affected after the fact for an ongoing period of time. And many people can't even walk across a room unaided, certainly can't go about their everyday activities. Underlying causes are generally for hip fracture or the condition that's the problem is osteoporosis, low bone density. 10 million people around about in the US at the moment. Globally, in Asia by 2050, osteoporotic hip fractures are going to be a major concern, and around about half of all hip fractures globally are going to be in the Asian region. So osteoporosis is the concern. Around 40 million in the US at the moment with low bone density. And then Alzheimer's and other dementias are a cause for falls and a higher risk for falls and fractures. So all of those conditions are kind of underlying the type of people that we look after. And obviously they fall into the category of a lot of the people that many of you are looking after in some capacity. I wanted to just talk a little bit about the component of fear. And the reason being is, yes, there are terrible outcomes. There was a fracture, there's hospitalization, there's lack of mobility, but fear is a major one that I hear all the time when I'm talking to customers or to medical professionals, PTs, who are looking after the people. So it's a diagnosis of osteoporosis or low bone density, a diagnosis of a balance concern, a diagnosis of aging, which none of us want to talk about, but any condition that starts to sit in the aging space, we start to have fear. Fear of falling. What does that mean? Someone with an osteoporosis diagnosis or low bone density has significant fear of falling. Now fear of activities. All the things that make life fun and make life good, now we're scared of doing them. The fear of the end of your plans. Many older adults are getting to their 55, 60, 65 onwards, and they've got great plans because they've worked their entire life for this moment in time. And now they've got this fear, do I have to not travel anymore? Do I not do that hiking trip with friends? And a real fear of being old. You know, we do a lot of work to stay young, stay active, stay mobile. And one of these diagnoses, one of these conditions start to put like a real shining spotlight over your head that says you are old. And that's a really negative thing nowadays. We don't want to hear that. Fear of overwhelm, so many things to do now that I've got this diagnosis, and how do I manage them all? And who do I have to now reach out for? I've been independent my whole life, and now I'm supposed to ask people for help. That's a really hard thing. I get a lot of anger from people I talk to, anger that they, especially when I'm talking like the younger active woman, either why didn't I know until I was 65 and had a DEXA scan, why didn't I know that I was at risk for osteoporosis? But I've been doing everything right. I've eaten well. I've exercised. I've run all my life. Why now when I've done all the right things? So all of that is all valid, and they really sit around the actual tangible physical, I've now got a broken hip, or I now have osteoporosis. And we always talk about not letting fear stop you living your best life. Now, it's a lot easier in the younger active women who have got a diagnosis of, let's say, low bone density, because it is about let's do something so it doesn't get to the decline end. Obviously, the more frail end, it's more of a concern. So some of you are familiar with traditional hip protection. I always say hip protectors, generally, there are a few out there I wouldn't choose, but generally hip protectors work. I have no issues with hip protectors. Hip protectors are a great concept. The challenge has been getting people to use them in the first place, or getting people to continue using them. Often they have used old school technology, so primarily foams of some sort, So they work, but in order to work, they have to be very big, very bulky, and can be uncomfortable. And certainly in a younger person can be very unattractive. So our solution, this is the active version. I'm going to talk you through the different model options we have, but that's really as simple as it is. A comfortable garment, put it in the pocket on the side of the shorts or the underwear, depending on what your need is, and within 10 seconds, you've got that protection there. Don't have to wait, no side effects, don't have to wait 6 months for it to be effective. It's immediately effective. We looking at research that's been done in the past. There's a lot of research out there with hip protection and a lot of conflicting advice. But generally, when hip protectors are worn at the time of the fall, if they're biomechanically sound, there's around a 69 to 80% reduction in the rate of hip fractures. So I always say this is not a one thing fix it. We are one more tool in the toolbox, one more tool for PTs, for OTs, for health professionals, one more tool for senior living, one more tool, not the entire solution. These are some photos of people who are wearing our active range, either just as their own shorts, under running shorts, under leggings. They really are incredibly light. Less than 2 ounces, so around 50 grams for those of you who are metric. So very, very light. So you really, they don't drag down. You barely notice they're there. Very, very thin. So 10 mils or just kind of under 3/8 of an inch. But being such a small measurement, we use millimeters for engineering. So very slim, flexible. So the shield flexes and forms. It softens when it's worn because when the material is warm, which warms up on your body, this becomes even softer and it really does wrap around and so it's very unrestricted and breathable. I don't know if you can see on here, but you can see on any of the pictures we have on our website, it's a lattice structure with holes all the way through. So it's very breathable. It means it's cool and comfortable to wear. It's not like a big heavy thing on the side of your hips. Okay. You're not going to be able to hear this, but I'm going to narrate it because it's actually me here. So you're going to watch me. We did testing, which I'll go through in a minute, but a lot of people aren't engineers. They don't understand newtons of force and all those types of things. So we wanted to show a demonstration that how does it work? If we put something this thin, people are skeptical. If we put something this thin in over our hip, is it actually going to provide protection? So I'll play this and you'll hear me talk. Can you hear that? You can't hear that?
Flexible shields.
Okay.
Are light.
Oh, you can hear
flexible.
We can hear.
Very, very comfortable. They sit over the vulnerable hip area, held in place in the pockets of specially designed underwear. In a fall, at the moment of impact, the shields will instantly provide a protective layer to absorb and disperse the impact energy and to help reduce the risk of a hip fracture. Now let's see a demonstration of just how protective these shields are. I'm going to drop this bowling ball onto this block, and first I'm going to have the shield in place for protection. And then I'm going to remove the shield and we'll see what happens. You can see what amazing protection the slim, lightweight, flexible shield provides.
Okay, so yeah, not a scientific test, just a way to show that it genuinely takes a lot of the force in a fall. It takes a lot of the force if for whatever's behind is protected. Okay, so it's great that it's flexible, it's soft, and we have a great video, but does it work? Because it doesn't matter how nice it looks and how comfortable it is if it doesn't work. So the first thing is there is no global standard for hip protectors. So I would like to change that in the future. So watch the space. But obviously just the fact that there is no global standard and we don't have to do a test isn't good enough. So we actually did a variety of biomechanical tests. So we work with an impact lab. They're called an impact lab company called Impact Lab, and they are based in New York, and they're an engineering group who test for impact protection. They do helmets and do some stuff with the military and various bits and pieces. It's all obviously we set up test rigs with weights and the shield, and we drop weights, and we have sensors which record force and attenuation of force. In a straight drop weight test, we had 82% force reduction. So 82% of the force was taken from the hip protector. So what you can see here, the readout shows if you don't have a hip protector in place, it's a very sharp, sudden, high force. Here's where we sit. We were testing other 3D thicknesses to see which one we could get to that had a good both comfort and performance, as well as some competitor products to make sure that we sat comfortably in the same range, although these are obviously bigger and thicker. We also, the VA recommend hip protection veterans. They have a guideline that say if you are going to use a hip protector, use one that shows a test. They've got a specific test that they recommend that shows a 50% reduction, and ours shows a 62% reduction, so well over that. There is a global standard. If I was selling this as a motorcycle hip protector, it would have to pass the EN 1621-1 test. We did that. There's a level 1, level 2. Level 2 is for extreme motorcycling coming off at speed. We well and truly passed level 1, and we were small percentages off actually level 2, which we were surprised at. So we have a lot of biomechanical testing around it, and anybody who is an engineer or who wants the testing, I've got a full presentation on testing, and so happy to jump in on a call at any point and go through a presentation with you and give you those results. Okay, so just really want to quickly talk to you about, I know that some of you who are in this summit are looking after or servicing the more active, younger aging adults. Some of you at the more frail end with senior living end of active adults. So our product sits across both, and I just want to explain what those differences are and how you might utilize it for who you support. So on the active side, we're talking about younger, they're self-sufficient, they're more active, they're generally, it's an osteoporosis or low bone density need. So the shield is the same shield. The same shield supports both. It's just the garment that's different. These people on the active side, they're only wearing them during high-risk activities. So it might be once a week when they go mountain biking, which is what I have a lot of customers. On the other end, we have those who are assisted. So that might be in a senior living home or in their own home. They are older, more care reliant. They're either not active at all or they're less active. Slower reaction time, might have the balance concerns. They're looking at hip protection. Again, they've got a fracture risk. They're also a falls risk. These people over in the active are more just a fracture risk. But they're also something that's more a comfort, practical needs, incontinence, etc. So we have underwear garments that serve that population. So again, not old and frail, definitely not old and frail. They don't even want to think about the words old. They don't even want to use the word seniors. Some of these women who I have as customers who I get to know late 40s, early 50s. They've tripped and fractured something and gone and had a DEXA scan and found out that they've got osteoporosis. They are mountain biking, cycling, hiking, walking, playing pickleball, dancing, you name it, they're doing every activity out there, and they are not planning on stopping. They have no intention of sitting down in a chair in the corner and becoming old. So they want to age in place, they want to age confidently, they want to age positively, and they want to carry on their active lifestyle. So these are active shorts. You can see our pictures, and on our website, we've got a lot of pictures of people wearing them as just shorts. They are a like a little yoga short. They're an athleisure fabric. They're incredibly comfortable. They're snug fitting. They're moisture wicking. They are literally a short you wear for activities. You can wear them under or over leggings. You can wear them on their own, under hiking pants, under pickleball skirts. I have someone who wears them swimming because he is worried about falling around the concrete edge of the pool. So there's got a lot of feedback. What they're talking about, it's all about not showing, not bulky, under normal clothing, forget they're wearing them. That's their focus. So if you look after that group, that is the garment that's going to be more likely. Hopefully you can hear this one. This is just a quick testimonial from one of my lovely customers who gave me some feedback after falling.
Whenever I go hiking, I wear the Phoenix hip protection. Back in the spring, I tripped and had a hard fall on some rocks. And at that time, I landed hard on my hip and also on my face, breaking my nose. I was able to get up and I was able to walk 5 miles to my car, which I really don't think I would have been able to do if I wasn't wearing the hip protection. I won't hike without them, and I think that they give that extra level of confidence that should we trip and fall, we can get up and continue walking.
So that's one of my more active. She goes all over the world, hiking, biking, all sorts, and sends me videos along her way. We have some people who are just cycling around their neighborhood. We have some people who are just walking the dog. But that's that active market. And then now we also support those who are high risk, either at home or in a senior living. Now they are high risk for both falls and fractures. They need protection all day. Some people are wearing them at night. So with that, it's a functional underwear garment. It's a full fit underwear, 95% cotton. It's really comfortable. It can fit over top of incontinence products. Can be washed in commercial laundries of a senior living community, a senior living laundry. So it's a really functional underwear. Same concept, pockets on the side, same shield, slips in. So the same amazing shield for active is also used for our seniors in senior living. In this situation, if you're looking after these people, you might also be looping in their family, the caregivers who are involved in making decisions or helping them make decisions. So we have a lot of conversations with families and a lot of conversations with staff at senior living. We work with a great group called Silverado, who are really seen as the gold standard for memory care, and they have them as a integral part of their falls management program. This next slide, I just want to talk through. We are working with an amazing group called Pegasus Senior Living. They have memory care, assisted living, independent living in a number of states across the US. And we started working with them 8 months ago. They are fantastic in that they are giving it as a gift to their memory care residents. That's where it started. We're looking at expanding now. But so they are paying for it, not on charging the family, not making money off it. They see this as a vital implementation for their memory care residents. At the moment, we've just started, as I say, early days. Around 150 residents are currently protected. Average fall rate of around 27%, some months 40% of our, when I call them our residents, the residents in Phoenix. So these are regular fallers. These are not people who are, sitting down and never falling. They are falling often. At this point, 8 months in, we have 0 hip fractures with anybody wearing Phoenix hip wear, which is really, it's obviously very heartwarming. I'm doing this to help people stop fracturing their hips, so it's a wonderful outcome. As I always do say, we never guarantee 100%. It's one more tool. They have an amazing falls prevention program and falls management and great staff who support that. But at this stage, 0 hip fractures. And we, as Pegasus, as the Senior Vice President, Dr. P says, they know falls and fractures are a problem. They are having falls and fractures in the Phoenix wearing residents, so they know it's not just that they're not having fractures at all. So we are now looking at expanding that broader because we've had such great results. So really encourage you, if you are working with the senior living side, I mean, reach out to me. We love looking after the frail end of the more frail, more high care needs. Before I finish up, because that's really an overview snapshot. I can go into a lot more detail with anybody who's interested, but I don't want to take up too much of your time, and I do want to leave some room if you've got questions. We have a great affiliate marketing program for PTs, OTs, anybody who supports and looks after from active through to senior. You don't have to worry about holding stock. You don't have to worry about processing orders. You don't have to worry about any of that stuff. We do it all. We simply give you a link. Some people have an online community. Some people just have a physical. I have got some people in my group, some PTs who have both a physical clinic and an online osteoporosis support group. And so whether you're sending people from your website or sending people from a physical place, you get a code, your customers get a discount on anything they buy, and you get a monthly commission, and that's all handled by us. One thing that we are just about to launch, and Dr. Jenny, we need to talk about getting your expert setup done. So what we are launching, because we're getting some really great experts now being involved, I'm going to give you a sneak preview of Dr. Lisa Moore, and this is where it becomes a more, we'll say yes to that. Hopefully you can see this. Can you see this website? Can you see the web? Is it going to the website?
It's not going to the website. It's still on the affiliate program poster.
Okay. Okay, well, look, I will, let me think. Let me just do this. Okay, bear with me for one moment. Stick there. I'm going to share. Okay, can you see that now? Okay, so what we're building is landing pages for our experts. So this is Dr. Lisa Moore. Our website sits behind here, so everything is there. But instead of you sending someone directly to our website, and they leave you or your website or social media, this is just a really nice soft landing, so that it supports the people you send here, and helps them to understand that the message is supported. So a nice picture with whoever the expert is, some information all about the product. And then here's our different experts. So at the moment we've just started with, we've got Dr. Beth Wagner, Margie Bissinger, who's an amazing PT and has an amazing Happy Bones, Happy Life program. Osteo Boston, this is part of, I think it's said earlier, I'm on the corporate advisory roundtable for Bone Health and Osteoporosis Foundation. They have some amazing community support groups. So this is Shelley, who runs the Boston group, and she's also very active. Claire Gill, obviously, we did a great, I've known Claire for many years, and we did a great podcast on her bone talk. So we'll be adding to the experts more information, so people know exactly what they're looking at, and great reviews. So these are all, verified people who have bought our product. And then down the bottom, when you join our program, we give you a product, we'll give you a product sample, obviously. You can do a review. This is Dr. Lisa did a review before she became an affiliate. She said, I'll do an open box review and I'll post it, but I don't want any affiliate program at this point, because I want to genuinely say whether I like it or not. She did, she loved it, and she's now works with us. So some people, they don't want to do a review, they want to do an interview or a podcast. I know that Dr. Jenny and I did a interview, so then that goes into that space. So that's our experts program, and so we're really keen to get people involved in that. So if you, whatever aspect you are working across, from the active to the seniors, do let us know. we'd really love to work with you, get you in the program, and help you support your people. So that's us really, and we do actually have some younger women who buy it for themselves and for their elderly mother or grandmother. So we really can support, whole families, which is fantastic. So that's all I want to talk about at the moment. I hope that's been helpful. I will put my information in the chat if I can get back to stopping the share. I'll put my information in the chat. If anybody wants to reach out, that would be absolutely fantastic. Love to talk to people. Oh, hello, Taylor. Nice to see you. I can't type and think at the same time.
No problem. Thank
Jumping
you
in.
so much, Natasha. Just put your information there. No problem. Take your time. And after the event, we will going to share to them the recording and all your information like the Natasha at phoenixhips.com will be there on the email. In the recorded emails and everything. That way they can always go back if they have specific questions, and definitely they can connect with the speakers if they have questions for a certain part. Definitely. This is really nice, the videos and the website. So you mean, let's say I'm an affiliate myself. So there will be like a part that I can share this website because my name will be on the soft landing and the rest of the other clinicians. Oh,
Yeah.
okay. Okay.
Yeah, so absolutely. One of the things that you're on my list of people I've got to speak to is because this is a new, because we started with the affiliate, we've started to get such great response from people.
Yeah.
And people want to join. So what I'm all about supporting whoever we work with, obviously supporting our customers and the end user. I jump on calls with them all the time and I love my wearers. But it's also about supporting the people who are supporting them. And so that's why we decided, you know what, let's create the actual pages for them. So yeah, when I'll be sending you an email to say I would like a picture of you in some nice active space and or doing something interesting, and a headshot, we put it up there, we create that page, we give you that specific link. It also means that the whole discount for the customers, for your customers, is built in behind that. So they go to that link, they buy, they look at it all, they've got all the information, everything in the website they want to buy, and then it just automatically applies your affiliate code into their order. They don't have to do anything. So it's really straightforward. So it's just about making sure the customer gets every information they need, and that if they've come from you, the first thing they see is you, so that they feel supported that, yeah, I was meant to get to this. This makes sense. This is what Dr. is talking about. So yeah, we'll get you set up.
Thank you. So we are globally watching right now. So which areas this is not yet available? So
Yeah, good question. 2026, lots of places. Right now, we have our warehouse in the US and we have a warehouse in New Zealand. We ship from the US to Canada. Canada, anyone who looks after them in Canada, talk to me. We have customs that change regularly, as you all are aware. So that the last one was a really easy, low-cost customs. The one before that, they got charged a lot, so it gets complicated. So the answer is we do ship to Canada. We just usually have a conversation first so everyone's aware of there could be big customs charges. Anywhere in the US, New Zealand, we ship to Australia from New Zealand. We are now working on how do we support other regions. I've been asked about Singapore, so anyone who's in Singapore. I have shipped to France and the UK for people who wanted it and were prepared to pay the shipping and the thing, but we don't have physical warehouses up there at the moment. My goal in 2026 is to get more physical warehouses in different locations so we can support a broader group. But we launched the new Shield in February, March of 2025. We launched the Active program in the active shorts in June of 2025. And so things have just gone really busy very quickly. The response has been amazing, which really supports what I've always known, is that if we can make something slim, light, flexible, comfortable, but high performing, people will wear it. And if we make something for active younger women, they will wear it because they are looking for solutions, because there is nothing out there that they can incorporate into their hiking, biking, pickleball, etc. So yeah, so watch the space. 2026, I'm hoping to get more global regions.
Congratulations, Natasha. That's very quick. 2025 June and then more active. So this is available an assisted living facility, active aging adults. That's really nice that you cover the active and the older adults, because it's always a stigma that we're always thinking, oh, that's only for old people. They will fall. It's not. It's really for even the active people. But I'm amazed with your video. She's a hiker. She's hiking, and at her age, I told to my daughter, she's sitting with me a while ago, Mommy, you cannot even walk like or run like that. She's teasing me.
You sent me a picture just about a month ago of her on the top of a very tall mountain in Kosovo, where she had just been walking. She had done a bike trip in Croatia, and then she hiked in Nepal. She is the extreme end, I'll give you that. But look, I've got loads of videos of these women who are giving me videos. I mountain bike. I mean, this one woman who mountain bikes, she said that most of the group that she mountain bikes with are 80-year-old women, and they're out there in the forests mountain biking. And this is the great thing, we are in a great point in time where aging doesn't mean at 65 or 70, we stop, we slow down, we sit in a comfy chair and we read a magazine. It just means we look at what we need, we implement products and services, and then we go out there and we live a vibrant, amazing life. And that's what Phoenix is all about. It's about, don't focus on the fall, don't focus on the fear, focus on what you can do, and it's the resilience and getting back up. It's all about not letting the fall keep you down. Get back up and keep living that life. And for some people, it's the life that they lead at that point is a senior living community, but still they want to be able to walk around the community. They want to walk outside and look at the gardens. They want to go on the day trip down to town. They want to do those things. And so however big your world is, it's about getting out there and still getting to live it, even though you might be aging, even though you might have osteoporosis.
Thank you. Thank you for your hard work. I'm not sure if some people will ask, although this is a hip protectors and it's only on the sides, the 3D. You explained it to me well before, like why the hip protector is only on the greater trunk sides. How about people who really landed on their butt and then the coccyx bones? We have cases, they have a pelvis and the groin area is the one affected. So what is the statistics why you put it on the sides versus the back, like on your butt?
Yeah, so the greater trochanter, the fall onto the side, that is what's causing the hip fracture as such. And we know that 9 out of 10 hip fractures are the result of a fall. And it's that hip fracture that can cause such devastating outcomes, death and disability, high cost. The answer I say to everybody is we can protect lots of body parts. I have people asking me about shoulders and elbows and all the rest of it. We can do all that. It's about where do we start, and what's the primary concern at this point is hip fractures. They're the one that causes the major problem. And so we started with hip fractures, we started with hips. With regards to garments, for example, in the active side, we have an active short, like a little yoga short. I get asked all the time, what about specific bike shorts? What about yoga leggings? What about long pants, pink pants, purple pants? All that will come, but we had to start somewhere. And so can we develop a garment that has a space in the back for a protection that sits over the coccyx there? Yes, absolutely. Absolutely. We just haven't yet. This material is incredible. I know I didn't go into a lot about the material, but it is an amazing 3D printed lattice structure. It has such incredible properties, and the ability to be so slim but so high performing. Yes, we can make coccyx. I do get that sometimes. So again, I keep saying, watch the space. Let's get hips protected, and then we'll keep going from there.
All right. Thank you so much. Amazing. That's the technology and that's the innovations, guys. So if you have any questions, connect with Natasha. She wrote already in our chat, Natasha at phoenixhips.com. And if you want to do some affiliate program as well, connect with her, especially you're in US base or Canada and New Zealand. So share it with your colleagues and also your patients. All right. Any closing remarks, Natasha?
No, I'm just putting in our websites. We do actually have two websites. So phoenixhips.com is our main website. If you are looking for active, you'll actually see on there's two versions. Do you want active or do you want senior? If you click on active, it's going to take you then to our active website, and senior, you'll stay through the senior website. So you can get to it just from phoenixhips.com. But if you are just interested in the active side, if you just go to phoenixhipsactive.com, and I've put both there, they'll take you directly to our active site, and everything on there is all about active. And just a quick note, I talk a lot about women. Our active shorts are a woman's style. But within that active and within the Phoenix Hips, we do have men's underwear. So we do look after men as well. It's just women are overrepresented in the younger active osteoporosis space. Half of a woman over the age of 50 will experience an osteoporotic fracture in their lifetime, 1 in 4 men. So it's definitely, so that's why we do look after both. Just want to say that. The shorts, though, are a woman's style.
Yes, yes, that's true because we just have cases of male hip fractures as well. And it's more disabling sometimes when they hit them. They're really disabled because they're very active. They feel also the ego of having a fall. But we have many cases of falls. They're doing lots of activities on the roof and fell on the ladder. You know, they're so active and
When
then
they don't do that.
yeah, it's just a sudden change, just one mistake, and then overall, and that's the goal of the. I remember from our podcast, you said this is not really preventing the fall. This is just in addition of you not to be disabled or having a very sudden bad effect of some situation that you will have a life sudden life change or something like that. Because let's say because of the fall, you have lots of things unable to do. Like what will be our sample here? She fell, but because she's wearing the Phoenix hip wear, she was still able to walk 5 miles, which she cannot do if she really
Correct.
fell unsupported. So we love those stories. So we
Yeah.
can fall, of course, but our goal is to prevent the falls by doing more education as a
Correct.
therapist.
Absolutely.
Continue our strengthening program, continue your balance training in your community, and then this is an adjunct that this is available. Share to them, especially for our hormonal imbalance. That's why the females are more because of the osteoporosis, decrease in menstruation or the period, the hormonal level. We are at high risk. But still, our men are still high risk because of activity wise, they are exposed. And the cyclists, the motorcyclists,
I have a lot of cyclists, who still want to cycle, and that's great. They just put on the protection. So yeah, it's all about. I mean, we do say do the falls prevention. Obviously, I keep saying one more tool in the toolbox.
Yes.
We can't stop the fall. And if you're doing everything to stop the fall, that's great, but you can't predict or prevent every fall. So make sure you've got the injury prevention piece, and that's what we are. It's the injury prevention piece. So you can just get back up. A fall is just a fall.
Yeah, in the same way, we also don't just teach them how to prevent from falling, but we also want to teach them in our sessions as a physical therapist. I always emphasize teach them how to get up from a fall because we want the piece of that too on the intervention. And then this one is very important for them that, oh, it makes sense that this is available, it's not good that you're aware of something is available and you're not sharing that it's available, so it's always be an educator to your patients. All right.
Yeah.
I appreciate your knowledge, Natasha.
Thank you.
Congratulations in this innovation.
Thank
And
you.
I
Yeah,
appreciate for your support as well for the geriatric rehab summit with
of
us.
course. I appreciate you allowing me to come and join you all. So have a wonderful rest of your Saturday and enjoy your Sunday. I'm going to go and enjoy mine.
Yes.
I'm
You
letting
are
the
our
gas.
last speaker. Yeah, so we're closing the event right now. So guys, if you have any questions, any concern, definitely we can always connect with you. You can connect with me in Jenny21PTRP at gmail.com. That the one that's sending you those like reminders, that's my email. If you have any questions, definitely connect with me. And also, if you find value in our course, in our summit today, definitely I appreciate you. And if you can just share, you can also like donate in the Future Foundation for that. All right. So again, thank you, Phoenix Hipwear, the protective shields, comfortable garments, is a hip protector, and Copa Healthcare. Thank you so much for supporting us on the Geriatric Rehab Summit. And if you have any questions, connect with us. And if you find value, please donate and support our cause for the Future Foundation Global. It will be our first time to join the APTA CSM next year, in February, for the CSM in Anaheim, California. So we will have a booth and then $5 or $10 support direct to the Future Foundation organization. It's a nonprofit organization. So I'm just their treasurer. So I'm just delivering a message. So I'm doing these things for educational and at the same time to connect with you. So this will be straight to the Future Foundation. If you are interested, thank you so much. And if thank you for your support. It's me again, your host. So supposed to have one topic. Unfortunately, he needs to go somewhere, and there's a it's a shockwave therapy. So there's a burial that he needs to attend. Maybe a family or a friend, family member. There's a burial, so unfortunately he cannot make it. But we will going to send. I asked him to just to send a short video about his shockwave therapy, so I can include that in the email for you guys. I really want you to learn more and be aware of these are the innovations that is happening nowadays, and we would love to be on the in aware of those things. So it's me again, Dr. Jenny Yusuf. I'm the founder and summit host. I'm founder of Balance and Fall Support Group in Aging Adults. If you have a Facebook, connect with me. There's a Balance and Fall Support Group. Facebook group. It's a private group, so connect there. And Future Foundation Global, there's a Facebook group as well about that. I'm your former vice chair, Global Health in Aging Adults, and certified neurospecialist and brain injury specialist. So I'm learning more with all this like you. So that's why I always want to have these kinds of summit. So we'll see you again next year. We have Geriatric Rehab Summit around summertime. If you want some CEU, please text me or message me on the topics you want to learn, and I will look for great speakers to discuss that. And then at the end of the year, we always look for some innovations, and those are for free. All right. So thank you so much. And I appreciate you guys. And if you have any concern, thank you and God bless. All right. Thank you guys for staying. I know it's midnight in Asia. And we have still very nice afternoon, Saturday afternoon in US base. But thank you and God bless. All right. Thanks, guys. Just stop the recording. Yay, we're done, right?